Good morning, everybody. Greetings from East Delhi Physician Association. On behalf of the organizing committee, it's my great pleasure to extend a warm welcome to each one of you who have gathered here for EDPA Con 2023, our esteemed conference on advance and innovations in medicine and allied specialties. This gathering is a testament of the collective pursuit of knowledge and excellence in the medical field. Throughout this conference, we are privileged to have distinguished speakers addressing various topics aligning to our theme. Their expertise promises us to enlighten and inspire us all. To commence this enriching journey, now let's call upon on stage our dynamic organizing chairman, Dr. P.N. Chaudhary, to say a few words first.
Thank you, Ankit. I think I won't waste much of time because we are just getting late. So I think welcome all of you, and because this is an program of East Delhi Association which is thriving on rich academic for so many years, and it is almost 24 years as of now. So next year we'll be celebrating 25th Silver Jubilee for EDPA Con. So welcome all of you, and definitely you will have a very excellent, rich academic feast in this day, and definitely we'll learn a lot of things. So with this, I welcome our chairpersons, Dr. Chaturvedi sir and Dr. Gupta. Dr. Chaturvedi sir, I wish to have some, because they are all PhD students, so just one mantra for them, just one mantra for them.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामय सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत्. May all be healthy, may all be happy, nobody suffer from any way, may people have well-being of everybody in mind. You can have well-being of everybody in mind if you remember the Gayatri mantras. Om bhurvastasudvaranyam bhargo devasdevai dhiyo yo no prachodayat. तूने हमें उत्पन्न किया, पालन कर रहा है, तू तो सही पाते प्राणम, दुखियों के कष्ट हरता, तू मांगते तेरी दया. ईश्वर हमारी बुद्धि को श्रेष्ठ मार्ग पर चला. विवेक, बुद्धि, that is an intellect and wisdom and the knowledge which you required from the postgrad medical students and medical professional is the true mantra for healthy living, healthy aging and patient-doctor relationship. And you know, today's program, the chairman scientific committee with academic flavor and forward and scientific bent of mind, he has prepared a very good program. And the first program today is only quiz. And what is quiz? Quiz is a competition or a game when somebody tests your knowledge by asking questions. And we have quiz masters, Jagat Guru Mukesh Bhatia. And Dr. Chaudhary, he is also Jagat Guru. He teaches us on scientific, every scientific meet of the month. He is a key person, and we are very lucky to have a person like him.
Thank you, sir.
It all yours, Dr.
Thank
Chaudhary.
You, thank you. So one line from Dr. Gupta, sir. I know that we are getting just one line for the students, sir.
अगर प्रभु से कुछ मांगना हो, भगवान कहीं मिल जाएं, तो क्या मांगे? एमडी में पास करवा दीजिए, डीएम में एडमिशन करवा दीजिए, ऑडी दिलवा दीजिए, बंगला बनवा दीजिए. भगवान से मांगना हो बल, बुद्धि, विद्या और कलह कलेश से मुक्ति और निरोगी काया. और इन्हीं सद्भावनाओं के साथ हम आपका स्वागत करते हैं और आशा करते हैं कि आप सब बिना किसी प्रेशर के अच्छे से अच्छा परफॉर्म कर पाएंगे. थैंक यू.
Thank you, sir, and for your kind words of wisdom. So I think now it's a time to start the quiz. Thank you.
The first session and the most enriching session or the most awaited session is the Dr. A.K. Jain Memorial Postgraduate Quiz. A few words about Dr. A.K. Jain. Dr. A.K. Jain, sir, was born in a small town in UP, Lalitpur, did his MD and DM Neurology from KGMC Lucknow. He shifted to Delhi in 1992 and founded the Jain Neuro Center in 1994, and which expanded to a 64-bedded Jain hospital in 2002. He He was a leader and an entrepreneur who had the heart of gold for all his patients, colleagues, and friends. He was the happiest person we knew with great passion for life. So now, without much ado, let's delve into the enriching sessions of EDPA Con 2023. To kick on our intellectual journey, I have the pleasure of inviting Dr. Shubha Lakshmi to take the lead. Dr. Shubha Lakshmi will guide us through the Dr. A.K. Jain Memorial Postgraduate Quiz, a tribute to excellence and celebration of knowledge. Let's the enriching and engaging sessions begin.
Thank you, Dr. Ankit, and very good morning to all of you present over here, and all the best to all the teams for EDPA Con Quiz 2023. I welcome all our chairpersons for this event, Dr. Pankaj Nand Chaudhary, Dr. Anil Chaturvedi, and Dr. S.K. Gupta, sir. So moving on to our quiz, we will be having 3 rounds, one by one. First round will be taken by me. Second round, Dr. M.K. Bhatia, sir, and third round will be about Dr. Shivani. So, okay. So, we will be having 3 quiz masters, and first round will be history-based round. So, as we all know, history is very important for our knowledge, and we should be knowing, and we should be well versed about it. So, let us go for this round. It will be direct question to each team, and each team will carry 10 marks. Sorry for this, it will be carrying 10 marks, and if there is 2 questions in same question, then it will be 5 mark each. And if half of the question is answered, half mark will be given. There is no pass and no negative marking. So first team A is from where? Team A, you have mic with you?
We are from Hindura Hospital.
Hindura Hospital, okay. So be seated. First question is for team A. What is in this photograph and what is he doing? You can see the photograph and time starts now. It is for 20 seconds. There is no negative marking.
Henry Gray.
And what he is doing? Okay, so let us see, is it correct or not? So he is Andrews Vespalis. He was the 16th century physician, and he was practicing medicine by providing accurate and detailed description of the anatomy of the human body. So what he was doing, he was checking for the muscles and vessels in this thing. Okay, so now next, so mark given to team A is 0. Team B is from Basai Darapur. So second question goes to them, and your question is, what is this and who has made it? Your time starts now.
This is the early microscope and Anton van Leeuwenhoek.
Okay, so time is up, I think. 2 seconds. Okay, so yes, sir, we can. Yeah.
So we have a Max Purple Gun team.
So this is a stethoscope. You are close, but it is not actually microscope what you told. It is a stethoscope, and this was used for hearing the sounds, and it was of 3 pieces, and it was made by René Lesson. So moving on to our third team. No, marks is 0. They have not given it correctly. So for team C is from RML. So team C, your question is, what is depicted in the picture and who is the person shown here? Bolo, bolo, bolo fast.
Lincoln.
Yes? Okay. So he is William Thomas and he is administering ether anesthesia. You can see it was the ancient procedure where ether anesthesia was done for giving any for doing any procedure. Moving on to our next team, 0 marks for this team also. So moving on to team D, that is from gyms. Who is the gentleman and for what he is known? Your time starts now.
Christian Bernard, cardiac transplantation.
So this is not a correct answer. You are very close, but it is lung transplant and this procedure, and the person is James D. Harry. So you are very close, but better luck next time. So next team is DE. Team E is from Maharaja Agrasen. This team D also scores 0. So question for team E is, what is depicted in the picture in the right and who invented it? Please no murmur among yourself, other teams, because it will help other team for scoring the marks. Three, two, one, done. So this is very interesting to know because it is electrocardiogram machine, and it was back to early 1990 where it was made by William Enthoven. So that triangle is also known as Enthoven triangle. So now moving on to the next team, it is from Max Vaishali. Sixth question, what is this picture is depicting and name the person who discovered it? Team F.
Venesection.
Yes?
Venesection.
Venesection. Okay. And who is the person? Okay. So it is not venesection actually. It is, this was discovered by William Harry, and it was the theory of circulation of blood which he was checking and showing in that picture. It was the wooden crafted picture which was shown here. Next team from LHMC. So till now no team has scored any marks. Let's move on to team for next question. Your question is, what is this and who has discovered it?
Penicillin.
Penicillin, okay. And who has discovered it?
Alexander Fleming.
Be more specific. What is that picture shown?
It is the fungus which inhibits
Very
the
nice,
growth of
very nice.
bacteria.
So it is Alexander Fleming who has discovered this penicillin by a petri dish of Staphylococcus bacteria which has grown in this, and he has seen that it has a defensive mechanism to kill the bacteria surrounding. So he named it as a penicillin. Very nice. So next team is from? He gets 10 marks, sir, because we have this thing for team G, right? Okay. So team H is from Max Patpasganj, and your question is, what is the picture depicting about and who is the person shown in the picture? Scurvy. What is actually shown in the picture and who is the person? Okay, so you are partially correct because this picture is depicting scurvy. How you have said it is scurvy? Lemon, yes. They are giving a citrus fruit to the patient. That was the patient, and it was the surgeon of Britain Royal Navy, James Lind, who has discovered it, and he used to cure the disease by giving citrus juices or fruits. So very nice. Half marks, that is 5 marks goes to team H. 5 marks to team H. So next question is for team I. Team I is from
Institute of
Saraswati. Okay. So team I, your question is, what is the name of this instrument and who has discovered it?
This is autoclave.
Okay. And who has discovered it? You have to give the complete answer because time will be up after that. Done? Okay. So it is not actually autoclave, but something closer to that. It was Joseph Lister's carbolic acid steam spray. It was used for this thing, applying in the patient's wound or dressing to cover it so that it doesn't catches infection. So it was done by, discovered by Joseph Lister. So no, you have not answered it correctly. So it is 0 mark for the team I. So team team J is from? There is any team J?
Yes, ma'am.
From
LLRM.
LLRM, okay. So team J, sorry. So this question is, what is the name of the equipment and who has invented it?
Is it pure tone audiometer?
Okay. Anything else you want to tell? Because time will be up. Time is up. Okay. So it is not audiometer. It is very simple instrument which we use every now and then. So it is glucometer. It was a blood glucose meter for assessing self-monitoring system of glucose, and Anton H. Sleeman, he developed this in 1970. So with this we come to end of this round, round 1, and may we have the score from the chairpersons?
I think anything team left? All teams are there? Okay, I think team G has scored 10 and team H scored 5.
Okay, so rest of the team, you have to still open your account. So for this, I would like to invite Dr. M.K. Bhatia sir. He will be taking our next round, and very well-known person. I think all the students might be knowing him. So over to Dr. M.K. Bhatia sir.
The first round signifies the importance of history of medicine. You must learn the history of all the questions have history of medicine. I still read the books of history of medicine, write articles on the history of medicine is equally important for all of us.
Well, okay, let me tell you the rules of correct answer will be of 10 marks, no negative marks, no pass as we have very less time. There will be question for the audience also, but these questions are only for the student, not for the learned senior consultant, only for students. Anybody. Prizes for everyone, participant and audience also. This is all courtesy the team of EDPA. In case of controversy, quiz master and judges' decision shall be final. In case of tie, question will be asked only to tie teams. Luck also play a role in quiz. It's not only a quiz, but there will be many extra learning points, and it will be a learning with entertainment. Right, sir. So round 2, 10 marks for each right answer, no negative, no pass, time 20 seconds. Team 1, it's all clinical base. What are the criteria to diagnose corticosteroid-resistant bronchial asthma? So team A. Team A, definitely. Timer हो गया चलिए okay well answer is it's defined, everything should be noted down. It is defined by failure to respond to high dose of oral prednisolone 40 mg OD for 2 weeks. What's the reason for this? Reduced nuclear translocation of steroid receptor GR alpha after binding steroids. वो बाइंड कर जाता है लेकिन the problem lies at the level of receptor. So I think it's a new thing for most of you. There is something called steroid resistant asthma also. Team B. In which layer of skin vitamin D synthesis occurs? No negative mark.
Dermis.
Eh?
Dermis.
Dermis. No, no, no. Well, basic concept histology. It is आंसर स्टेटम बेजेल है और ये डर्मिस से ऊपर है. This point to be noted. Point to be noted. Laser pointer. Laser pointer. Point to be noted. कि it is not a superficial layer. It's a part of epidermis और ये dermis के ऊपर है. Done. Simple सवाल. लेकिन what is more important? जहाँ पे most of students get stuck up. Let's talk about biochemistry of vitamin D. जो D2 होता है, this is ergocalciferol. This is the one which come from plants. D2 होता है. D3 is cholecalciferol जो कि मिल्क से आता है और form in the जो सनलाइट से बनता है जो कि स्टेटम बेजल में होता है. 90% of our vitamin D is made by the skin, sunlight से. And one more thing, most of you are not getting exposed to sunlight. आज से 10 साल बाद पूरी मेडिसिन बदल जाएगी. मेजॉरिटी ऑफ द डिजीज विल बी ड्यू टू विटामिन डी डेफिशिएंसी और सेकंड जो चीज़ आएगी आने वाला कल है ड्यू टू एसिडिक पीएच ऑफ द ब्लड. एल्कलाइन पीएच एंड विटामिन डी आर द फ्यूचर ट्रीटमेंट. और ये जो स्टोरेज फॉर्म है जो कि लिवर में होती है और दिस वन विच इज एक्टिव फॉर्म. एक्टिव फॉर्म इज 1-डाईहाइड्रो. जो हम लोग चेक कराते हैं लैब के अंदर वो विटामिन ये वाला चेक कराता है, विटामिन D3 चेक कराते हैं. गॉट इट. आगे अब प्रॉब्लम अब CRF के अंदर विटामिन डी लेवल कम क्यों होता है? प्रॉब्लम लाइक किडनी काम नहीं करी, 1-अल्फा हाइड्रोक्सिलेशन नहीं होता. दिस इज डन इन द किडनी. ओके, तो दिस वन यू शुड नो अबाउट द बेसिक बायोकेमिस्ट्री. टीम C. Which of the following drug may be needed when we are treating a case of pernicious anemia with vitamin B12 and folic acid? Beautiful question. Do you have color mic? Yeah. Vitamin C. No, this is not the right answer. The right answer is aspirin. Low dose aspirin. ये आंसर क्यों है? ये हद देखो बात. ये आंसर क्यों है? Why this answer is there? Learn the basic. When we treat a case of pernicious anemia with B12 and folic acid, पहला सवाल और question for the audience. Which electrolyte imbalance occurs? Quickly. Hypokalemia. क्या है? अब इसका रीजन क्या है? If you read हैरिसन का 18, 19, 20, 21 एडिशन पढ़ेंगे, वहाँ टेबल बनी है कॉज ऑफ हाइपोकेलीमिया. उसमें नाम दिया है विटामिन B12 और कुछ नहीं दिया. यू रीड 15, 16, 17 एडिशन, उस पर एक लाइन लिखी है that when we give B12 it lead to hypokalemia, no description given. But you read 12, 13, 14 edition, उसमें लिखा हुआ है when we treat a case of pernicious anemia with B12 folic acid, it lead to hypokalemia. The reason given is when we give B12, large number of cells are being formed. Potassium being an intracellular ion, it enters cell, it lead to hypokalemia. फिर आगे वो लिखता है कि but why this doesn't happen when we treat with another deficiency like iron deficiency anemia, reason not known. तो हाइपोकालेमिया होता है, रीजन नॉट नोन. सेकेंड चीज जो होती है इसमें प्लेटलेट काउंट गोज वेरी हाई. प्लेटलेट काउंट में गो एज हाई एज 7 to 8 lakhs. फॉर दैट यू मे नीड टू गिव लो डोज एस्पिरिन टू प्रिवेंट थ्रोम्बोसिस. इट्स अ ब्यूटीफुल क्वेश्चन. इनफैक्ट ये लास्ट ईयर के नीट एसएस का क्वेश्चन है, इसलिए ये सवाल लिया गया है. सो क्या सीखा आपने? दो चीजें सीखी, हाइपोकालेमिया एंड थ्रोम्बोसाइटोसिस. टीम D. Most specific eye signs seen in grave disease. कौन से वाला है?
Lid lag.
है?
Answers option C, lid lag.
Lid lag. C. No. No. Answer. Anybody in the audience? Only students, not consultants. हाँ जी, चलो. Student के लिए question है. How many you go for A? Raise the hand. Student only. B, C, D, E. जिसको इसका आंसर नहीं आता उसको थायराइड नहीं आता है. आंसर इज डिप्लोपिया. ये क्यों है? लेट्स लर्न द बेसिक कंसेप्ट. बेसिक आने चाहिए, देखेंगे. करेक्ट आंसर का डिप्लोपिया है. लेट्स टॉक अबाउट थायरोटॉक्सिकोसिस, हाइपरथायराइड ग्रेव डिजीज. ठीक है? ठीक है नहीं है? नो, ये गलत है. दे आर नॉट सेम. लेट्स लर्न द बेसिक. थायरोटॉक्सिस का मतलब है इंक्रीज थायराइड हार्मोन इन द बॉडी इज थायरोटॉक्सिकोसिस. This can be source, can be thyroid. This is hyperthyroid. It could be extra thyroid, euthyroid. और hyperthyroid के अंदर भी grave disease, toxic endoma and multinodular goiter. अब again one more thing, जो thyroid hormone के action होते हैं, they are never direct. They simply increase the sensitivity of beta receptor to epinephrine. That's why you get tachycardia, atrial fibrillation, all because of high amount of थायराइड बीटा एड्रेनलिन एक्शन. तो याद रखेंगे. अब ये जो थायराइड हार्मोन इंक्रीजेस सेंसिटिविटी ऑफ बीटा रिसेप्टर टू एपिनेफ्रिन. दैट्स व्हाई थायरोटॉक्सिकोसिस हैज मेनी फीचर्स सेम एज ऑफ फियोक्रोमोसाइटोमा. ओके. अब यहाँ पर आई के अंदर एक होती है मसल, अपना लिवेटर पैल्पेबल सुपेरियस मुलर मसल होती है. दिस वन मसल व्हिच इज सप्लाई हैज अ सिंपैथेटिक सप्लाई. तो इंक्रीज थायराइड हार्मोन इज देयर इन ऑल. जो आई साइन जिसकी लीड लैग लीड ट्रैक्शन आर सीन इन ऑल थायरोटॉक्सिकोसिस. ये सभी थायरोटॉक्सिकोसिस में मिलेगा. लीड लैग लीड ट्रैक्शन ये सब मिलेंगे. लेकिन आई साइन विच आर सीन इन ग्रेव डिजीज आर कीमोसिस, प्रोप्टोसिस, डिप्लोपिया, पेप्टिडीमा, ये सिर्फ ग्रेव डिजीज में होते हैं. तो या अब टाइम कम है, आई कांट स्पेंड मोर टाइम, लेकिन आपको ये बता दिया ये तीनों चीज़ें अलग अलग हैं, अलग अलग हैं. ओके. प्रोप्टोसिस, कीमोसिस, रेड आई, ये सारे ग्रेव डिजीज से मिलते हैं. टीम 5. मोस्ट इंपॉर्टेंट डिफरेंशियल डायग्नोसिस ऑफ कोनस मेडुलरिस सिंड्रोम इज. रेज द हैंड, रेज द हैंड.
Cauda equina.
Cauda equina is the most common wrong answer. Again, this you should know. Answer benign prostatic hypertrophy. अगर आपने सर्जरी की किताब एस दास पढ़ी हो, बीएचपी का, जहाँ पे जाके पढ़ना, उसके लास्ट लाइन में लिखा है कि किसी भी केस के बीएचपी के केस के अंदर यू शुड चेक फॉर पेरिएनल सेंसेशन, चेक फॉर एंकल जर्क. क्योंकि बीएचपी का मोस्ट इंपॉर्टेंट डीडी इज कोनस मेडुलरिस सिंड्रोम. ओके. क्योंकि इसकी सप्लाई S1, S2, S3, S4, S5 इन्वॉल्व होता है कोनस के अंदर भी. और भी ओके. तो इसका भी प्रेजेंटेशन होता है रिटेंशन विद ओवरफ्लो, एग्जैक्टली सेम एज ऑफ बीएचपी. तो कैसे डिफरेंशिएट करेंगे? बाय लुकिंग एट दी पेरिएनल सेंसेशन एंड एट द मोस्ट यू कैन चेक फॉर द एंकल जर्क. क्योंकि कोनस मेडुलरिस में पेरिएनल सेंसेशन नहीं होगा और एंकल जर्क एब्सेंट होगा, जबकि बीएचपी में ये चीज़ होंगी. पर प्रेजेंटेशन सेम है, डिस्टेंशन विद ओवरफ्लो, एंड दिस इज ऑल्सो नोन एज लोअर मोटर न्यूरॉन ब्लैडर. टीम 6. 5 marks each. Name any congenital kidney disease where hyperkalemia occurs due to chloride shunt, or name any drug which also causes hyperkalemia by chloride shunt.
Spironolactone.
है?
Spironolactone. Second.
No. और ये? Well, the right answer is Gordon syndrome. Gordon syndrome में there is extra amount of chloride which enter the cell. With the normally क्या होता है? Normally aldosterone से सोडियम आएगा और पोटेशियम और H बाहर जाएगा, normal. पर यहाँ पे extra amount of chloride enter the cell. To balance this negative particle, body has to retain H ion and sodium, potassium. That lead to hyperkalemia and metabolic acidosis. Little gentleman or वाटर में there is hypokalemia. इसके अंदर hyperkalemia होता है, chloride shunt, and the drug which lead to this problem is also cyclosporin, the drug which lead to hyperkalemia due to chloride shunt. Cyclosporin, the drug. Team 7. Why repetition is lost in arcuate fascicle lesion? Why? Quickly. Why? So let's learn the spontaneous speech normal होती है. ये क्या है? Let's go to basic physiology and anatomy of speech. Oh, slide missing है. चलिए. Well, we all know जब आप किसी से बात करते हैं, first it goes to your auditory center. कहाँ पे होता है? Temporal lobe में. Then it goes to Wernicke area, which is area superior temporal gyrus में, जहाँ पे speech की understanding होती है. Message go to Broca's area, which lies in the inferior frontal gyrus, is via arcuate fascicle. अगर Wernicke area में defect होगा, speech understanding नहीं होगी, and there will be irrelevant talk. Broca's के होगा तो speech outflow नहीं होगा. Now the $1 million question कि arcuate fascicle में repetition क्यों नहीं होता है? इसका आंसर ये है, arcuate fascicle में he can understand, Wernicke ठीक है, और Broca ठीक है, he can speak. अब मान लो, लेकिन spontaneous speech normal है, उसको भूख लगी है, कहेगा जी मुझे भूख लगी है, तो आपने कहा repeat करो. Now your words go to Wernicke, but Wernicke cannot convey message to Broca's, तो he cannot repeat it. लेकिन याद रहे, जो खुद बोलेगा spontaneous speech is normal, but he cannot give message to Broca's area, that's why repetition is lost. ये भी need assess का question है ये वाला. Well, next team. In which cardiac condition protein losing enteropathy occur? Which cardiac condition is important? DD of cirrhosis of liver. Yeah. Let's again. No. Done? Answer is constrictive pericarditis. Classically, इसमें hepatosplenomegaly, ascites और edema होता है. Ascites is out of proportion to edema in CP. That's why we have a special term called so-called ascites precox. बल्कि normally heart failure में edema पहले आता है, ascites बाद में आता है. This is one exception where ascites come first और edema बाद में आता है. It's all because of effect of CP on the hepatic vein की etiology दी आती है. और what are the clinical feature of CP? CP के the important feature are there is small sign positive. क्या होता है? Normally JVP falls on inspiration, but there are few exceptions where JVP rises. उनमें एक नाम CP है, RV infarct है, and restrictive cardiomyopathy है. Second thing what happens in CP is protein losing enteropathy. और तीसरा होता है nephrotic syndrome भी होता है. That's why patient has massive splenomegaly भी होती है, ascites भी होती है. I quote a line from Harrison. इसकी इतनी close resemblance होती है cirrhosis के साथ कि without you doing the proper investigation, you cannot differentiate between cirrhosis and the constrictive pericarditis. एक और सवाल, question only for audience. जितने भी cause हैं acute pericarditis के, everyone can lead to CP. Only one exception. वो exception कौन सा है? All CPs can lead to CP. All acute pericarditis can lead to CP except one. आंसर है rheumatic pericarditis. Rheumatic pericarditis में इसका CP नहीं होता है. Okay. Team 9. Vertical gaze is affected in which syndrome, and with which syndrome lateral gaze is involved. जो ब्रेन के stroke syndrome होते हैं बड़े सारे. Quickly.
The sinus thrombosis.
है?
Cavernous sinus thrombosis.
No. Perinaud syndrome, site of lesion is midbrain, और जो दूसरा lateral gaze center होता है pons के अंदर, and that is involved in locked-in syndrome. Locked-in syndrome के बारे में usually basilar artery involved होती है. Patient has quadriplegia, cannot move. खाली only movement that is possible in that is up and down movement, not even lateral movement, क्योंकि lat के जो up and down का जो center होता है that is in midbrain, और lateral gaze का center होता है pons के अंदर, तो lateral gaze भी का involve होती है. So Paranoid syndrome is a midbrain lesion. Well, little bit more about Paranoid syndrome. Paralysis of upward gaze, downward gaze is usually preserved, eyelid retraction, cochlear sign, pupillary hyporeflexia. Locked-in syndrome, ventral pontine infarct, complete quadriplegia, preserve conscious. ये बात patient fully conscious होता है. Lateral gaze movement not there, and preserve upward eye movement. This is the only thing what patient can do. Cannot move any limb, cannot move any eye also except this one. Last thing, in Cushing disease there is an increase in midnight salivary cortisol. Why does this occur, and what is the most accurate test to diagnose the case of Cushing disease?
The answer for second is high dose dexamethasone suppression test, and
First का? Well, done. The जो आपने बोला high dose, that is the test done to differentiate between pituitary adenoma and extra ectopic secretion of ACTH. पहला सवाल यह कि why this increased midnight cortisol level? We all know circadian rhythm is there in इसका steroid secretion. Maximum level 8 AM पे होता है और minimum होता है midnight पे. क्या इसके clinical applied है? जब भी steroid level check करना है, you always advise to get checked between 8 to 9 AM. Steroid level maximum होता है. Earliest feature of Cushing syndrome or Cushing disease is loss of circadian rhythm. तो रात के टाइम भी का salivary cortisol का level बढ़ जाएगा. क्योंकि saliva collect करना बड़ा easy है, rather taking blood sample, तो that's the first thing that should be done in the case of Cushing disease. Now the most accurate test, now little bit आपको बता दूं कि हम इसको pituitary को investigate कैसे करते हैं. पहले screening test करते हैं जिसमें 24-hour cortisol level, urine cortisol या midnight cortisol level या ATM का serum cortisol. This is to differentiate between normal person and Cushing or pseudo Cushing. उसके बाद हम करते हैं low dose DEXA to differentiate between pseudo and true Cushing. फिर चेक करते हैं ACTH to rule out adrenal adenoma. Then we do high dose DEXA to differentiate between Cushing and ectopic. And finally, the most accurate test to diagnose is inferior petrosal sinus. We take sample of ACTH and we check from the peripheral. Ratio should be more than 2:1 is the most accurate test. एक गुरु मंत्र याद रखो, एक गुरु मंत्र. Endocrine में कोई भी disease we never diagnose based on imaging. It's always diagnosed by biochemistry. Most of people say MRI. MRI देखा और आपने ट्यूमर निकाल के बाहर फेंक दिया. Tumor can be non-functioning, it can be anything. आपने उस इंसान को जीते जी मार दिया. तो एक गुरु मंत्र everybody, all students should carry. Endocrine may be always make diagnosis by biochemistry, not by imaging. Helps, but doesn't diagnose. Okay. Question for audience also. Commonest cause of pleural effusion in India and the world, respectively, are. Question only for student, not for the senior consultant. कितने लोग A वाले हैं? Raise the hand. कितने लोग B वाले हैं? कितने लोग C वाले हैं? कितने लोग D वाले हैं? सवाल मुश्किल तो नहीं है ना? सवाल मुश्किल तो नहीं है? है मुश्किल सवाल? Not at all. दिल थाम ले, दिल थाम ले. आंसर A है. A? India, viral. सब क्या कह रहे हो? क्या पढ़ा रहे हो आप? Yes. Not known to 99% students. Why is the answer? Why हम इसके जाते हैं? Yes. Viral fever में pleural effusion होता है. Is minimal and self-limiting. हम सबको साल में एक बार viral fever होता है. अपने आप दवाई खाई ठीक हो जाते हैं. हम जब 10% को भी effusion रहा हो तो पिछले 10 साल में हमारे पास कम से कम 100 केस यहाँ पड़े effusion के. टीबी किसी किसी को होती है और किसी किसी को effusion होता है. तो दोस्तों commonest cause of pleural effusion in the whole world is viral fever. It's a good carry home message for all of you. With this, we talk about एक round score बता देंगे.
Right, I think
अभी time बहुत है तो we can cover.
So
पहले I don't mind. मेरे पास एक और round भी है. पहले ये करेंगी. Time बचेगा तो एक round और कर दूँगा.
Dr. Bhatia has asked very interesting questions, So interesting that anybody didn't score any mark.
चलो marks are irrelevant. आपने सीखा, that's other purpose. ठीक है? आइए.
I think there are quite learning points and actually.
Learning points are more important than the actual marks.
Right.
हाँ दे दीजिए.
So this is the round 3 for the quiz, and this is basically image-based questions will be there. So we will have 10 marks for the right answer. There will be no negative marking and no pass as we had been following. So the first question is for the team A. This is your question. Identify this device. Next one. Yeah. मेरा ओपन है वहीं से ओपन है. It's not working from there. Yeah. This is the question for team A. Identify this device. This is the leadless pacemaker which has been launched by the company Abbott, and the advantage of this is it is a completely leadless one and has got a very good life. यहाँ पे अभी भी it's not working. This is the question for team B. These are the echo images, and from these echo images tell what will be the ECG change seen in relation to this diagnosis. These are the echo images. You have to tell the ECG changes which will happen with this condition. There are two separate images I have placed for your convenience. Yeah. But the condition is same obviously in both the echo findings.
Left ventricular hypertrophy, LVH changes will be there in the ECG.
I'm sorry, but it is basically LV aneurysm. As you can see from the arrow also, I've deliberately put that image for making it easy. The left ventricle is just bulging out. If you see it in the image 2, the left ventricle is bulging out, and the ECG change associated with that will be, if it's LV aneurysm. So what will be the ECG change associated with it?
That ST elevation will be
Yeah,
there.
there will be persistent ST elevation post-MI for more than 2 weeks. So sorry, you don't get any marks for that. Yeah. This is the question for team C. Name this sign. The sign which is seen in this X-ray chest. Name this sign. Yeah, you can try. Why don't you try?
Sarcoidosis, Garland sign.
It's a sign, not a. I'm not asking about diagnosis because it's difficult. But sign is
It's a loud sign.
It's a loud sign, right? It's a correct answer. The sign is called as the Silhouette sign, where if there's any intrathoracic lesion, it may abort the margin of heart or aorta or diaphragm. So that's a Silhouette sign. So, good one. Next, please. Question for team D. Identify this condition. This is a peripheral smear. Try to identify this condition.
formation in
Yeah, again a correct answer. This is the Role formation, which is basically the stacking of RBCs which happen in a like the coin stock stacks. Similarly, the RBCs form a stack, and it has to be differentiated from which other condition? The commonest differential diagnosis of this one will be. हाँ, it's marks मिल गए, marks मिल गए. Yeah, agglutination. It has to be differentiated from the agglutination where also the RBCs clump, but वहाँ ऐसे stack नहीं बनाएंगे, यहाँ stack बनाएंगे, and if we put the normal saline, this will not declutter, but that will declutter. So good effort by team D. Then next question is for team E. Name this the facies which is associated with this condition.
Box is here, ma'am.
The facies associated with this condition. Time is up. So this is the leonine facies which is associated with lepromatous leprosy. These are basically the lesions of lepromatous leprosy, and the facies which is associated with this is the leonine facies. Next question, please. Yeah. This is for team F. Name the sign of the findings which we can see in this ECG. You have to name the sign of the changes which we see in this ECG. Team F. Changes are obvious, yes?
P wave absent.
Oh, I'm afraid your time is up, I guess. This is the D winter sign, which is what changes we can see. There's ST depression, but that is a upsloping type. That is a atypical finding for this ECG. That ST depression is there, but it is upsloping type of ST depression, and T waves are quite peaked. You can see especially the ascending limb of T wave is very much peaked. Second thing, and the third thing is there's elevation in AVR. So three findings: ST depression, which is upsloping type. There is T waves which are peaked, especially the ascending part of the T waves, and AVR elevation, that is called as D winter sign, and that is specific for, that is equal to ST elevation MI only. If we proceed further, there will be complete occlusion only, but it is there with ST depression. Question for team G. Name this procedure. Give me the complete name of this procedure.
Sleeve gastrectomy?
That's partially correct, but it's not only sleeve gastrectomy. You can see something else also. No. No, it's not. There are two steps, but the name of this procedure is very specific. It's biliopancreatic diversion with duodenal switch. Right, biliopancreatic diversion with duodenal switch. What is happening? Gastric sleeving is being done, but you can see the changes in the small intestine. Small intestine has been divided into two parts. The one part is carrying the food, and the food from the stomach has mostly bypassed the small intestine, and it's landing directly into the large intestine. And the second part of the small intestine, what it's doing, it's taking the digestive enzymes and again releasing into large intestine. So it is termed as the biliopancreatic diversion with duodenal switch. The next question, 8th question for team H. Identify the disease with this JVP waveform. This is a JVP reading, the JVP recording. Identify the disease which is associated with this finding. Tricuspid regurgitation. What do you see in the JVP? And yeah, so the answer actually, we can see the X and Y descents are very rapid. They are deep X and Y descents which are very obvious from the JVP. So X and Y deep descent, that is associated with constructive pericarditis. It is the W sign of constructive pericarditis. The next question. Yeah. Team I. This is a celebrity, a very, very famous celebrity. Tell me the disease chronic disease with which he is suffering from. आप लोगों की generation का है, हाँ? Who is he and from which disease is he suffering?
HIV.
I'm afraid that's the right answer. He's Dan Reynolds, a famous singer of the Imagine Dragon band, and he's suffering from ankylosing spondylitis. That was quite on a lighter moment. At least everyone is laughing. The next question, the last one. This is for the team J. This is an X-ray image of a 37-year-old female who presented with pain and swelling in the right wrist. Identify the condition. राइट रिस्ट में प्रॉब्लम है तो राइट वाले पे ही फोकस करो, लेफ्ट तो सही है, नॉर्मल है. ट्राई टू आइडेंटिफाई.
अरे बोल स्केपॉइड फ्रैक्चर, बट वो बैठेगा नहीं. स्केपॉइड फ्रैक्चर, rheumatoid arthritis.
I think no. The duration is also less, na, for few weeks only. For few weeks it has been happening there. So yeah. This is the X-ray of septic arthritis, where we can see the joint effusion and the spaces are narrowed, and there will be juxta-articular osteoporosis is also visible. So this is the X-ray of septic arthritis. So that's that brings us to the completion of the round 3. So after, I think team C, team D, they have scored for this in this round. Now we have one more round which will be taken by Bhatia sir.
मेरा next round लगा देंगे.
I think we have only 3 minutes left.
I'll finish in 5 minutes. अच्छे questions हैं.
Right. So I think it would be a rapid fire question probably.
Rapid जल्दी कर लेंगे, but go through question. लगाएंगे, round 2 लगाएंगे. I'll finish in 5 minutes. Don't worry. It is round time कम है, तो we'll quickly go through. लगाओ.
Hello, 10 team C and 10 team D. They have 10 marks each.
Round 2. अच्छा छोड़.
10 marks each.
10 marks each. And from round 1, 10 team G and 5 team H. So these are the score till now, and rest still have to open their account. So
Well, एक और राउंड, लेकिन यह थोड़ा जल्दी करेंगे, टाइम कम है. हाँ जी. Which organ is involved in malignant rheumatoid arthritis? Team A. Quickly. Well, the answer is skin. Skin due to vasculitis. I are the most common wrong answer. And याद रहे, this is the most characteristic deformity in rheumatoid arthritis, so-called ulnar deviation of fingers. Team 2. Which antiarrhythmic drug is also known as proarrhythmic drug? Why amidron is not a proarrhythmic drug? ये नहीं, team B है.
Lignocaine.
No, 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 no. Well, prolong any drug, any condition which lead to prolonged QT interval is a proarrhythmic. Class 1A drug आती है, including torsades pointes. Amidron, although it causes prolonged QT interval, लेकिन इसके अंदर बाकी class 2-3 effect भी होते हैं. That's why it is not a drug which lead to proarrhythmia. This is the basic. ये का phase 0 जहाँ पे सोडियम की एंट्री होती है, एंड क्लास 1A ड्रग दे इनिबिट सोडियम एंट्री. ये जब ये राइट शिफ्ट हो गया, ये क्लास 1A ड्रग है. क्लास 1A ड्रग दे आर ऑल्सो कॉजिंग prolonged QT. ये 1B वाला ये 0 का फेज 0 लेकिन शॉर्ट QT, और 1C वाला prolong ये शिफ्ट करेगा लेकिन QT इंटरवल इज नॉर्मल. तो एट ए ग्लांस दिस इज द amiodarone which is causing prolonged QT interval but no proarrhythmic drug. Team C, commonest cause of metabolic acidosis with hypokalemia.
RTA. Renal
RTA, commonest cause? No. No, no, no. Answer is gastroenteritis. Severe diarrhea. कहा आपने RTA बोला ना? RTA बोला, तभी मैंने आगे शिफ्ट ना RTA बोला, that's why. Well, याद रहे मेटाबॉलिक एसिडोसिस और हाइपरकैलेमिया मेटाबॉलिक एसिडोसिस और हाइपरकैलेमिया हमेशा इकट्ठे होते हैं. 3 एक्सेप्शन है, डायरिया, RTA टाइप 1 एंड टाइप 2, एंड द कॉमन कॉज इज ऑफ कोर्स डायरिया. टीम 4, रूमेटिक फीवर. टीम 4, out of 5 major criteria, which is the most rare and most common feature? Both need to be answered. What are the 2 late features? Quickly.
First answer, most rare is Sydenham's chorea, and the commonest is polyarthritis.
Okay.
Late feature, the latest is Sydenham's chorea and carditis.
No. दोनों गलत हैं. Eczema margitum the most rare, arthritis most common. Rare में chorea and subcutaneous nodules हैं. This should be known to all the resident doctors. Team 5. No, उसने वो आधा लिखा हुआ है, पहले लिखा हुआ है, दोनों नीड टू बी आंसर करेक्टली. लिखा है बिल्कुल, बोथ नीड टू बी आंसर करेक्टली. इसीलिए मेरा रोज का काम है यार, वही पता है गलतियाँ होती हैं. पहले क्लैरिफाई कर दिया, लड़ाई नहीं होनी चाहिए. हाँ, टीम ई. व्हाट इज ग्रेड 4 टेंडरनेस? नेम एनी कॉज ऑफ ग्रेड 4 टेंडरनेस क्विकली. हाउ डू यू डू द ग्रेडिंग ऑफ टेंडरनेस? हैंड माइक.
The second.
पहला ये बताएंगे ग्रेड 4 टेंडरनेस क्या होती है? क्विकली. क्या बोला?
Second answer can be peritonitis.
है?
Second answer peritonitis.
No. दोस्तों पहले देखें, हाउ डू वी डू द ग्रेडिंग ऑफ टेंडरनेस. ये आपको आना चाहिए, प्रैक्टिकल क्वेश्चन है. आपने पेशेंट को हाथ लगाया, दर्द है, हाँ दर्द है, ये ग्रेड 1 टेंडरनेस. आपने पेशेंट को हाथ लगाया, पेशेंट चिल्लाता आ इज ग्रेड 2 टेंडरनेस. आपने हाथ लगाया, ही विड्रॉस, ग्रेड 3 टेंडरनेस. ग्रेड 4 डोंट टच, ये ग्रेड 4 टेंडरनेस है. और कॉज ऑफ ग्रेड 4 टेंडरनेस आर गाउट, आर्थराइटिस, रूमेटिक फीवर एंड सेप्टिक आर्थराइटिस. न्यूमोनिक गैस है, ऐसे याद रखेंगे. वेल, लिटिल बिट एक्स्ट्रा, गाउट के अंदर वी गेट पोडेगरा, इज अ ग्रेड 4 टेंडरनेस. एल्कोहल इज द मोस्ट इंपॉर्टेंट प्रेसिपिटेटिंग फैक्टर. अब अल्कोहल की बात हो और कोई शेर व शायरी ना हो और भाटिया साहब क्लास ले रहे होती है तो शराब की तौहीन है. इस बात पे एक शेर अर्ज है. इरशाद बोलो. आओ तुम्हें बताएं शराब कैसे पिलाई जाती है. आओ तुम्हें बताएं शराब कैसे पिलाई जाती है. खोलने से पहले बोतल हिलाई जाती है. ओए क्या बात है. फिर आवाज लगाई जाती है. आ जाओ ए टूटे दिल वालो, आ जाओ ए टूटे दिल वालो, यहाँ दर्द दिल की दवा पिलाई जाती है. वाह क्या बात. स्टडी शुड बी फन. या विच टाइप ऑफ एल्कोहल इज द मोस्ट इंपॉर्टेंट प्रेसिपिटेटिंग फैक्टर? क्वेश्चन फॉर ऑडियंस. क्या आंसर? जल्दी से बताएंगे. आंसर बियर है. ओके, टाइम कम है. चलिए टीम 6. We give which vitamin in the synthesis for sideroblastic anemia? Why we glucose in the treatment of porphyria?
Sir, B6.
B6, right answer.
Sir,
लेकिन ओके, व्हाई वी गिव ग्लूकोज इन द ट्रीटमेंट ऑफ पोरफायरिया?
Sir, it basically inhibits the hemin.
No. ये बेसिक है. Quickly, I'll take only ये this is a gray area for all of you. It inhibit vitamin, हाँ 5 marks. LA दोस्तों, little bit basic concept. हीम बनता है प्रोटोफायर और फेरस से, ये माइटोकॉन्ड्रिया ऑफ आरबीसी में होता है. अब ये जो रिएक्शन है, ये पोरफायरिया में भी यही आता है और सिडोब्लास्टिक एनीमिया में यही आता है. सिडोब्लास्टिक एनीमिया में इसकी डेफिशिएंसी होती है. वी वांट ये खूब बने, दैट्स व्हाई वी गिव B6. और यही का ये रिएक्शन पोरफायरिया में होता है. पोरफायरिया में यहाँ पे एंजाइम की डेफिशिएंसी होती है तो पीछे वाले सारे इकट्ठे हो जाते हैं. ALA इज ए टिश्यू टॉक्सिन. तो यहाँ पे पोरफायरिया में हम चाहते हैं कि ये ना बने. हम चाहते हैं ये ना बने, जबकि सिडोब्लास्टिक हम चाहते हैं ये बने. देन व्हेन वी गिव इमेटिन और का ग्लूकोज, इट इनहिबिट दिस एंजाइम. ये जो दिस एंजाइम इज इनहिबिटेड बाय ग्लूकोज एंड हिमेटिन. तो याद रहे, सिडोब्लास्टिक एनीमिया इज द वन कंडीशन अगेन जहाँ पे आयरन ओवरलोड स्टेज होती है, और एनीमिया विद आयरन ओवरलोड स्टेज इज सिडोब्लास्टिक एनीमिया. So anemia, hemochromatosis. Team 7. True about renin and aldosterone level in SIADH. Quickly. D is the right answer. दोनों कम होते हैं. Right answer. SID में दोनों. Team 8. Time कम है तो I have to rush. Team 8. Interpret the following data. जिसको इसका आंसर आता है उसको एसिड बेस डिस्टर्बेंस आता है. Every one of you, all resident doctors should try to answer this question. जो भी है टीम जो है टीम H के लिए है ये वाला. Quickly. है? A is the most common wrong answer. हाँ, आंसर नन अबाउ. देखेंगे इसमें जो एनाइन जो आ पा रहा है, एनाइन गैप ये आ रहा है 20. तो सारी रिपोर्ट नॉर्मल है, एनाइन गैप ज़्यादा है. तो दिस इज सीन इन मेटाबॉलिक एस्ट्रोसिस एंड मेटाबॉलिक एल्कलोसिस. एक ही पेशेंट में जब मेटाबॉलिक एस्ट्रोसिस और एल्कलोसिस वो होता है. अब एक और सवाल, ऐसी कौन सी कंडीशन है जहाँ पे ये दोनों चीज़ें इकट्ठी मिलती हैं? टाइम कम है तो आई टेल द आंसर. आंसर डायरिया एंड वॉमिटिंग. CRA वॉमिटिंग, इनमें एसिडोसिस होता है और इनमें एल्कलोसिस होता है. एंड द टीम 9 जो बायोकेमिकल रिलैप्स अकर इन विच टाइप ऑफ हेपेटाइटिस और एपिसोडिक राइज ऑफ एंजाइम किस में होता है?
फर्स्ट का हेपेटाइटिस सी.
हेपेटाइटिस
सी.
ओके. दूसरे का?
एंड सेकंड का हेपेटाइटिस बी.
नो, दोनों गलत है. आंसर ए है इसका और दूसरे का सी है. सी के बारे में खास ध्यान रखेंगे. पेशेंट मे नॉट हैव जॉन्डिस और माइल्ड जॉन्डिस. तो ओनली क्राइटेरिया इज एपिसोडिक राइज ऑफ एंजाइम्स और कॉमनेस्ट कॉज ऑफ क्रॉनिक हेपेटाइटिस इज सी. द लास्ट टीम, लास्ट क्वेश्चन. पैराडॉक्सिकल ब्रेडिकार्डिया इज सीन इन विच कंडीशन एंड स्टोन हार्ट इज सीन इन विच कंडीशन?
वो एंट्रिक फीवर, पैराडॉक्सिकल ब्रेडिकार्डिया सीन.
सेकंड. वेल, आंसर है pulmonary embolism. Tachycardia is the commonest finding in pulmonary embolism, but in some cases there can be bradycardia. We call it pulmonary paradoxical bradycardia. Or stone heart is seen in dioxin toxicity. I wish I had time to explain to you. अब नहीं है. Question for audience. Last. Commonest, which is not a part of classical triad of diabetic symptoms. Who says A? Resident doctor only. A, B, C, D. ऐसे नहीं, हाथ खड़े करो. A, B, C, D. The right answer is D. Polyphagia. अब आप कहेंगे सर हमें पढ़ाया गया था स्कूल में, कॉलेज में जी पोलीफेजिया गलत है. वो गेनोंग में लिखा है गलत है, रॉबिन्स में गलत लिखा है. हैरिसन पढ़ेंगे. हैरिसन लिखा है क्लासिकल टायर्ड इज पोलीयूरिया प्रोड्यूसर अनयूजुअल वेट लॉस. आप सबने मूवी देखी होगी मुन्ना भाई एमबीबीएस, देखी थी? स्टेज में उठाते हैं, पूछते हैं मुन्ना भाई व्हाट इज डायबिटीज, तो मुन्ना भाई क्या कहता है? इट्स अ स्टेट ऑफ क्रॉनिक हाइपरग्लाइसीमिया characterized by polyuria, polydipsia and unusual weight loss. मुन्ना भाई को भी पता है the classical tired is polyuria, polydipsia and unusual weight
So I
loss.
think we are close to the end of
अच्छा
this
एक
quiz.
एक मिनट वापस लाओ.
It's time
फिनिश.
is over, sir.
अरे
Time is
यार
over.
एक लाओ, एक चीज देनी है सबको, बच्चों को. फिनिश
Time
फिनिश.
is over. Time is over.
And there is a tie, so we may have to ask
One tie question.
One more
Tie
question. कोई दिक्कत? One more
So
question.
the tie between Team C and Team D. Team C.
कौन सी टीम है?
Team C. Just
टीम
raise your
सी
hand.
हाथ खड़े करेंगे. और
And Team D.
टीम डी कौन सी है? चलो आपके लिए
There's
है.
a tie question.
चलो.
final question.
ओके, फाइनल क्वेश्चन. ये बताइए कि इन बार्टर सिंड्रोम रिजेंबल फीचर लाइक विच ड्रग?
Furosemide.
Furosemide is the right answer. Give it. Thank you very much. Okay. मेरे वाला दिखा दो ना, मेरे वाला.
So I think so tie questions are always
हो
there.
गया,
So,
टाइप भी हो गया.
so we have teams.
मेरे वाला दिखा दो
winners.
एक मिनट जरा.
हो गया
सब
Okay,
कर
sir.
दिया.
हो गया. हो गया sir. So winner of the team would be announced in the group. I'll definitely put the marks. So because we are just short of time, so I think we conclude session and thank you all the quiz masters for the wonderful session. Protest. Yes. Today we have Dr. Rahul Jain is with us. Dr. Rahul Jain is son of late Dr. B.K. Jain. So I want Dr. Rajiv Bansal, which is Chairman Scientific Committee, to felicitate Dr. Rahul Jain. Dr. Rahul Jain, please come on the stage, please. Dr. Rahul Jain, is he here? Dr. Bansal, please. Can we have bouquet, please?
Thank you all the quiz teams for participation and wonderful this thing. Few teams always win and few are like this, so nothing like that. But yes, you all played very well.
Sir.
We assume questions were slight tricky as well as tough also, but yes, it was nice. Thank you all.
Thank you. Ladies and gentlemen, what an exhilarating experience it has witnessed the brilliant minds in action during the A.K. Jain Memorial Postgraduate Quiz. Heartfelt congratulations to all the participants for outstanding performances and commendable efforts. I may request the chairpersons and the judges to proceed to the felicitation desk. Request Dr. Rajiv Gupta sir to do the honors, please. Let's begin the next session. The next session is on recent advances in asthma and COPD. In the ever-evolving landscape of respiratory medicine, today's exploration of COPD and asthma advances serve as a beacon lightning of our path towards enhanced patient care. May I begin the session on COPD? May I request the chairpersons to come on stage? I may request Dr. Lalit, Dr. Arjun Khanna, Dr. Atul Bhasin, Dr. Bharat Gopal, Dr. Sharad Joshi. The speaker for this session is Dr. Rohit Kumar. I may request the chairpersons to invite the speaker, please.
Well, good morning for the first scientific session after the PG session. So today's first session is on recent advances, what we see in patient of management of COPD and asthma. So as you all know, the pollution rising day by day. Every year we see lots of pollution causing respiratory problem, and the challenges for management of respiratory problem is rising every day. So today we have with us senior speaker, Dr. Rohit Sharma, who will be talking about recent advances in the management of asthma and COPD. I request Dr. Rohit Sharma to come to stage He is MD medicine, DNB medicine, and he has done DM pulmonary and critical care in sleep medicine. And he's also MSc endocrinology and DM. He is at present associate professor and head Department of Pulmonary Medicine, Critical Care Medicine and Sleep Disorder in the Vardhaman Mahavir Medical College and Surgery Hospital. Well, I request Dr. Rohit to give his talk, and the talk timing will be 20 minutes. Thank you very much.
So good morning, everyone. I have been given a very difficult task. Normally, when we talk about asthma and COPD, in my department, we have one-day seminars on airway summits, and we discuss this topic for almost hours, and even then I get the feedback that it was not discussed very well. So I have to do this in the next 20 minutes. In fact, the time has already started, so without wasting time, I'll go ahead. Now, asthma and COPD, many people have argued that these may be very similar disorders. In fact, there's a Dutch hypothesis and there's a British hypothesis. But for today's talk, I'll take it as two different disorders, and I'll even discuss the similarities. In fact, in practice, many of us have taken these diseases in a very similar fashion. In fact, I remember my MD days. In one of our CENTUPS exam, we were asked about GOLD guidelines. And the person sitting in front of me asked me, GOLD COPD wala ya asthma wala? So I quietly whispered, COPD. And then he wrote the answer. So this was how, in medicine, we used to take these disorders very similarly, but they are different, and we'll come to that. Now, let's begin with, how are they similar and how are they different? Well, you'll find, I'll talk about the definitions, but in asthma, you have a chronic inflammation, airway hyperresponsiveness, and episodic breathlessness and wheezing. And for residents, this is really important to understand. The key word here is actually episodic. In COPD, in stark comparison, again, chronic airway limitation, abnormalities of the airway, but here the disease symptoms are more persistent. In asthma, we're dealing with type 2 inflammation. In COPD, it's more of type 1 rather than type 2. And the management is different. Once we start the patient on triple inhalers, we use it in both the conditions. But when I'm treating with asthma, pure asthma at an early stage, I use inhaled corticosteroids as the sheet anchor of therapy. Then I add bronchodilators to it, dual bronchodilators or a single bronchodilator. But once I'm talking of COPD, bronchodilators are the sheet anchor of therapy, may or may not add inhaled corticosteroids to it. So, when you're talking of early disorders, it is important to classify which one are we dealing with. But once you come to, using triple inhalers, you'll use both in both the conditions. Now, this is a classical PFT, if you can look at it, the FEV1 by FVC is reduced. We do a pre and post bronchodilator, and you find a significant improvement in the values. But mind you, you can see this in both conditions. So I've given two scenarios, very similar. All of us must have seen it. The case A scenario is a very classical textbook case of asthma. A 16-year-old boy with paroxysmal breathlessness, wheezing, chest tightness, more during winter, recurrent sore throat, rhinitis, and has a history of allergy. Case B is very typical of COPD, a smoker with a smoking index of 300, shortness of breath, wheezing, more in winter seasons, cough, sputum production. But what if it was a 40-year-old guy who had asthma in childhood, had improved, has started smoking at the age of 16, at the age of 40 he presents with breathlessness and wheezing. We do a PFT, there is bronchodilator reversibility. I'll right now confess, there are times when we cannot describe this is asthma, this is COPD. But for the purpose of this discussion and for the benefit of the residents, we will always classify them as two different conditions and we'll manage them appropriately. And as I said, in the later stages, you'll give triple inhalers to all of them. But in the initial stages, asthma, make sure you're giving them inhaled corticosteroids. You do not miss out on inhaled corticosteroids for an asthma patient. Initial COPD, make sure you're giving them bronchodilator. Giving them inhaled corticosteroids may not be that advantageous for your patient. So what's about the recent advances? I actually had a lot of slides with a lot of data, but thankfully the organizers made it very easy for me. They said, we do not want to see data. We want your experience on this. And that's what I'm here to share. Mind you, I turned 37 2 days ago, so I don't have that much of experience. But I'll share whatever I've learned over these years. So COPD, the definition has changed. As I said, GOLD was COPD. The GOLD comes up with guidelines every year. And there are times when you're like, ab kya change kiya inhone? Every year they're changing the guidelines. But every 3 or 4 years, they do a dramatic change to the guidelines. So I'm going to talk about what is the dramatic changes that they've done. Earlier you used to say, it is common, preventable, treatable condition. It is because of noxious particles. Essentially what you were saying, it's because of smoking. Now the definition has changed a little. They've added this new term, heterogeneous lung disorder. If you remember your asthma definitions, asthma was always defined as a heterogeneous disorder. Now even COPD is being defined as a heterogeneous disorder. It includes dyspnea, cough, sputum production. What is really important is the last three words, persistent airflow obstruction. This is, I think, one of the most important things which helps me differentiate asthma from COPD. Now this is a new taxonomy that has been revised. We have COPD G, D, C, P, I, A, U. All these classifications. So earlier our understanding was smoking, COPD. In fact, I am involved in a couple of clinical trials, global trials, wherein they say, if your patient has smoked for this much time, include this patient. But if the patient has not smoked, do not include them. And I'm having a real difficult time recruiting for these trials. I see a lot of female COPD patients. They have COPD because of biomass fuel exposure. I see a lot of, Sir's talked about air pollution. We are seeing a lot of pre-COPD and COPD now. I think it may be because of air pollution, but they are non-smokers. I cannot take them on a trial. But our evidence is all on smoking COPD. Is non-smoking COPD a totally different cohort? Now, once the guidelines start talking about it, we will in the coming years have more evidence on this. Genetically determined COPD. We all, during our pathology lessons talked of alpha-1 antitrypsin. How many of us regularly get it checked? COPD because of abnormal lung development. We have children who've had a pneumonia, their lung growth was stunted, and they may be presenting with COPD at the age of 30, 35. But because we are trained to think that COPD will only occur at the age of 40 and above, we may be misdiagnosing them, missing out on this pre-COPD concept. How about cigarette smoking? How about biomass fuel? These are known entities, but we will, now, since we've now started calling COPD as heterogeneous, we will start identifying this more and more. COPD due to infections. In fact, during my residency days, we used this term TOPD, post-TB obstructive airway disease. It is an entity, it is COPD, it behaves like COPD, you have to give them bronchodilators. COPD and asthma. So you have those patients who are asthmatic patients, and if they're not well treated, they develop a degree of fibrosis, and that becomes irreversible. They behave like a remodeled asthma, that's the term. But nowadays we can call it COPD-A. That's an asthma COPD phenotype. Now, I do see a lot of diabetic patients, and most of, I will use a few similes when I say diabetes and COPD management. In diabetes, when I was young, we used to say more than 150 sugars. Then we brought the cutoff down. Now we're talking of pre-diabetes. We're talking of picking up patients who are obese, who have metabolic phenotype of diabetes, and acting early, picking them early. So similar to that, in COPD also, we are now talking of a term known as pre-COPD, wherein you have gentlemen who will come, may or may not be a smoker, but he has respiratory complaints. You do a PFT, PFT is okay. Does not rule out COPD. So you can pick up pre-COPD. Similarly, you can have a person who has, he has no complaints, he's a sedentary job, comes to you, he says no complaints, you do a PFT, you find that there are certain PFT changes. So that is again a pre-COPD. And the idea is to pick up these patients early, we may alter their course of the disease. So screening for COPD, there are many challenges, but this is again, the new guidelines talk of this term pre-COPD, like you have pre-diabetes, like you have pre-hypertension, we now have pre-COPD. The FEV1, FVC predict all-cause mortality independent of tobacco smoking. So even in non-smokers, you can pick up these changes and probably early intervention is possible. Now, diagnosis of COPD, and this is a very logical thing. Earlier, they used to use this term post-bronchodilator FEV1 or post-bronchodilator FEV1 by FVC. But how often, if the patient comes to you very first time, you do a PFT, do a pre-bronchodilator FEV1. If it's less than 70%, COPD is possible. Do a post-bronchodilator test again to confirm it. If it's more than 70%, we think it's no COPD, but if you have high suspicion, you can still confirm with the post-bronchodilator FEV1 by FVC. And if the pre-bronchodilator, so this happens a lot. A patient comes to me, even if I've not been able to do a post-bronchodilator FEV1 by FVC, at least I can do a pre-bronchodilator FEV1 by FVC the very same day, and diagnose it as an obstructive airway disease. As I said, there are times when classifying them on the very first instance is not possible. There may be some degree of overlap. Am I treating asthma? Am I treating COPD? I confess there are times when it's difficult for even experts to make that distinction on the very first instance. Now, severity management, earlier post bronchodilator gives you gold 1, 2, 3, and 4 based on what the value is, FE1 percentage predicted. But then, based on the exacerbation history and based on their symptom score, we classify them. Now, if you remember the old guidelines, they used to call it A, B, C, D. Now it's A, B, and patients who have frequent exacerbators. And based on this, we treat them. A with a simple bronchodilator, B with the LABA-LAMA combination, E again with the LABA-LAMA combination, and we'll add inhaled corticosteroids if the blood eosinophil is more than 300 or if the patient is having exacerbations. So basically, what I'm trying to say is COPD, bronchodilators is the sheet anchor of therapy. A, you can use either. Technically, I would prefer a long-acting muscarinic agent. B and E, use both. And in E, if the patient is having exacerbations more than 2, you would end up giving him triple inhalers. So factors to consider when adding inhaled corticosteroids: strongly consider its use if the patient is having hospitalization or more than 2 moderate exacerbations, has a blood eosinophil of more than 300, or if there's this COPD asthma phenotype. There is, we talk of pharmacological management a lot, but in fact, there's a lot of, whether you want to use ultra long-acting inhalers and short-acting inhalers. I'm not getting into that. That's a whole new discussion, and I do not have the time for it. But let's talk about the non-pharmacological management of COPD, which is equally important, if not more. So in all patients, smoking cessation, and not just smoking. So if it's biomass fuel, you have to insist that they should start using a safer fuel. Pulmonary rehabilitation if the patient is B and E. Physical activity needs to be increased. Now look at these guidelines. Annual influenza vaccine, it's there, but it's quite underused if you ask me. PCV, when in India we have 13 and 23 available, so we always advise PCV 13 and 8 weeks later PCV 23. Zoster vaccine, Tdap, RSV, SARS-CoV, all these vaccines are available. As physicians, this is a very important act that we often miss out on. Giving vaccine is actually a real big game changer for these patients. Every time we prevent an exacerbation, we prevent the decline in lung function. So that's an important target. It's not just symptom management, but exacerbation reduction, exacerbation prevention. The other thing that I wanted to bring to the table is about choosing the right inhaler and the technique. So there are so many. I'm not even talking about the drugs. That's equally important. Short-acting, ultra-short-acting, long-acting, ultra-long-acting. No, I'm talking about how do I select whether I want to give the patient a metered dose inhaler or a dry powder inhaler. It all depends. Try to understand the device. They're very fundamentally different. What does a meter dose inhaler do is once you press it, the mist is already coming out. The particles are of that size, they'll come. So you need a slow and a steady breather for this. He has to inhale and the particles will just keep going down. But with a dry powder inhaler, clump. So what this person has to do is he has to make a very strong effort, break this clump of powder, deaggregate it, deagglomerated, and this will then, along with the flow, go in. So for a DPI, the breathing pattern is very different from that of an MDI. And this is a common mistake we guys make. So, we'll give a DPI and an MDI. The breathing pattern is very different. For a DPI, you have to breathe very rapidly, and that energy is going to be used up to break the particles. With an MDI, once you press the canister, the drug is coming out. So you just have to breathe in slowly and long. The breathing pattern is so different. And if you mix it up, if you breathe slowly with a DPI, the powder will never will never even reach the target rates, right? And if you breathe fast with the inhaler, all of it will just hit the back of the throat. Most of it won't even go in. So these are important training things that we need to assess and assess the technique on each visit. There are amazing devices. There's a lot of technological advancements. New devices have come in which have made it very easy. But at the same time, learning how to use the device, teaching how to use the device is equally important, if not more. There's another thing that has come, Rome proposal. This was to look for earlier, like when we looked at exacerbation patients, we used to look at patients and say, oh, he seems to be having a moderate exacerbation, let me give him steroids. Or in the trials that I do, a patient comes to me with breathlessness, I'll just nebulize him and send him back home. Next day he says, oh, I'm not feeling better. So I'll be like, okay, let's give him some steroids, give him antibiotics, now it's a severe exacerbation, or let's admit him. This was all based on my experience and how I'm doing it, and I could be wrong with it. But now, there's a new Rome proposal that has come, which says you can look at these patients, look at their dyspnea score, look at their respiratory rate, heart rate, the saturation, and the CRP values. Even if CRP values is not possible in every visit, even if ABG is not possible at every visit, you can actually look at the saturation. And if on the very first instance you find that the patient is having severe dyspnea, very high respiratory rate, very high heart rate, saturation is low, ABG shows new onset worsening hypocapnia, you can admit the patient as severe. So if you look at the earlier definitions that were used in the GOLD guidelines, they used to say if the patient required steroids, it's a moderate exacerbation. If the patient required admission, it's a severe exacerbation. But they did not give us criteria on how to classify it as moderate and severe. Now we have those. There's a lot of biologicals in COPD. There's a lot of evidence that is coming on. We are participating in some of these trials, which are ongoing. There are a couple of trials which have already come, but this is something which is to be talked of on a later level. There are a lot of intervention therapies in COPD, bulectomy, lung volume reduction surgery. Technically, let me tell you, this is not a recent thing. Lung volume reduction surgery has been known for years. Essentially what it means is we remove the function, the non-useful lung and allow the useful lung to expand and do its job better. But now what we have is bronchoscopic ways of doing it. So with a bronchoscope, we go in, put in a clip, or put in a device, or a coil, or there's other techniques that are coming in for doing it bronchoscopically. I am never comfortable sending a severe COPD patient to a surgeon, and neither is the surgeon very comfortable operating on a severe COPD patient. But bronchoscopic interventions allow us to manage these patients, and this is something new. Again, when I say new, it's a decade-old technique that we're talking about, but it's coming up in our country. Shifting gears, I have very little time, so I'll be a little quick. Asthma, very similar, heterogeneous disease, wheeze, shortness of breath, chest tightness, cough, varying over time and intensity, with variable expiratory airflow limitation. And this is where, if you ask me, how do I differentiate between asthma and COPD, it's all based on variability. If I find that variability in a characteristic history, I'm very confident in saying this patient has asthma. If I do not find that variability, and again a characteristic history, I'm very confident in saying it's possibly COPD. I know, confident and possibly sounds like an oxymoron. Airflow limitation may later actually become permanent. This is what we called a remodeled asthma. So even this asthma can behave like a COPD. Now the new techniques that we are using here is in pheno. Again, when I say new, it's more than a decade old. During my DM residency in AIMS, we used to do this. It has diagnostic, prognostic markers. We use it a lot in a research tool. I'm not saying that you have to get this test done if you have to diagnose asthma, but if you're looking at severe asthma, it helps you to phenotype. Okay, really running low on time. So this is the new technique, another new technique. Getting a spirometry done, if you've ever had it done, you'll know it's very labor intensive, not just for you and your technician, but even for the patient. We have a new technique which is known as impulse oscillometry available. And this will give you a report. What it does is the patient just has to do tidal breathing, no forceful maneuvers, and it will superimpose a sound wave on this breathing. And based on that, we get values which will tell us whether the patient has a small airway disease, a large airway disease, where is the resistance. And it's, again, in India, we're getting more and more evidence and data on this, but this is really interesting. The terminology here. Earlier, when we had asthma, we used to say, use a bronchodilator and the asthma symptoms will improve. But try to understand, if I may be permitted by the permission of the chair, a few more minutes. Just about 2 more. Yeah, that would be good enough. Very kind of you. We can discuss. Yeah, we'll. So the terminology that has changed slightly is earlier, we used to give asthma inhaler as a reliever inhaler. Now we're saying every time we have to give a reliever, why not give him an anti-inflammatory drug alongside? So an ICS and a formoterol or a short-acting agonist, that becomes anti-inflammatory reliever. And there is, this is a very good diagram to look for when if I have to look at asthma managements, adolescents and adults, this is my go-to diagram. The only thing that I want to bring to your attention is there are 2 tracks. Why did they come up with 2 tracks? If I am permitted to use, certain commercial names, formoterol containing therapy, which is, the Foracort inhalers that we've been using for a long time. Formoterol has an onset of action of just about 5 minutes. So if you use it as you're using it as maintenance therapy, but if you want to use it as a reliever, you can. Salmeterol has an onset of action of about 30 minutes. So if the patient's having an exacerbation and you give him a salmeterol inhaler, he'll have to wait for 30 minutes for that. So with salmeterol, we have to use Astelin. But with formoterol, you use a single maintenance and reliever therapy. This is known as smart therapy, what we use. So when you're using an ICS formoterol, you can use it as a single therapy. That's just the take-home point from this. For all chronic disorders, this is not just for asthma actually. I believe for all chronic disorders, you will review, assess, and adjust the treatment. So you have mild therapy, where you just can use this if you're using formoterol. Otherwise, reliever will be a short-acting beta agonist that has to be added. There is low dose and medium dose of inhaled corticosteroids. And there is this asthma management plan that everybody should be aware of. It makes it very easy to manage patients. I have patients who come from abroad also, but even if a patient's coming from Gurgaon, I need to give him this asthma management plan. A bit about phenotyping. How do I look at severe asthma? It's a different ballgame. I do what is known as endotyping. That's just a fancy name. What it means is there is a phenotype, a severe asthma phenotype, and I have to link it to its mechanistic pathway. Is it Th1 and Th2? Implications being that if it's Th2, I have a couple of drugs. Omalizumab, mepolizumab, benralizumab are available in India. Anti-TSLP, we have ongoing trials on this, and anti-IL-33, our center is also participating in some of these trials. But if you have anti-Th1, anti-2H2, you're not very clear, these drugs may work, but for anti-Th2, only these drugs are approved, and the first three are available. Dupilumab is also shortly going to be available. Sublingual immunotherapy is something that has been added in the GINA guidelines. Now, what it essentially means is it's based on the principle that toxins in small amount, if it doesn't kill you, it will make you stronger. And that's the idea. We give, for dust mite, it is allowed that we can give this sublingually. I'm not aware of many centers who are doing this. I think VPCI does immunotherapy, but they use subcutaneous immunotherapy rather than sublingual immunotherapy. Bronchial thermoplasty was something which had come. The idea here was that we will burn the airway smooth muscles and they will be permanently dilated. But let me tell you, the company that was manufacturing this has stopped manufacturing this. So I would, this is probably now of interest. One thing, my take-home points in asthma is LAMA monotherapy, never to be used without an inhaled corticosteroids. Azithromycin is something that can be considered. Sputum eosinophils can guide you, pheno can guide you, and you have to manage comorbidities. With that, I'll conclude, but I'm hoping for a discussion on this.
Thank you, Dr. Rohit. And I think it's a very difficult task to probably club COPD and asthma. And as the topic proposed was advances in, so it's quite tough. I think what we'll do is we have probably another 10 minutes. It's okay. So we'll take another 10 minutes and Pankaj, it's fine, 10 minutes. So in 10 minutes, we'll break it down to 5 minutes each for asthma and COPD. So if any have a question, kindly raise your hand. Otherwise, we'll just try and sum up the important aspects. So we'll begin with asthma. You want me to continue? Yeah, so let's think about asthma. First thing is diagnostic. Sharad will go from here. Anything you want to add for diagnostics of asthma? Both are similar diseases. So let's concentrate on asthma for 5 minutes.
So as rightly said by Dr. Rohit, reversible paroxysmal, that is asthma. Early onset allergic components, that is asthma, and reversibility on it should be there.
Quick word on any role of skin testing when you are, because it's quite a cheap method of doing. So skin testing versus role of IgE RAST. You see a lot of physicians prescribing huge number of 150, 60 panel of allergens. So how is it useful or no? Otherwise,
so skin testing is useful, but mostly in the pediatric age group or the adolescent population also, they will definitely be scared of 150 allergens to be pricked in the skin. So maybe the RAST and the blood test for allergy are more important or more useful for especially pediatric population.
So I think my take would be that kindly have a pre-test understanding of why you are getting those done, because otherwise you land up in a lot of soup with 60 positives and you will not be able to answer what to do. So be careful. Sir, Dr. Lalit, quick for this asthma, any differential diagnosis as a physician you want to entertain when a guy is coming with breathlessness, so that for everybody, differential diagnosis in a working OPD, patient coming with shortness of breath, wheezing.
Basically, we have to differentiate between asthma and COPD patients.
No, asthma and as a physician, other diseases which could present with breathlessness.
Cardiac failure, we have to differentiate.
So I think that is very important. Because a lot of patients would be elderly and would actually have an indolent heart failure, and sometimes that is overlooked and we don't treat. So Arjun, coming to the next point on asthma, which just comes to my mind is about treatment. So can you just summarize?
Sure.
I think that is very important because there are two tracks. So can you just summarize in short for physicians, how do you manage a patient who has been diagnosed with asthma?
So last couple of years, the management of asthma, since 2019, GOLD has changed completely. There is absolutely no role of giving them only reliever medicines. So salbutamol, levosalbutamol, SOS are absolutely out. The basic take-home message that needs to be given to everyone is the treatment of choice of asthma is inhaled steroids. Whatever is the severity of asthma, mild, moderate, severe, even the mildest patients who have symptoms only say twice or thrice a year, there is absolutely no role of salbutamol or levosalbutamol. Any asthmatic who comes to us, any level of practice, the treatment of choice now, even to start the therapy in the mildest of asthmatics, is a combination of ICS and LABA. All the trials that have been done are on formoterol with budesonide. So if a patient comes to my practice with so-called asthma, suspected asthma, or if I have diagnosed asthma, the treatment of choice, the starting therapy of choice would be SOS, ICS, LABA, which is so commonly available, Foracort, on all these components, where the combination is formoterol with budesonide. If at all I have to use a SABA, such as salbutamol or levosalbutamol in a patient, it has to be clubbed with an inhaled steroid. So there is absolutely no role of bronchodilators alone. The inhaled dose, the dose of the inhaled steroid would go up. The GINA step up, step down is basically a step up, step down based on the dose of the inhaled steroid. So all patients would be started on a baseline low dose of steroid. As they are uncontrolled, we keep moving up the dose of the steroid. This is track 1. Track 2 is when the patient cannot take a combination of ICS LABA. So multiple other drugs are available. Most of the international guidelines, including GINA, do not talk about oral drugs which are used in the management of asthma, especially in the Indian subcontinent. So there is no role of darifilin, doxyphilin, acebrophilin. You will not find that in the guidelines at all. Montelukast, which is very commonly used in the Indian practice, is only to be used as a second line drug where your patient is not controlled on full doses of ICS LABA. Along with that, 2 phenotypes. If the patient is a male smoker, the patient has concomitant rhinosinusitis. These are the only patient subtypes where montelukast is shown to have some kind of a benefit. Otherwise, routine prescription of montelukast should not be there in all asthmatics. Combination of montelukast with levocetrizine, other antiallergics is again not indicated for all patients of asthma. In fact, if you give antiallergics to a patient with asthma where it is not indicated, it can make your control of asthma more difficult. So the treatment of choice for asthma, to keep it very simple, summing it up in one line, is a combination of ICS LABA. The most studied molecule is formoterol with budesonide, and whatever is the severity of asthma, even if it is mild asthma, rather than sending him home on a pump of salbutamol, give them a pump of formoterol with budesonide, and that takes care of a lot of problems.
So I think we have had a summary of all, and I hope it's been useful. Quickly going to the perspective of a physician. So you get a lot of patients who would have issues with not taking inhalation therapy, am I right? There is a lot of still myths about it. So how do you deal with it, and what are your then go-to options if somebody just tells you, I don't want to follow what Arjun is saying? So there will be people whom we will say inhalers, they will not take inhalers. That's the truth. Your physician perspective of managing this, because I want you to touch down upon your experience of using darifilins and these type of salts for last 40 years.
Thank you, Dr. Bharat. Before we move on to this, I think the 2 most important things which we must understand is, once we are treating resistant kind of asthmas, we must try and rule out the ABPA part and the Chuk's-Strauss syndrome in these many patients. Many a times we keep on stepping up our steroids, bronchodilators, and they don't respond, and we don't try and search for other things at times. Number 2, the most important aspect which we find, as I find as a physician, is that when we see critical care patients, there is a sudden switch over of steroid therapy in these patients. You're already giving them steroids and the patient is not responding. So what we do is we switch over to a different kind of a steroid at a higher dose with no response, without taking a support of NIV at the time of treating patients. So I would like to have a word by all of you that what should be done at this moment. Now coming to the third part about the compliance, I think if we make the patient understand the bronchodilator therapy and especially the nebulizer part, and he's very comfortable, they understand that yes, the side effects, the adverse effects of oral therapy are more than the inhaled ones, and we need to improve their compliance by just guiding and counseling them. That's more important.
So I think the three terms, compliance, adherence, and now there's a new term called persistence. So how you prescribe and patient follows it, he follows it for some time, then how long does he follow that therapy? Probably those three are the most important, which have to be educated, and education is very important for any disease at every visit. So we will close on asthma, 3 minutes for COPD. So I think Sharad, do you want to tell us about the go-to treatment of COPD now, considering that let's not confuse people with those alphabets of A to Z. So a patient comes, he has recurrent exacerbations, that's the usual scenario for a physician who is having cough, expectoration, getting some short course of steroid. What will be your go-to therapy for such patients?
Before we go to COPD, one very simple question. After we initiate inhalation therapy in asthma, symptoms have subsided, how long do we continue?
So if you are asymptomatic, the answer is that every 6 months you have to follow up with a PFT and look at the symptom score and everything, right? Then you can step down. As Arjun was saying, there is a step ladder approach. You can step down to the lowest possible inhaled corticosteroid dose, right? Now the other is that your question could be that can we switch the patient off? Now that is only possible if the trigger is known and the patient is now not exposed to that trigger. If you have a perennial allergen or you have a trigger at workplace and something, it is not wise to switch even if the patient feels I am okay. So yes, it's like diabetes. Do you switch your patients off for diabetes? No, you don't. You don't say now your diabetes is controlled, stop everything and go just to diet. Once you have taken that decision that patient needs therapy, it has to be. So I think we are closing, just closing remarks for COPD therapy. So basically the triple therapy which is in vogue.
So the important thing is that very often we come across the patients with frequent exacerbation, one thing. And second is that there is lot of overlap. Even a COPD patient might have rhinosinusitis or allergic phenomena. In those cases, triple therapy or adding ICS to LABA-LAMA combination in COPD is recommended.
So Dr. Rohit, you talked about TH1 and TH2. So the biomarkers is readily available because how you differentiate between TH1 and TH2 is in the biologicals available. So how we would know that this is TH1 and TH2? Right?
So earlier they used to say look at sputum eosinophil, but I will be honest, I have never seen sputum eosinophil reports. Easiest, look at the blood eosinophil reports. That's one of the easiest marker. You can look at FeNO if you have that available. You can look at serum IgE values, which will tell you whether it's allergen driven or whether it's atopy driven asthma. So for me, serum periostin is also a research tool. So I rely on just 3: serum eosinophil count, blood eosinophil count, serum IgE, and FeNO.
Right. Thank you.
So what is the role of glycopyrrolate in COPD?
So in asthma or COPD?
COPD.
I think in COPD, as Sharad was just saying, the world has moved on to more or less a triple therapy. The drug of choice, even when you are not using triple therapy, is a LAMA-LABA combination. So there is more or less hardly any use of a monotherapies now. Even if monotherapy is used, it has to be a LAMA first, then a LABA. So glyco will fall in that LAMA category. So I think that's a drug which has made a lot of change. I'm getting a lot of indication that we need to close the session for the next program. Finally, yeah, please.
See,
I can
most of
take
the times
questions.
our patients say that they prefer using a nebulization instead of using a DPI or MDI.
So
is there any harm in continuing with nebulization?
So what I'll do is, because we need to close it very fast, there are specific indications for long-term home nebulization therapy. Let me be very clear, it is one where you cannot coordinate with the inhalers, you have dexterity in issues, you have elderly, you have nobody to care for. So nebulization is an easier technique, but then if you compare with other devices taken properly, the effect is going to be as good. So please, there is no take-home message that everybody should be on nebulization. There are very specific scenarios where you put patients on home nebulization. I think we need to close it. We need to probably close with the idea that both COPD and asthma are quite debilitating diseases, and how the world has changed is that it was only asthma which was thought to be heterogeneous. It's even COPD which is heterogeneous. You saw so many alphabets now being described for taxonomy of COPD. So I think with that, we close. There is lots to discuss about COPD asthma. You have some point? Somebody, yeah, so there is a question. You're loud enough. No.
Just to be very clear, difficult to treat asthma is not the same as severe asthma. When I say difficult to treat asthma, and as Sir pointed out, not everything that wheezes is asthma. So my first role when I see a patient in my severe asthma clinic is make sure it's asthma. Make sure the patient is compliant to treatment. Make sure he's taking the inhalers correctly. Once all this checklist is done and I'm very confident this is asthma, I will do endotyping of them, find out whether this patient is IgE or is type 2 or non-type 2. And based on that, I'll take a call on biologicals, but there are other therapies that also can be offered. Most of my patients, I work in Safdarjung Hospital, most of my patients cannot get biologicals, cannot afford it. So either I get them into a trial, or the second thing is I do have to use systemic steroids for a long time also. But yeah. So if the patient is OCS dependent, biologicals are known to have an OCS reducing, OCS sparing effect, and we can try that.
Thank you, Dr.
So
Rohit Kumar. I need to close this session, sir.
We
are already behind time. I need to close this session. May I request the chairperson and speaker to proceed to the felicitation desk. May I request Dr. B.K. Tiwari, sir, to please come forward and do the honors. May I start the next session? The chairpersons for the next session are Dr. Rajiv Gupta, Dr. Anil Mota, Dr. Jasjeet Singh Wazir, Dr. Ashok Grover, Dr. Rajiv Bansal, and Dr. Ajay Gupta. The next session is on diabetes. May I request the chairpersons to invite the speaker and start the session.
Welcome to the third session of the day. A very interesting session on some of the latest drugs that are available now. And we have a very internationally famous speaker for this. Professor K.K. Sethi is well known to this audience and probably one of the most versatile speakers and sought after speakers in the country. He has been speaking not only in India but even in lots of countries, and he is a product of Delhi, Maulana Azad Medical College, both his MBBS, MD and DM, and I have had the honor of knowing him since when he was doing his DM, and I know how hard he used to work. In fact, at that time, the GV Pant Hospital, there were the 3-4 people who really made GV Pant on the world map, and Professor K.K. Sethi being one of them. So he's a renowned author, written several articles in various magazines and art journals. He has been also the editor of Indian Heart Journal, and he has been awarded by the Government of India with a prestigious award, Padma Shri, in 2006. And he has close to 300 publications to his name. So request Professor Sethi to deliver his talk today.
Good morning, friends. First of all, let me express my thanks to the organizers for giving me this opportunity today. Somewhat strangely, but not very irrelevantly, fielding a cardiologist on a presentation on diabetes, and that too in presence of so many stalwarts of diabetes on the dais, actually shows how much significance the cardiovascular disease has actually attained in management of diabetes. That is one aspect of my interest in coming here. But apart from that, I am happy to see many of my old friends whom I was not able to meet for several years. But one thing has somewhat startled me, that the color of hair after COVID, I have seen people has changed in most of them. And obviously, that means that people have become more mature, more senior, and we are all very lucky to have survived that episode and epidemic, and we should be thankful to God for that. Now, coming to the subject for today, some of the most important advancements that has happened in the management of diabetes in the last few years is our major shift in approach towards its treatment, from a glucose-centric approach to looking at cardiovascular outcomes. And two important classes of drugs which have made their mark in this are, of course, the SGLT2 inhibitors, which have been extensively investigated, and somewhat less prominent and less investigated, but very, very important for future, are the GLP-1 receptor analogs. So it's the latter on which primarily my talk is focused, and I will be mostly focusing upon the cardiovascular aspect of these drugs rather than towards management of diabetes, which automatically will become a little bit of part of my discussion. Now, looking at the outcome benefits in the EMPA-REG and the two trials which have used GLP-1 analogs, you notice that in both of these sets of trials, the 3-point MACE, that was the cardiovascular death, myocardial infarction, and stroke, were one of the endpoints that were investigated. And the EMPA-REG actually showed that you have a marked reduction in cardiovascular death, but somehow or the other, there was not so much reduction in myocardial infarctions and strokes, as you can see on the right-hand side of this picture. As a freebie, we also got a very significant reduction in heart failure hospitalizations, incidence of heart failure in these people. That was something that was a pleasant surprise to all of us, but has nevertheless become a very major therapy in treatment of heart failure as for today. On the other hand, when you look at the LEADER study and the SUSTAIN-6, which have used the two GLP-1 receptor analogs, you see that in the leaders, the cardiovascular death has been reduced, but the heart failure hospitalizations not significantly affected. In the SUSTAIN-6, which was with injectable semaglutide, as you know, not much difference was seen between cardiovascular death and heart failure hospitalizations. But looking at the right-hand side of the graph, in the leader, myocardial infarction and stroke were not significantly reduced. In the SUSTAIN-6, stroke was significantly reduced with a significant trend towards reduction of myocardial infarctions. So telling us that these two classes of drugs have different types of effects on the cardiovascular system, and whether or not with the GLP-1 receptor analogs it can be classified as a class effect, we don't know as yet, because the results with the two drugs are not necessarily matching with each other. The patterns of CV benefit and the mechanisms of the same have been briefly summarized on this slide. As far as the GLP-1 receptor analogs are concerned, the focus is on prevention of atherogenesis or atherothrombotic events, because the time taken for the benefits to come is rather long as compared to SGLT2 inhibitors, which have hemodynamic effects, and therefore you start seeing very quick response in them, particularly in terms of symptomatic relief of heart failure and other things which are concerned. The GLP-1 receptors possibly work through atherothrombotic pathways, and obviously both these classes of drugs do not cause significant hypoglycemia, which is a common mechanism, but majorly heart failure risk is reduced by SGLT2 inhibitors. Now, a very important aspect of patients with diabetes is the presence of obesity. And obesity is a very significant morbidity that not only brings in a number of diseases, but also worsens their prognosis to a very large extent. It increases the risk of all-cause mortality from various problems by almost 7 times. And Indians, as you know, the thin fat Indian with a lower lean body mass and a higher subcutaneous fat is a vulnerable individual towards these kind of complications. And 1 in 10 adults in India are diabetic. 67% of these are obese people. The first thing that we advise to them when we look at an obese man or a woman is to do lifestyle modifications. Initially, everyone is enthusiastic, the doctor and the patient, but soon to realize that the advantages of the initial enthusiasm have waned and the weight comes back in different periods of time. Even in post-bariatric surgeries, unfortunately, there are not everybody who sustains the weight loss, and weight regain is known no matter which one out of the 3 procedures is performed in them, namely sleeve gastrectomy, Roux-en-Y, or 1 anastomosis gastric bypass. The effect of available anti-diabetic drugs on the body weight is well known to all of you. The 2 classes of drugs that we have been talking today, the GLP-1 receptor analogs and SGLT2 inhibitors and metformin, are known to produce weight loss. The DPP-4 inhibitors are weight neutral. Insulin sulfonylureas and TZDs definitely cause weight gain. Now, GLP-1 receptor antagonists basically act on appetite regulation, directly and indirectly activating brain regions in the hypothalamus and hindbrain, which were involved in appetite regulation and reduction of hunger, energy intake, and food cravings happens. It results in increase in satiety, and that is how it is assumed that the mechanism of weight reduction actually happens. The SGLT2, on the other hand, are basically inhibitors of these SGLT2 inhibitors cause glucosuria, and in the renal parenchyma there is a huge difference then between the concentration of the glucose between renal artery and the renal vein, and that results in appetite stimulating hormones which are reduced by the SGLT2 inhibitors, and there is a reduction of appetite. On the other hand, when you lose glucose in the urine, there is calorie loss, and that actually becomes a appetite stimulant with compensatory food intake, and the overall balance between these two actually dictates how much weight loss occurs in a given individual. And you would have noticed that in some patients you get very large weight loss with SGLT2 inhibitors, resulting into several kilos. In others, the weight loss is relatively mild. The focus these days, therefore, is to prevent diabetes or to prevent cardiovascular outcomes from diabetes by what we would like to call as an upstream approach, because as you see that obesity or adiposopathy occurs, it not only results in hypertension, coronary disease and diabetes, but a number of other problems like obstructive sleep apnea, NASH, osteoarthritis, dyslipidemia, etc. And they all join together to produce these complications. And earlier our approach was glucose-centric, which we call the downstream approach after hyperglycemia has set in. But more recently, we started talking about weight-centric approach or upstream intervention. And if we concentrate on weight reduction, there is a very strong possibility that not only diabetes can be controlled better, but many of the other complications can be reduced. Now with semaglutide, which is the topic for discussion today, there has been a number of studies, though not in very large number of patients, in the Pioneer Global Program, where the drug has been used as monotherapy, comparison with SGLT2 inhibitors, DPP4 inhibitors, then comparison between semaglutide and liraglutide, then patients with moderate renal impairment, semaglutide versus placebo, cardiovascular outcome trial like the Pioneer 6, etc., which are, some of them are relatively short-term trials of about 26 weeks and so, but others have now been extended to almost 52 weeks and more. Now, the endpoints in most of these studies, obviously when you are comparing two drugs, was the change in HbA1c levels and the change in body weight, which was a confirmatory secondary endpoint. But in the Pioneer 6, obviously the first 3-point MACE and time of first expanded composite CV endpoint has been the major focus of this study. And the Pioneer 7 is again a 52-week study, proportion of patients achieving HbA1c less than 7%, and again change in body weight, and this is in combination with insulin, as all of you know. Oral semaglutide has shown significant HbA1c reductions versus a range of comparators in the Pioneer program, and as compared to almost all the drugs that we have mentioned just now, it is quite an equipotent drug, and in average HbA1c reduction of about 1.5% with this drug. But if one is able to get to the 14 milligram dose, which is not very easy in my personal experience, not only because of cost, but patients somehow are reluctant to take that dose, but the reduction in HbA1c from baseline, especially in individuals whose baseline HbA1c is more than 9%, is well above 2% range in most of these studies. Now, the pooled cardiovascular outcomes data combining oral and subcutaneous semaglutide in SUSTAIN 6 and Pioneer 6, it shows a almost similar 24% risk reduction versus comparators. And if we combine these two data, and a combined analysis has also shown a 24% reduction, similar reduction in all these three types of analysis which have been done with these two studies. So cardiovascular safety of oral semaglutide, when added to standard of care, in whatever data that is available to us till now, shows a non-inferiority for MACE of oral semaglutide versus placebo has been confirmed, and a non-significant 21% reduction in 3-point MACE was achieved. A significant 51% reduction in the risk of cardiovascular death, and a significant 49% reduction in all-cause death was also observed. However, as we all know, these are small studies and larger trials are on the way. Hemoglobin A1c and body weight were reduced with oral semaglutide versus placebo, and oral semaglutide was generally well tolerated, and safety profile was consistent with the GLP-1 RA class. Now, SOUL is one big trial involving almost 9,000 patients that is looking at oral semaglutide lowering the risk of major cardiovascular adverse events compared with placebo. The trial is underway and the duration of follow-up is up to 5 years, and obviously we will be eagerly awaiting for the result of this trial. Let's for a moment come back to the importance of weight loss in type 2 diabetes. And as you know that risk of type 2 diabetes falls significantly with reduction in weight loss, and not only that, it is proportionate to the reduction in weight from baseline. If you have about 15 kilograms of weight loss in a given individual, obviously diabetes can be more or less prevented in that particular individual. Similarly, weight loss helps very, very significantly in diabetes control, and I am not an expert on this. You all know much more than me about that, but you need at least about 10 to 15 kilograms of weight loss to achieve a very significant effect as far as change in HbA1c is concerned. And also, you can look at change in fasting glucose by weight loss category, almost similar results, 5 to 10 kilograms here and 10 to 15 kilograms of weight loss required. Now, this is a diabetes remission clinical trial, and if you then see that the incidence of remission is directly proportional to the amount of weight loss that takes place, greater the weight loss, greater is the proportion of patients with remission, and this is data follow-up of up to 2 years. Not only that, weight loss has a very positive effect on CVD risk markers, and this is look ahead 1 year data, blood pressure reduction, triglyceride reduction, and HDL increase and LDL reduction, all in proportion to the weight loss, not in terms of percentage of weight loss from 2% to 15%, and more the weight loss, more is the improvement in these risk factors. Similarly, this is a little messed up slide, but oral semaglutide has also shown clinically relevant weight loss, especially with the larger doses when it is compared with almost all other anti-diabetic agents that we use, and up to 5 kilograms of weight loss has actually been shown, especially with the higher doses, as I said before. The reduction in weight is more significant versus empagliflozin, as you can see in this, that is almost oral semaglutide roughly 4.7 kilogram, which is 24% greater reduction in weight on empagliflozin at week 52. But everybody is not able to achieve that much of weight loss. It is quite variable from patient to patient. But the drug also causes selectively greater loss of fat over lean body mass, and that is what would be clinically relevant. A 3-fold greater loss of mean fat over lean body mass was observed with semaglutide versus placebo. And as I show you my last 2 slides, I want to share with you a very recent presentation that I attended in European Society of Cardiology meeting, and that was published in New England Journal of Medicine late September of this year, which for the first time has looked at patients with heart failure with preserved ejection fraction with obesity. It is called the STEP heart failure preserved ejection fraction study, which is being conducted on non-diabetics. The diabetes was excluded in this study. This was a randomized, double-blind, placebo-controlled trial, 529 patients with BMI more than 30, ejection fraction more than 45, and all had heart failure with preserved ejection fraction, symptomatic class 2 to class 4. And this was, of course, with injectable semaglutide, 2.4 milligrams subcutaneously or placebo for 52 weeks. And the median weight of the patients was 105 kilograms, BMI of 37, CRP of 3.8, ejection fraction 57%. And all of them were getting all these guideline-directed background therapies including beta blockers, RAS inhibitors, diuretics, and mineralocorticoid receptor antagonists. And you can look at the results of this study. At 52 weeks of follow-up, there was a quality of life was very, very significantly improved by the Kansas cardiomyopathy clinical score, and the change in body weight was to the tune of 10.7 percentage points. Not only this, so this was mainly a clinical study. The confirmatory secondary endpoints was a significant increase in the 6-minute walk distance, significant reduction in C-reactive protein levels, and the other various parameters that all showed a very, very significant reduction. So the American Diabetes Association in 2023, and you all know about this, I don't need to go into the details of this slide, strongly recommend that the efficacy for weight loss is very, very high with semaglutide and also with SGLT2 inhibitors, and patients with cardiovascular risk factors should preferably be given either of these two drugs in whatever sequence you would like to do, but if required, both of them can be combined very, very successfully. And ladies and gentlemen, these are early days. As we learn more about cardiovascular outcomes and diabetes in patients with heart failure, CKD, established CVD, or multiple risk factors, the decision to use GP1 receptor agonist or a SGLT2 inhibitor with proven benefit should be independent of background use of metformin. So my last slide, the global and national burden of type 2 diabetes is increasing and is complicated by inadequate control and multiple comorbidities. Diabetes with high body weight, syndemic, leading to adverse patient outcomes. Adopting an upstream approach towards weight management in type 2 diabetes can lead to multiple clinical benefits. So strategies in weight reduction in their current scope have multiple challenges, especially patients with type 2 diabetes. And GLP-1 receptor agonists have various overarching benefits beyond A1C control and can have a valuable place in upstream approach in type 2 diabetes. And I hope that in the near future, we will be seeing larger studies with cardiovascular outcomes and in patients with obesity that will further improve our paradigm in diabetes management. Thank you very much for your kind attention, and I would like to hear from the experts sitting on this panel now. Dr. Gupta.
Thank you, sir. That was a very interesting presentation and right up to date also. The last one, the last slide of yours was really good. What I would like to ask you is, are there any contraindications to use of GLP-1 receptor antagonist in cardiac patients?
No, not from cardiac point, except patients with very severe renal disease, moderate renal dysfunction, yes, they are fine. But otherwise, as of now, we don't see any significant contraindications to the use of GLP-1 receptor.
It was found that generally in heart failure, the GLP-1 RA drugs were not all that useful.
No, not at all. In heart failure with reduced ejection fraction, they are not very useful. The whatever data is, little data is available. Direct study on heart failure with reduced ejection fraction is not available because the preliminary data itself shows that their mechanism of action is not hemodynamic. They work on atherothrombotic pathways in terms of reduction of strokes and myocardial infarctions if possible, and through that mechanism a reduction in cardiovascular mortality. But we need larger studies for that because the numbers are relatively small, but we do not expect that they will work in heart failure with reduced ejection fraction. However, they do not worsen heart failure with reduced ejection fraction because the results are neutral, and therefore you can use them if there is a patient with previous infarction, for example, who has heart failure with reduced ejection fraction, multivessel disease, or peripheral vascular disease in addition, or cerebrovascular disease. You can easily use this drug from that point of view. Till we get more information, the situation for heart failure with preserved ejection fraction, however, is going to be different because the result in non-diabetics is also very significant, which was very heartening to note that in people who are overweight, you attack the weight and that itself produces beneficial effects because the preserved ejection fraction has very few therapies available. It's a very difficult animal to treat. So I think that is where this is going to have a very, very major role.
Yeah, that's true, sir.
Sir, I have one basic question which I want to know from your experience, and that is injectable semaglutide versus oral semaglutide. Which one do you recommend and why? Number one. Number two is about oral semaglutide having a negative effect, especially in worsening of retinopathy.
Yes.
So I want to know what do you prefer?
At this time, see, patients would any day prefer oral semaglutide. However, as I said that these are early days and we need larger studies. The question of retinopathy obviously is, has been raised with oral semaglutide. And again, as I said that the number of patients has been very, very small and one has to wait for that kind of data. Adverse effects will be known as larger studies are conducted with specific patients. This time everything was focused on diabetes management. Now we should be looking at what happens to the cardiovascular outcomes and other organ systems. There is a preliminary indicator at least that the kidney, moderate renal dysfunction is also benefited. There is a delay in worsening of nephropathy, but as you said, the retina is of some concern, and I agree with that.
So, with your permission, can I add on to that answer?
Oh, certainly, please.
Talking about the renal part, the flow trial was prematurely terminated because of the renal benefits. So, a big tick mark there. About retinopathy, we don't have a white paper on that. But as per the guidances and the discussions, moderate to severe retinopathy, we should avoid using that, because from the studies, even in dulaglutide, we had evidence about progression of retinopathy. Is it rapid lowering of sugars or the GLP-1? We really don't know about that.
I don't think so. I think it was more with injectable semaglutide, but with oral it was not.
It was more oral, and it was more oral.
Yeah.
And they said that doctor said that please do not try to inject
If I remember correctly, I think there is some concern with liraglutide also with retinopathy. So that is an aspect which could be a class effect, but interestingly, so far the cardiovascular effects have not been similar between them. That is an interesting thing, and therefore it might be individual molecule related rather than a class effect. We don't know. A question has been raised. SGLT2, it's a class effect because multiple drugs have shown similar benefits.
Few questions from the audience. Doctor,
yes, please.
Yeah,
sir. So I would like to go back to one of your previous slides. I don't know whether I misread it or what are its implications. It said that the oral semaglutide was non-inferior to placebo in a 3-point maze.
Yes.
What does that mean?
Yeah, that means that when you start investigation with a product, you always compare it with placebo. First thing that you do. And the upper bound for non-inferiority is decided by the trial investigators based on international guidelines as to what is the upper, which means basically the standard deviation on both sides of the mean. And when you start with, you get a much larger upper bound. You get a wide range to, define non-inferiority. After that, once more experience gathers and you compare it with other drugs, that you have to have much more precise effect with the drug, and therefore the upper bound allowed could be down to maybe 30% or 1.3. As you see these forest plots, you see the range of the values, So median and the lower bound and the upper bound. So this is 80% upper bound there. The first trials are with smaller number of patients. When you compare with placebo, you have more flexibility.
Right. No, what I meant was, since it was similar to placebo, so the implications...
So it's not harming. That is what the first trial said.
Okay, so
the subsequent,
very initial,
you have to start like that always, and then you see whether you have a positive outcome or not.
Right.
Dr. Sethi, any age restrictions with this GLP-1?
Oh, sorry, I didn't know from where the question is coming. Yes, can you
any
say
age
again?
Restrictions?
Any?
Age restrictions.
Not so far I know. The only side effects that have been seen are the GI side effects. That is as common to injectable as well as oral GLP-1 receptor, analogs. Even the other one.
Till
has
what age can they be prescribed?
Actually,
no restrictions.
We don't know as yet, but patients have above 70 years of age have been given this drug.
So this drug has also been tried in adolescents for weight loss in the STEP-TEEN trials. So it's kind of approved for adolescents. The extremes of age, as sir also rightly said, there wouldn't be no bar there. And that question on non-inferiority, the Pioneer 6 trial was actually a cardiovascular safety trial for a non-inferiority, that a drug is safe as far as cardiovascular. So it was not designed for superiority. Yeah.
But the other trials have actually shown superiority. Yeah.
Sir, one question is.
Yes.
As GLP-1 RAs, they are to some extent reduce the aortic valve calcification.
Yes.
Do they
reduce
also
aortic
help
stiffness.
in coronary calcification?
No, we don't know. It's not been studied. They reduce aortic stiffness basically by virtue of their mechanism of action, and that has been, sort of discussed as one of the mechanisms by which they work. But we don't really know. There is some reduction in blood pressure, and there is reduction in systolic pressure, as well as some little increase in the diastolic pressure, so which doesn't go above the normal permissible limits, but the pulse pressure gets reduced, and that is how the aortic stiffness becomes less. Coronary calcifications, no, I don't think it is going to be something that will reduce. We haven't seen anything that reduces coronary calcification. It's a degenerative calcification which you can pick up on the CT scan in the form of a Gadsden score, and it correlates with severity of actually coronary artery disease in most patients, though not in everybody.
The interstitial calcium in the aortic valve has been reduced in patients who are decreased GLP-1 RA. So when we increase the GLP-1 RA level,
these are very early days, and tomorrow you might start looking at something in the aortic valve, because we know that aortic valve stenosis in elderly is also a degenerative disease, and Lp(a) is one of the pathogenetic particles that has now been implicated in causation of aortic stenosis, apart from other atherosclerotic risk factors, and that is something where you actually see macrocalcification, and that is something that again will automatically come as a byproduct of this study, because the older individuals have very significant incidence of aortic sclerosis, aortic calcification, and subsequently aortic stenosis. So we don't know at this time, but at least the floodgates have been opened for a lot of things.
Thank you, Dr. Sethi, for an outstanding presentation. My question, sir, here I am. My question, that can we use semaglutide orally in the absence of diabetes for weight reduction? And if we should use it, is it again step ladder pattern 3, 7, 14, or we can directly go to the 14?
We have to go to 3, 7, 14 for anything. That is very clear, because the tolerability otherwise will be a problem. The GI symptoms will generally cause trouble when you start with this drug. There is a very significant incidence of nausea and other difficulties, which you have to come over, explain to the patient. We don't recommend, I don't think anyone on this panel who are more educated than me on diabetes will recommend a direct 14 milligrams hit. As far as first line drug for reduction of weight loss, well, it is not given as a standard indication. Whether you want to use it as an off-label indication, I mean, it's up to you. In a diabetic patient, yes, you are justified in using it. In a non-diabetic, this is the first data that I have seen, and obviously people have taken the cue from SGLT2 inhibitors in heart failure situations, where they found that in diabetics and non-diabetics it was equally effective, and that is why this trial has been conducted. The good thing is that hypoglycemia has not occurred, and whether or not we should use it as treatment of obesity will be your personal choice. There is no guideline directed recommendation for semaglutide as yet. At least that is what I know, but I have more experts on this.
I agree, sir. Semaglutide is not approved in India for weight loss reduction as yet.
So actually, the ironical thing is that oral semaglutide is, the molecule is the same. That's approved in India for diabetes management. However, the injectable form, the 2.4 milligram, is already approved for weight loss in the country but unavailable. So the generic molecule semaglutide is approved in the injectable form for weight loss, currently not available. Maybe in the near future we'll get it. But on a scientific forum, we can't say that, okay, we can go ahead and use that. As sir very rightly said, off-label use of the drug can be done, but that's at an individual's off-label kind of label.
The confidence comes from this heart failure preserved EF trial actually, because that was entirely in non-diabetics. You know, so you can take your own cue out of it. I'm not going to recommend anything.
And sir, just to add, oral semaglutide 50 milligram is under trial for only obesity management, and the results
25 and 50, the trial is already published in NEJM. And what sir just said about the heart failure part, the trial on the MACE reduction, the cardiovascular outcome, the SELECT trial was recently presented. A 20% reduction in non-diabetics of 2.4 milligram semaglutide for 5 years, 20% reduction in their cardiovascular outcomes. So that's astounding. That's really astounding.
Sir, last question. We are running short on time. Last question.
Okay, okay.
We are short on time. Thank you everybody. Thank you, sir. We'd like to, I will conclude this session now. We would like the speakers and chairpersons to proceed to the felicitation desk. I request Dr. Rajiv Lochan, sir, to do the honors, please.
On his behalf will be joining us. First of all, I would like to welcome our chairpersons on stage, Dr. Manoj Kumar, Dr. B.K. Tiwari, Dr. Mukesh Mehra, Dr. L.H. Ghotekar, and Dr. Samir Kubba on the stage, please. Thank you so much. I would like to invite our speaker for today, Dr. Vijay Kumar. Dr. Vijay Kumar is the Director of Interventional Cardiology at Fortis Escorts Heart Institute. Over to Dr. Vijay Kumar. Thank you so much.
Good morning, everybody. First of all, thanks to the Physician Association of East Delhi. And on a Sunday morning, I would like to share some of the recent breakthroughs that are essential for all of us to be updated so that we provide better advice and better management to our patients of advanced or complex heart diseases requiring surgery or intervention. So in the last 2 decades, or in the last 1 decade, I would say that intervention cardiology has taken a great feat, and a lot of new breakthroughs have been seen and which have been launched in our country as well. And that has taken the treatment of cardiac illnesses to the next level, the minimalistic era. In the minimalistic era, we have a great role of intervention procedures to handle almost all kind of heart diseases. So I would go one by one through the various things that have happened in the recent years, a change in terms of treatment, in terms of diagnosis, in terms of lifestyle or lifelong management of certain heart conditions. So in the screening front of coronary artery disease, especially till now we were doing angiographies, and we were having very situations where it would puzzle whether a blockage between 50 to 90% is worth doing any invasive procedure or needs revascularization or not, whether the patient comes with an acute MI or whether a patient of unstable angina has multivessel disease. And some of the lesions may be looking very critical, some of the lesions may be looking intermediate types. So here is the role of studying coronary physiology by either hyperemic mechanisms or by non-hyperemic means. So we have pressure wires, special wires. These are measuring the pressure distal to the stenosis and the proximal to the stenosis, and the ratio is called fractional flow reserve. And then there will be a non-hyperemic method in which instantaneous diastolic wave-free ratio or flow is measured, and then a full cycle flow is also measured, the pressure ratio is also measured, so which is called RFR. So FFR, RFR and IFR, you measure when you have done the angiography and you find an intermediate kind of lesion, or if you have done treated a culprit vessel and if you have the other vessels which are looking not very significant, or you are feeling that it would require. So you can do these tests through pressure wires, special pressure wires, which will study the coronary physiology. And if the values are less than 0.8 or 0.89 on RFR and IFR, it will conclude us, or it will guide us to do revascularization. So this is a new change or new concept. You don't need to keep these patients or send these patients for a stress test or a non-invasive test once again after the patient has undergone his index procedure. As well as in a multivessel disease scenario also, the patient, it is easy for the physician to decide, because putting stents in every artery or in every diseased segment is not the right way to treat. You can treat only the lesion which needs revascularization, and this is a very important tool to manage multivessel coronary artery disease. Now we do CT scan and we do CT coronary angiography. Now very recently softwares have come. In our country also the softwares have been brought, but there's a learning curve to it, that a patient has his CT coronary angiogram and the same FFR can be done through CT scan, and you will have pictures like this which will show that yes, there is a significant disease in one of the arteries or in one of the segments, and this would not need even hospitalization. And probably in the times to come, as this imaging tool learning curve is improved, we will have patients going not requiring an invasive procedure, and we will have the diagnosis done just through a CT scan and plan for the intervention of the patient for targeted vessel. Then coming to the next advancement that has happened in the imaging field of coronary is the intravascular imaging, or IVI. There are a lot of tools: intravascular ultrasound, then optical coherence tomography, OCT, and then in near infrared spectroscopy. These are very, very important tools that have been used, that have become very prevalent in use, and it should be known to all of us as well as the patients. The awareness should be there that these tools have been made to improve the outcomes of intervention, optimize the results of stent implantation, and in the follow-up, if these patients, if these stents fail, these tools are very helpful in deciding what was the cause of the failure, whether there was restenosis or whether there was under malapposition of the stent, or there is a thrombus which has choked the stent. So, and then in different situations where some patients may need contrast, some patients may be completely requiring a zero contrast or minimal contrast during these procedures. So intravascular ultrasound is one of the methods, one of the tools which does not require a contrast to be given, and you can complete the entire procedure of a chronic kidney disease patient with the help of this tool. And this is very important for the left main, where the measurements may visibly be appearing something to the patient, something to the physician or the interventionist, but when you do left main intravascular ultrasound, you get to know the actual size of the left main and the left anterior descending artery or the circumflex artery, and the right decision of the choice of size of stent is made. And when you have done the implantation, you can see whether these stents are well apposed or not. Then these tools also help in detecting the various pathological severity of the stenosis, whether it is a fibrous plaque or whether it is a mixed plaque or whether it is a heavily calcified plaque or whether it is a fresh thrombus or an old thrombus. So intravascular ultrasound is contrast without a contrast test, and in optical OCT you need a contrast, and in near infrared spectroscopy again you don't need any contrast. So these are important imaging tools from diagnostic to therapeutic and point of view in coronary intervention. So now there are gadgets which are coming up which are going to combine these gadgets, these various tools to still further refine the interpretation of your lesion pathology and your outcomes of the stent that you have implanted. So which tools to choose for particular condition? These are more important for the interventionist. He has to decide whether intravascular ultrasound is needed for a patient or whether an OCT is needed for a patient. When a patient comes or when he has done an angiogram, then one of these tools can be picked up to decide whether what tool he has to plan his angioplasty or stenting procedure. These tools are very important. Sometimes we get patients with acute MI and young patient and has just thrombus or just a minimal a plaque rupture or a plaque erosion. So these tools like NIRS and OCT, they can be used to detect whether there is plaque erosion or just a plaque rupture or there is a frank thrombus. So, and that will decide whether you will put a stent in that patient or not. So these are important tools in the management of patients coming with myocardial infarction with non-obstructive coronary artery disease. So these tools of imaging are very important. These are some of the examples where this 69 years gentleman comes with stable angina and has dyslipidemia. You do intravascular ultrasound, and these white arcs you can see, they are how calcified, and that describes the lesion and your planning that you have to do for these patients. These are some OCT images where you can see a thrombus and then decide that the cause of the ACS was thrombotic lesion. And then you can see how thick the fibrofatty plaque is there where there is hardly any calcium, and then you can manage this plaque with a special cutting balloon. So the choice of tool that you will use for the intervention, or whether what diagnosis you will made, or how will you define your lesion, these are very nicely done with these imaging modalities. Then this is at the end of your stenting procedure, you can see how the struts are well opposed to the intima, and if it is mal opposed, then you can do further post dilatations, and that's how you optimize or expand the stents to the full. And this is a OCT view of a bioresorbable scaffold where you see the struts like this, they are well opposed, and so you are satisfied with the end of procedure, with the result that you have achieved. This is a image near infrared spectroscopy. These tools are still to become common in practice because most of the time the OCT or the IVUS is used. This is more into research based institutes. So I personally don't have the use of the experience of this near infrared spectroscopy imaging modality. So in these ACS lesions, as I was saying, you can have plaque rupture or thrombus or ulcerations. These can be better diagnosed with OCT, and the decision for putting a stent versus just putting on medical therapy can be made on the table. And this is how the landing zone of your stents, where you will start and where you will end in the left main or in any particular vessel, can be decided by intravascular ultrasound. So this is these white arches which you see are the calcium tools, which are more than 180 degree, and if you get such images on the ultrasound where the thickness of the calcium is more than 0.5 millimeters, the arc is more than 180 degree, and the length is more than 5 millimeter, then you decide special tools, and you have to tell your patients that yes, you need special tools which will imply cost of the procedure to give the best results to the patients. So this is an example of another intravascular ultrasound imaging which was done for a very heavily calcified lesion, and it was and he was a very sick patient where we had to take impella support and complete the procedure. So such patients don't need contrast load. They are very sick patients, and intravascular ultrasound can be used using almost a very small amount of contrast to complete the procedure in the best possible way. And this is an example how a patient who undergoes very good procedure, the third picture where my cursor is showing, you had a very good result, and then 5-6 months later when he comes with a restenosis, and here you see that there is a lot of fibrofatty plaque that has grown in, and this patient will need special scoring balloons or cutting balloons to cut the plaque and then do some drug-coated balloon kind of treatment or a restenting. So OCT is very important in detecting the cause when the patient's stent fails. So you have to understand your patient that there are tools which will be used if they are coming for the second procedure, or if they are coming, or if they are having multi-vessel disease where we have to diagnose. So basically there is we have seen that there is lack of awareness amongst the physicians as well as the patients that there are certain existing tools of imaging modalities or coronary physiology assessment which are important for the outcomes and which are important for the reason for finding the etiology why the patient comes with recurrent restenosis or thrombus formed in the stent. So this is an example how very late stent thrombosis happened in one of the patients who discontinued all his antiplatelets, and it occurred at the junction of the two stents which were opposed with each other. Now these are the advancements that have happened in the calcium modifying tools. Rotablation has been, atherectomy has been there for long, but there has been newer innovations and newer advancements. So we have now rotational atherectomy, orbital atherectomy, where the movements of the burr are different from the rotational atherectomy. Then there are special ultrasonic balloons which are called lithotripsy balloons. These were first used for treating peripheral vascular disease. Now they are being very commonly used for coronary artery disease with heavy calcium of more than 180 degree, but it allows, or it's a crossable lesion where you take this balloon and crack the calcium and make the vessel more compliant and more accommodative for the stent. And then some patients come with total occlusions, stents occluded with restenosis or barely any very small channel, and you cross these chronic total occlusions or instant restenosis lesions, and with slow movement of special burrs which have laser physiology, and that cuts the tissue gradually and makes the space for the next procedure once the previous stent has failed. So these calcium modifying tools are very much useful in treating difficult complex lesions, either calcified or stent failures or stent within a stent coming with restenosis, and the imaging tools of OCT and IVUS are very important. Then this is an example how the intravascular lithotripsy can treat a peripheral vascular disease and break the calcium and make the possible to implant stent, or even the recent structural intervention of transfemoral TAVI. We have increased, or we avoid the alternative pathway even with the help of intravascular lithotripsy balloons, which have been used to treat diseased femorals and iliacs and take the large catheters to them also. So next advancement that we see, that we can now treat the most sick patients that we see who have poor ejection fraction, who have sole surviving vessel, who are redo surgeries with single surviving graft, or left main unprotected with severe triple vessel disease. These patients will need hemodynamic support during their procedure, and we have the conventional intra-aortic balloon pump for the lesser riskier patients, but patients who are really sick, they need temporary mechanical support, which is called impella, and that is parked in the left ventricle, and it's a special catheter with a motor pump that draws blood out of the LV and it distributes into the aorta and the vital organs and prevents the vital organ flow to decrease or the cardiac output to decrease, and it can increase the cardiac output up to 5 liters. So all these difficult interventions which need protection, they can be helped, they can be performed with the use of these backing or these mechanical circulatory support systems. Most of these are surgical turn down cases, and this is an example of a lady who came to us at 81 years. She had her first rotablation based atherectomy based PCI done to the LOD. Then 1.5 years, 2 years later, she comes with severe moderate aortic stenosis worsening to severe, and then in the second slide, her transcatheter heart valve was implanted in the aortic position. Then again, I think 2 years, or last year she was 88 then, and she came with non-STEMI and cardiogenic shock. And then we performed impella supported crossing the large cells of this this Evolute R valve and doing a rotablation based PCI and treating her left circumflex and left main to LAD. So, and this lady is still surviving and she is doing well. So this is only possible with the recent advancements of all circulatory support systems and the new valves that are coming up. So mechanical circulatory support system is temporary support to destination therapy. Patient may be supported with impella, IABP, tandem heart, or an ECMO. And there are different devices which help in maintaining the cardiac output of the patient in a shock situation or in a situation where the patient is surviving just on a minimal coronary vascular, minimum coronary blood circulation. So this is the picture of VA ECMO where the right atrium blood is transferred from the right atrium to the aorta, and the cardiac output is maintained up to 7 liters. And then coming to the advancement, the biggest advancement of the last 1 decade, I would say, or last 2 decades now, 20 years of celebration has been done for both mitral as well as aortic therapy. We have an armamentarium of valves. The first section of valves which are available, and the next section are polymer-based valves or single leaflet valves which are in the pipeline and may change the complete concept of tissue-based valve therapy in the coming years. So this is an important, today we don't need open heart surgery for especially high risk and intermediate risk patients, and the indications are shifting to the low risk patients with better valves. A person today can think of living till the age of 97 or 100 only with the help of these recent advancements. This gentleman had his transcatheter aortic valve replacement done despite a difficult anatomy, thanks to the transcatheter valve therapy TAVI and the hardwares that are available to do these procedures safely. The cerebral protection device system, you can see the upper arch. This is called the Sentinel cerebral protection system, which prevents the stroke from happening, and the valve was deployed in that gentleman, and he goes home the next day itself after the procedure. And now redo surgeries don't require, most of them, if you have a tissue valve, you can, and if they degenerate within 10 years or 15 years of time, they can be managed with a valve-in-valve therapy, and both at aortic position as well as mitral position. So these are examples how surgical tissue valve failure can be also managed very easily. And these are non-invasive procedures done under conscious sedation. And then mitral clip is the next thing that has come for managing the functional MRs and the degenerative MRs. And some of these patients who have had valves, either the transcatheter aortic valve with a moderate or severe mitral regurgitation, and their mitral regurgitation did not improve, they have been managed at a second stage by 1 or 2 mitral clips. And another difficult anatomy is mitral annular calcification, which is, we are going to start a trial where intravascular lithotripsy will be used to just break the calcium of the mitral valve leaflets and manage the mitral stenosis or the mitral stenosis mixed lesions. And then this is the no option situation where anticoagulation is a major contraindication to a patient, and you still have the risk of thrombus. This is the left atrial appendage closure system. We have the Amplatzer device experience. Watchman has also been launched in our country and will be very soon used in most of the centers. And we measure the left atrial appendage through echo as well as transesophageal, and CT evaluation is done, and then the device is fixed under transesophageal guidance. This is the example how the left atrial appendage was closed for one of our patients. And this treatment of heart failure, now interventional treatment, most of these patients are either with reduced ejection fraction or with preserved. So the ones which have functional regurgitation, they are treated with mitral or tricuspid edge-to-edge repair, which is now picking up in our country as well. And then valve replacements have also started in the abroad, and very soon they will be launched in our country also. And some of the examples, mitral clip is very useful. The COAP trial has...
Can you please hurry up? The time is up. Sorry for the intervention. The time is... Can you please hurry up little?
Beg your pardon?
Can you please hurry up, sir?
Yeah. 20 minutes. So these are the mitral clips which have been used, and this is how we have treated mitral regurgitation with 2 or 3 clips in a patient. And similarly, the tricuspid regurgitation also, patients who have no surgical option can be treated by coaptation devices or heterotopic caval valve implant. This is the patient who has been treated with a trick valve, where the regurgitation reflux is prevented to affect the hepatogastric system. And a tri-clip is similar to mitral clip, which can be used to clip the leaking tricuspid valve. And the registry is also having various kinds of treatments available for tricuspid regurgitation. These are some of the imaging methods. And the most important message through this is there are unbelievable breakthroughs which can manage every cardiac condition, but it has financial implications and definitely social implications as well. But at the same time, awareness of both patients and physicians is important.
Dr. Bijay, please conclude.
Yeah, thank you. Yeah.
Sir, please conclude your session.
Yeah, this
and
is
then
my, I think it was 25 minutes.
we
if
will
I've-
take few questions from the
Yeah,
audience also.
Yeah. So my conclusion is there are a lot of breakthroughs which have been happening or which have happened in the field of intervention cardiology, and they can treat most of the sick patients. Especially valve therapy has picked up as the latest. So I'm open to any questions or any queries.
Yeah,
in the
I have
minds
one
of
question,
audience.
sir. Can you just elaborate a little more about drug-coated balloon basket 2 small trial? How it can be beneficial for the small artery occlusion compared to the angioplasties?
So drug-coated balloon, we have two kinds of drug-coated balloon. In the recent 2023 trials, there was a trial which has a negative result, especially for the sirolimus-coated trial, but the paclitaxel-coated drug-eluting balloon or drug-coated balloon has good results, and they are useful for restenosis situations, or they are useful for side branches, and they are useful for long and small calibered vessels.
So today we had a very good interactive sessions, and from the Dr. Sethi to Seth, we all become rich now in the cardiology. So.
Yeah, now we have two interventional cardiologists here. I think Dr. Manoj and Dr. Kuba actually.
Dr. Vijay, very nice presentation, and I will congratulate you. In very short time, you presented all the new addition in the intervention cardiology. Initially, it was only angioplasty and device implantation, but now the expansion has gone. One very old cath lab joke is there that if you want to intervene in intermediate lesion, go for IBUS. If you don't want to intervene, you want to leave the lesion, go for FFR.
Yeah.
And this is our also practical experience that whenever you do IBUS, you find that the plaque is very aggressive and your mind tilted towards your going intervention immediately. And sometimes also there is a disparity between the result of FFR and if you repeat stress thallium or stress echo, it came to be positive. So what is your take-home message for this situation? And how much you agree with this joke that FFR, you avoid intervention, IVAS, you go for intervention?
So absolutely, Dr. Manoj, you are right. The sensitivity and specificity of these tests are not very high. They are, I would still say that they are lesser or they are non-inferior to stress thallium if you compare stress thallium with these invasive tests which you do on the table. You have to make your clinical judgment at the end. If you have a multivessel disease, if you have treated the most significant lesions, and if you have a disparity between a pressure wire versus an IVUS, then if your visibility to the IVUS is looking significant in a important vessel, then I think you should intervene it. That's the practice that we follow.
I think what has happened, a very good presentation, Dr. Vijay, you covered everything, and I think what has phenomenally happened in last few years is tremendous development in structural heart disease interventions. So many of the patients who were sent for surgery, they can actually avoid. Dr. Vijay, I would just like you to dwell upon the topic for the interest of the audience, especially for TAVI in moderate risk patients. Initially, it came as a therapy for patients who were turned down for surgery, very old patients, lot of comorbidities, the STS score being very high, the Euro score being very high, and patients will not tolerate surgery. But the partner trials and the recent trials have shown that even for patients who are relatively okay and don't want to undergo surgery, how do you counsel them? Because ultimately it's a tissue valve. What are its long-term aspects about anticoagulation? So suppose a patient who is 60, 65 years of age, has severe AS, doesn't want to undergo surgery. How would you go about it practically for the interest of the audience?
So you will have, you are sitting in your OPD and a 62 or a 65 years aged person comes with his echo report showing severe aortic stenosis, bicuspid valve, heavily calcified, and he has no other risk factors, and he has heard of TAVI and he says that mujhe to TAVI karna hai. So in a person like this who has bicuspid valve, 60 to 65 age, severely calcified, I would still advise him that surgery is the first choice, because these young patients, they have to understand, or they have to be told, that aortic stenosis is a lifelong management of lifelong for the patient. Lifetime management of aortic stenosis has to be considered, which you have to explain him that if you undergo in such a heavily calcified lesion where surgical results would have an edge, or even if the transcatheter valve therapy has equivalent result, there are still certain challenges like sizing challenges, like paravalvular leaks, the risk of having a pacemaker, the risk of their coronary future revisits, or the coronary at risk of getting occluded by a calcium chunk or by the leaflet. If these things are challenging, and they are going to end up having complications for this patient. So if you have a heavily calcified bicuspid sitting in your OPD, you should tell him that yes, TAVI is there, but you are quite young for this, because we don't have still the data for valve-in-valve failures, and what will be the outcome if a patient is going to have 3 or 4 valves in his whole life. So they should be counseled that they should have surgery as the first choice. And if there is a patient who has this kind of anatomy and he has numerous comorbidities, then yes, you are absolutely right in advising transcatheter TAVI for him. But if you are having a 70 plus or 75 plus or an 80 plus, even low risk of 70 is not the same as low risk of 50 or 55. 55 bicuspid, you can never advise TAVI for him. But 65, heavy, high risk, low risk, and bad anatomy, surgery is the choice. And 70 and above, if you have patients who have severe aortic stenosis, they can be advised TAVI, taking into considerations different aspects and explaining them that yes, these are the risks, and we will take care of the risks so that the chance of these risks are minimum. In case of moderate aortic stenosis, you have to follow these patients up by periodical echoes, and then once the patient and moderate aortic stenosis symptomatic, then you can consider a TAVI for them as well, because a person, if he doesn't have any coronary artery disease or any other reason to explain his symptoms. So this is what I would be doing in my OPD.
Thank you, Doctor, for a wonderful talk and outstanding answer from your side to audience.
Yes.
No time. So now we conclude the session, and
we can ask 2 questions. Dr. Makkad, please.
Okay, thank you. So I would like to go back to, sorry, Dr. Tiwari.
Not at all.
Would like to go back to the concept of IFR and FFR. Now my question is, this to stent or not to stent has always been a question in the minds of the physicians, and of course in the minds of the patients also. Now that IFR and FFR are available, are these, my 2 questions are these a part of the standard angiogram reports that you have an IFR and FFR? If not, why not? And should it be a part of the routine angiograms, because it helps you make a black and white decision on whether to stent or not to stent, because it very clearly said if it is 0.89 you treat, or less than that or more than that not to treat.
So it has still not been clubbed, because it, number one, it's going to be costing to the patient, because it has to be a new package for the patient, an angiogram, just doing an angiogram. And if you have a multi-vessel disease, you will definitely, if there is an intermediate lesion which you feel that to stent or not to stent, then we speak to the patient, and then we do the coronary physiology study and attach the result with the angiogram. That is done, but not as a package, as a part of every angiogram case.
So shouldn't it be a part of the package?
So if something is very clearly 90% and a single vessel disease, there's no need to do an FFR or an RFR for such a patient. FFR and RFR are indicated only when there is a multi-vessel disease, or if you have a single vessel disease and his symptoms are ambiguous and it's an important vessel or an important segment of the vessel, then yes, you decide to do a flow study, pressure study, pressure wire study, and then attach the result, not as a part of package.
Okay, fair enough. Fair enough. Thanks.
Calcium score?
No. Statins have to be taken, that's all. Otherwise, there's no specific drug which dissolves the calcium.
Sir, I was going through the chapter that they say that weight reduction, exercise, they all are responsible in reducing the calcium score. But then why athletes have more calcium score?
So it's athletes have calcium score. I'll have to check, because at the end, atherosclerosis, if somebody has a tendency for more atherosclerosis, the pathogenesis of calcification is change in the same atheromatous plaque over a period of time. So there's nothing specific that athlete has more calcification, and a person, it all depends upon the tendency or a genetic makeup of the person, whether he has dyslipidemia, whether he has a tendency for atherosclerosis or not. It's calcification is a degenerative process of the same atheromatous or the same atherosclerotic pathogenesis.
Dr. Vijay Arora, to answer that question, my few thoughts is, calcium is not always an intimal calcium. It can be an adventitial calcium also. Sometimes you see a lot of calcium on the CT angio. Even when we do a coronary angiogram, we see tram tract calcification, but the coronaries may be clean. So an adventitial calcium is separate from an intimal calcium. And even if you look at the CT angio, at times you look at a high calcium score. The meaning of calcium is basically some sort of injury would have happened to the intima at some point of time, and the response of the body is to heal it. And the initial stages may be a fibrofatty plaque or a calcium, but later on it can change. So what we are trying to say is that every calcification may not be an intimal calcification. It could be medial, it could be adventitial. We have seen certain elderly patients, when we just take them for an angiogram, we put our foot on the floor and we see a lot of tram tract calcification. But when we do an angiogram, the lumen is absolutely clean. So, and regarding that study on athletes, we'll have to go into the details of that what exactly was the profile of those athletes. We have athletes' heart also. We have patients who are athletes having hypertrophy of the heart, bradycardia. So there are many things which are happening in the coronary physiology. So I think we must distinguish between the area of the calcium and its physiological importance.
So I think last comment from the hall, because we are physicians and we are seeing a lot of young deaths, right, recently of late. So just a quick, pointers to that, because how we can prevent this young deaths that's happening actually, and any intervention, any prevention that we could make it out. Dr. Manoj, you want?
We have all noticed that almost 30% increase in the incidence of myocardial infarction in last 3 years. One of the cause is definitely COVID, because COVID is an inflammatory disease. It has eroded the endothelium of all vessels, including coronary arteries. But at the same time, the emerging risk factors other than the conventional risk factor, diabetes, hypertension, hypercholesterol, or this age and positive family history, the sedentary lifestyle. Today I have published an article in the Times of India that sedentary lifestyle is one of the most strong risk factor in 21st century. And lot of studies has shown that the stress, sedentary lifestyle, the newer risk factors, especially young, because there is a study which has shown that the persons born after 71, they have a very high risk of coronary artery disease. This is just because they are unaware, they are callous for the control of the risk factors. Definitely, every 30 seconds there is a heart attack case in our country, and it is very pathetic information which I am sharing, that 25 to 45 years age group is now mostly involved in this epidemic of heart attack, and especially after COVID. Definitely ICMR study shows that there is no relation between the vaccine and this heart attack, but definitely COVID disease itself, it has inflamed the vessel. Thank you so much.
Thank you.
Thank Dr. Vijay for wonderful presentation. I think you have covered every aspect, right? Physiology to intravascular imaging to valvular replacement and all. I think round of applause for Dr. Vijay Kumar for a wonderful presentation. Thank you very much.
After this enriching session, I would like to request the speaker and the chairpersons to proceed towards the felicitation area, and Dr. Lalit sir for the felicitations. Now, I would like to proceed for the next session on gastroenterology. I would like to invite our chairpersons, Dr. Shubhashish Mazumdar, Dr. Kunal Das, Dr. Vibhu Mittal, and Dr. Sanjay Mahajan on the stage, please. I would also like to invite our speakers, Dr. Naresh Agrawal, Dr. Nitin Gupta, and Dr. Ramesh Garg. And I would like to request Dr. Kunal Das to introduce our speaker, first speaker, Dr. Naresh Agrawal.
Thank you. I would like to welcome Dr. Naresh Agrawal.
Sorry for interrupting. If some lovely lady has lost a bracelet, we have found it and you may come to collect it.
Welcome to the gastroenterology session. The first speaker is Dr. Naresh Agrawal. He needs no introduction into the EDPA circles. He is a senior consultant and assistant director at Max Super Specialty Hospital, Patparganj. He has done his MD and MBBS from SP Medical College, Bikaner, and DM Gastroenterology from JV Pant, Delhi. He is founder of Rajasthani Gastro and Liver Center and has over 22 publications in various index journals. Faculty in various international and national conferences, and we are going to hear about endoscopic ultrasound from Dr. Naresh. What are the recent advances? As you all know that endoscopic ultrasound is a very, very common procedure, and it is very useful in biliary-pancreatic diseases. And Dr. Naresh will tell us about the recent advances that has happened in the field.
Good morning and welcome to all dear colleagues for sparing time, and special greetings to the organizers who have been working hard. I have observed myself day in, day out for last many days to make this conference, wonderful conference, success. So when I talked to Pankaj, he told you should talk nothing other than innovations. And we'll be talking about innovations in gastroenterology, and we'll be not talking of experimental modalities, only for innovations which are in regular clinical use. So I welcome my chairpersons, Dr. Vibhu, Dr. Majumdar, and Dr. Kunal Das, and be wrapping up in 10-12 minutes about endoscopic ultrasound. So the innovation was to combine ultrasound and endoscopy. So the probe of ultrasound and the equipment of endoscopy combined makes it as endoscopic ultrasound. In endoscopic ultrasound, we have ultrasound introduce transducer at the tip of endoscope. It's just like an endoscope. We introduce in the lumen of esophagus, stomach, duodenum, and it gives us endoscopy picture plus ultrasound picture. And initially, when we were doing internal medicine and DM, we used to study in our books what is the best modality for CBD stone, and this was an MCQ question in our DM entrance, that EUS is the best modality. And it was the introduction that age. After that, it has grown so much that now in 2021, we have guidelines in various societies, established guidelines, and this is an integral part of any tertiary endoscopy center. And we have multiple studies. This has evolved enormously and is in the guidelines and diagnostic as well as therapeutic modality of choice, first choice for many diseases. This is the spectrum which usually includes for endoscopic ultrasound. It can visualize like never before bile duct, mediastinal lymph nodes, masses, pancreas, pseudocysts, pancreatic cystic neoplasms and vessels of mediastinum and upper abdomen. Common diagnostic and therapeutic uses are the biopsies of mediastinal lymph nodes, which can be done nothing better than endoscopic ultrasound, and the yield is more than 90%. CBD stones, even the sludge or small particles can be visualized by endoscopic ultrasound, and there is no other modality which can see CBD stones or sludge in the CBD as a cause of pancreatitis better than endoscopic ultrasound. Pancreatic cystic neoplasms, these are the lymph nodes, and these lymph nodes are just in the adjacence of the transducer. We can see so well these neoplasms, even MRI or any other scan cannot see, and we can see the echogenicity of these lymph nodes. If there is mild necrosis also, that can be seen. And most important, we can have a Doppler to see the adjacent vessels to make it safe, and we can take biopsies. So this needle is the needle of FNAC or biopsy which is taken from lymph node. Then large bile duct stones. This is a small stone, 3 millimeter stone, which can be seen in such a magnified way by endoscopic ultrasound. Pseudocyst. This is a pseudocyst, and this can be seen in such a beautiful manner by endoscopic ultrasound. It can be drained in the stomach. Then small early cancers of mucosa or submucosa of GI tract, esophagus, stomach, duodenum can be seen beautifully, and they can be staged. We can see the layers of intestine, and this layer, the submucosa layer is seen, and after that the muscularis propria, and we can stage them that the tumor is in the T1 stage, and we can plan for endoscopic therapy. Then the other use is gastric fundal varices, which is a common finding in portal hypertension. They can be dealt with by coil embolization, and we can avoid the risks of glue and reducing the dose of glue. It can be managed very well. So talking to sensitivity and specificity about bile duct stone is more than 90%. About the sludge, it is more than 92%. So I'll have a liberty of playing a video. Can we play that video, sir? So I'll just fast forward it. This is a large pancreatic fluid collection. The names have changed, the terminology has changed, and this F in the green color is the transducer, and whatever therapeutic modality is done is through this port, and this is the fluid collection. In the icon lower right part is the endoscopic image. This is the impression in the stomach. So we will puncture this cyst by an accessory. So this is the puncture, and this opening flanges are the stent which is placed in the cyst, and the other part of the flange is deployed in the stomach. So there is a lumen opposing stent. The lumens of the cyst and stomach are opposed with each other with a small stent which is placed beautifully, and we have a Doppler to make it safe, and we can avoid bleeding, which was a common risk before this. And after that, there is a gush of drainage of this fluid. This is usually a pancreatic fluid rich in amylase. So the particular advantage is that this is minimally invasive, can be done in outdoor procedure, and it avoids the risk of bleeding. Absolutely, there is no bleeding in such cases. And the major benefit of this is that before this we used to drain by percutaneous puncture, and these fluids are rich in amylase, so there is an external fistula which usually does not get healed and takes a very long time. In this way, we can drain it in the stomach, and there is an internal fistula, so this is naturally drained. Can we play the other video? So this is another small video. So I have still 3-4 minutes left. see the anxiety on Dr. Pankaj's face. Doesn't matter if it does not play. Okay? Chalo, leave it. So because of short time, we will not waste our time here. PowerPoint. You leave it, I will do it. So, another patient, we had a CBD stone, I already discussed. These are the pictures of the cyst, CT scan pictures of the cyst which we drained by endoscopic ultrasound. So we can see the stent here. This is a stent placed between the stomach and the cyst. So this cyst is already almost compressed, decompressed. After 2 to 3 weeks, we can remove the stent and patient is cured. Another innovative procedures which can be done by endoscopic ultrasound are EOS guided cholecystogastrectomy. In select group of patients, cholecystectomy is very difficult, like patient is very morbid, hemodynamically not stable, is in gangrenous cholecystitis or sepsis or multi-organ failure. Endoscopic drainage of gallbladder can be done. EOS guided gastrojejunostomy in terminal malignancies, there is a pyloric obstruction and patient is unfit for surgery. We can make a gastrojejunostomy by endoscopic ultrasound. Celiac plexus block can be done, or celiac ganglia block can be done in terminal malignancy with refractory pain. Select patients for liver biopsy and vascular embolizations. These are some of the new uses, and the uses are still exploring and developing. Biliary procedures are now in common clinical use. Rendezvous procedures, some difficult cases of ERCP, we cannot find papilla or papilla is strictured. We can have access of common bile duct, and we can avoid morbidity of percutaneous biliary drainage, which is obviously a morbid procedure. This is called the rendezvous procedure. So I'll wrap up my talk here. By this quotation by a great person, the real power of technology is in the ability to empower people what they want to do. We can have a lot of ideas in our mind, but innovations is to make that practically possible. And this Scott Belsky is the head of a well-known Adobe company. He is the well-known person for R&D of these companies, that it is not the ideas, it is the ideas to implement the practical science. Thank you so much for it.
Thank you, Dr. Naresh. It's open for questions.
You can take questions later.
Okay.
Our next speaker is Dr. Nitin Gupta. He's a senior consultant in the Department of Gastroenterology, Rajiv Gandhi Cancer Institute. Dr. Nitin, this is MDBS and MD from Maulana Azad Medical College and DM from GV Pant Hospital. He was awarded gold medal in MD, and he has numerous publications and chapters, API books to his name. And he will be speaking on third space endoscopy. Here we talk about first space, which is the lumen of the gut, second space, which is extra lumen. Now we are taking the endoscope into within the wall of the gut. So Dr. Nitin will be speaking on third space.
At the outset, I would like to thank EDPA and especially Dr. Naresh for giving me an opportunity to be here. I'll be talking about something which is new, as he said, innovations in endoscopy. Majority of us would not be knowing about what third space endoscopy is, so I'll just start with the basic concept of what is third space. The standard endoscopy or the first space is doing an endoscopy in the natural lumen of the GI tract. We are all aware about it. We know what is done through it. In late 1990s, the endoscopists, they try to become surgeons. What they did was they started puncturing the GI tract. They took their scope into the peritoneum and started doing procedures there. And that is what was the second space of endoscopy. Natural orifice nodes. So doing liver biopsies, cholecystostomies, even appendectomies were done by puncturing the GI tract going to the organ, performing the surgery there, and coming back. So this was what was called as the second space. But because of a number of complications, this really went out of favor. Until recently, about in the first half of this century, endoscopists realized that there was another way of going beyond the lumen. What they realized was, if they could inject fluid into the submucosal space. Now the submucosa is 1 millimeter thick. By injecting fluid into the submucosal space, they could distend that submucosal area and make it into multiple centimeters. Then after incising the mucosa, they could actually get their scope into the submucosal space and do endoscopic procedures there. And this is what is called as the third space of endoscopy. Doing endoscopies in the submucosa and performing therapeutic interventions there. And this brings us to what are the basic steps of performing a third space endoscopy. The first is you create a mucosal bleb by injecting saline or other fluids into the submucosa, distend the submucosa, give an incision into the mucosa, make an entry point, and then get your scope inside into the submucosal space. Once you have got your scope into the submucosal space, then you start dissecting the submucosal tissue. Now the submucosal tissue is actually a fibrofatty tissue which is expansile, other than, different from what the muscle is. You can actually keep on distending it after putting in fluid, and then you can do your endoscopic procedures there. The third step is performing the therapeutic procedure, the real aim of this procedure. Performing the therapeutic procedure while your scope is in the submucosal space, and then once you have done that, you come back and close the mucosa so that you do not create a perforation. So this closure of the mucosal flap that you have created is the one which helps you to do these procedures safely, and this is the premise of the third space endoscopy. Various third space endoscopic procedures are dependent on what kind of therapeutic procedure you are doing. And the most common third space procedure that we are doing the world over is the per-oral endoscopic myotomy. So what is per-oral endoscopic myotomy? It's a third space procedure going into submucosa, and your intervention is cutting the muscle. Now this can be done for achalasia, various motility disorders of the esophagus, for gastroparesis, and also for diseases like Zenker's diverticulum. The difference is the difference in the type of myotomy that is being done. But the critical point is go into the submucosa and cut the muscle. That is what a POEM procedure is. Achalasia, we all know the pathology is in the failure of lower esophageal sphincter to relax and poor esophageal peristalsis. There are various types, I'll not go into the details. And this was the first time in 2006, Dr. Pankaj Pasrija, he realized that if I can go into the submucosal space and if I can cut the muscle fibers of the lower esophageal sphincter, I can probably treat achalasia cardia. And this was done in a pig model in 2006, and the results were successful. This was published in Endoscopy, and then it was taken over, and now more than thousands of procedures have been done. The steps remain the same. This is a schematic diagram. This is showing us, I'm sorry, this is not. So you can see the scope is going into the first step is you give a mucosal injection. So the first step is you give a mucosal injection, make a bleb, then you cut the mucosa, take your scope into the submucosa. Now this is the submucosal plane. This bright red color is the muscle. So you take your scope into the submucosal plane, dissect the entire submucosa right into up to the stomach, and then with the help of the knife, you cut the muscle. You can cut this muscle completely, go into the stomach, and when you come back, you seal this mucosal entry point with the clips, as you can see in this video. And this is almost an airtight seal with very little risks of complications. So this is the basic concept of performing a POEM procedure. It's usually done in a general anesthesia and in intubated patient. Thousands of procedures have been done world over now, and there have been reports of this procedure being done in neonates as well. High clinical success, more than 80%. The results of POEM procedure have been proven to be better than endoscopic dilatation. That was the first procedure that was done for achalasia, and now similar to surgery. I'll come to those. The most common adverse effect is development of reflux. Now, if you cut the lower esophageal sphincter, obviously the chances of reflux are high, and there are studies which have shown up to 25% patients have clinical reflux. Adverse events or complications not very common, and now they are becoming better and better, the lesser and lesser as we are becoming more confident about these procedures. The major drawback is a relatively long learning curve. Studies have shown that you might require up to 50 to 60 procedures before we can become confident in doing it. So, by the concept of achalasia, the treatment is cut the lower esophageal sphincter and decrease the lower esophageal sphincter pressure. The advantage in POEM over a conventional surgical procedure is, since it is an intrathoracic entry, you can actually tailor the length of amount of esophageal muscle you want to cut. So conceptually, it should be better than the surgical procedure, because in surgical procedure, you cut only the lower esophageal sphincter. However, with POEM, you can cut any amount of length of esophageal muscle as desired by the manometry. The other finding, the other thing is, obviously it's an incisional procedure, incisionless procedure. It should have a shorter hospital stay and probably a faster return to daily living activities. There is retrospective data which shows that the procedure time, the rate of adverse events, development of reflux, hospital stay, they are comparable in both surgery as well as POEM procedure. And this was the first randomized control trial published in New England Journal, where they said the POEM was comparable, non-inferior to surgery for achalasia. However, the reflux was higher. Now, recent guidelines published in 2010, they suggest POEM procedure is equivalent to surgery for achalasia cardia. So the question is, what do you do when you get a patient of achalasia? That's the question. So I would recommend get a manometry done. I'll not go into the details, but if the manometry suggests it's a type 1 or type 2 achalasia, either of the two procedures can be offered depending on the expertise. My thinking is, as over the years the POEM procedure will evolve better, the results of POEM are going to become better than surgery. In type 3 POEM, you don't have an option. POEM is the best procedure. So this is myotomy. The other option is, if you have a patient who has got a submucosal tumor, tumor arising from the muscularis propria. The same thing, you go into the submucosa, dissect the submucosa, cut the tumor from the muscle, and take it out. So this is what we call as submucosal tunneling and endoscopic resection. And studies have shown that various lesions easily up to 4 centimeters and sometimes more than 4 centimeters can be easily measured, treated by submucosal tunneling and endoscopic resection, and the complication rates vis-a-vis surgery are much less. Gastroparesis can also be treated similarly. You cut the pylorus and the distal enteral muscles, see the mucosa, and gastroparesis. The results are not as good, but yes, it's an evolving technique. Another role for third space endoscopy is Zenker's diverticulum. We all know the pathology of Zenker's diverticulum is a hypertrophied or a hyperactive cricopharyngeus muscle. So you can, what you do is give a submucosal injection, cut the cricopharyngeus muscle, the area which is believed to be the diverticulum point, and then you can stitch it with the help of the clips. The studies have shown you have almost 90% success rate with a very low adverse event rate compared to surgery when you do POEM for Zenker's as compared to a surgical procedure. The second most common procedure for third space endoscopy is doing an endoscopic submucosal dissection. Now the concept of a submucosal dissection is, suppose you have a cancer of the GI tract, which is an early stage cancer, limited to the mucosa. Why cut the entire bowel? You can go into the submucosa, dissect out the lesion, and remove the entire mucosal lesion, and you can actually have patients getting cured in early stage esophageal cancers. So this endoscopic submucosal dissection helps you to do an en-bloc complete resection of early neoplastic lesions of GI tract which are confined to the mucosal layer. With evolving techniques, now the amount of tissue that you can resect can be significantly large. You can see this lesion that we resected was of 11 centimeters circumferential esophageal lesion, and the patient is doing well. The latest NCCN guidelines, I'll just finish in a couple of minutes. The latest NCCN guidelines, as you can see, they suggest that patients with esophageal cancer who are early T1A or T1 TIS, the endoscopic therapies are preferred over esophagectomy. Similarly, for early stage gastric cancers, Japanese guidelines, they recommend that EMR or ESD should be considered for those early stage gastric cancers. So what do you need for this? Now the equipment of endoscopy is evolving. You need high-end sophisticated equipments. We have dedicated endoscopic surgical knives for resection and doing surgeries in the third space. You have forceps and graspers which to prevent the bleeding, which is a very common complication. And you have various clips to close the mucosal defects or close the perforations that you may inadvertently cause while doing the procedure. And what you need most is an advanced endoscopist. As I said, the learning of these procedures is higher. So just to summarize, management of number of GI disorders has now significantly improved with this innovative third space endoscopy. Achalasia, refractory gastroparesis, Zenkers, and early GI tumors and in fact subepithelial neoplasms can be dealt with in a better manner with third space endoscopy. And they have actually shown to be now very effective with an excellent safety profile. What is important is we need to understand that it requires a high level of skill and a sophisticated equipment. But with more and more people coming into this and more innovations coming into this field, third space endoscopy has a great potential and holds tremendous promise for future therapeutic procedures in endoscopy. Thank you.
Thank you, Dr. Nitin. You may join us here. Now I'll invite Dr. Ramesh Garg. Dr. Ramesh Garg is Head of Department Gastroenterology, Center for Liver Transplant and Gastrosciences, Saroj Super Speciality Hospital, Delhi. Sir has done his MBBS from MD and DM, all from Maulana Azad Medical College. He's an expert advanced endoscopist performing more than 5,000 procedures per year, all spectrum of endoscopic procedures, and has numerous publications in national and international journals. So we'll be talking about cholangioscopy in CBD diseases. Now no longer large stones are for surgeons. They can be managed by physicians. Dr. Garg.
Thank you, Vibhu, for the kind introduction. And a very good afternoon for all ladies and gentlemen. At the outset, I would like to thank East Delhi Physician Association for inviting me here for my presentation. And I can see Professor Sareen, who had been my teacher, and it is really my privilege to have a presentation before him. So we are privileged, sir, and a very good afternoon, sir. And I'm also thankful to Dr. Naresh Agarwal and Rajiv, who is my batchmate from MAMC, for inviting me here. In continuing with the theme of this conference, advances and innovations in the subspecialties in the GI, the topic has been assigned as a cholangioscopy and lithotripsy for CBD disease by the organizers to me. The working definitions for the cholangioscopy and lithotripsy. Cholangioscopy is the direct endoscopic method for the diagnostic visualization and or therapeutic intervention for common bile duct diseases. And lithotripsy is the endoscopic technique which is used to crush, pulverize the common bile duct stones that are too large to be removed with the conventional method of ERCP, sphincterotomy, and balloon dilatation. So this presentation is more for the probably surgeons. I don't know how many surgeons are sitting in this gathering. As you are all aware that the standardized technique for the handling the common bile duct disease had been the ERCP, and which has been in the forefront for the few decades. And we had been using ERCP for the removal of CBD stones and for the biliary stentings for the obstructive jaundice of either benign or malignant lesions. However, there are few problems with the ERCP technique. A substantial number of CBD strictures are indeterminate. We don't know whether they are malignant and whether they are benign. And we do have difficult CBD stones which cannot be extracted with the conventional method of ERCP. So I take these both things one by one. Indeterminate biliary strictures, where the cholangioscopy plays a very important role, includes those which has no diagnosis or questionable diagnosis after the cross-sectional imaging of ultrasound, CT scan, contrast enhanced MRCP and MRI, and we have done the ERCP and tissue sampling. In spite of that, we do not have diagnosis with that. What is the relevance and why we are so particular about the diagnosis of indeterminate strictures? In series, 20% of all strictures are indeterminate. They require repetitive investigations in the form of invasive, also EUS, ERCP investigations. That leads to the cost escalation, and that leads to the physician and patient frustration. And this is the very important, the surgical data which we have in the background, that approximately 25% of the patients who have been operated for the presumed malignant stricture turned out to be benign. Probably the surgery was not required, and some medical management would have solved the problem of stricture disease. This is just a representation of visualization of our biliary system by the ERCPs, and these are the various strictures in the form of inflammatory, post-operative, post-cholecystectomy strictures and malignant strictures like cholangiocarcinoma or CA gallbladders. Just for the sake of just discussion and informing the people, the differential diagnosis of indeterminate biliary strictures. I will emphasize on the benign, because malignant strictures, if you prove, most of these requires, if they are operable, surgical resection or biliary stenting or some palliative things. However, there are lesions or benign strictures which can be managed with the medications alone, like IgG4 related or autoimmune pancreatitis. And in our setting, in our country, we do see sometime tuberculosis of bile ducts too, which I will be just showing in short time. The cholangioscopy, as I've told you, is the direct visualization of the CBD, the common bile duct. And there had been few criteria on the gross visual inspection of whether this lesion is likely to be benign or malignant. However, we need to sample all these things because the tissue is the big issue. The cholangioscopic appearance of nodularity mass lesion may mimic cholangiocarcinoma with benign disease too, and this is the histopathological examination of a patient who were presumed to have a malignancy, and on the cholangioscopic biopsy it turned out to be tuberculosis, and the patient was just treated with anti-tubercular treatment and patient was all right. This slide just shows the visualization of biliary system by the various techniques or the various cholangioscopes which are available. However, I will just concentrate on the spyglass cholangioscopic system because most of the centers have this system only. The others have been outdated because of the ease and the maneuverability of the system. This is probably used. This is the spyglass DS2 system which is used in most of the unit nowadays for the cholangioscopy. And this is the representing image of cholangioscope through the ERCP scope. And these are the representative image of a lesion which is present in the common bile duct in the form of some nodularity or some polypoidal ulcerated and thickening of mucosa suggestive of pathological findings in the disease. See, I'm just presenting this, this case and highlight this case. This was around 10 years back. A 45-year-old male has presented with a pancreatic head mass and an obstructive jaundice. The patient underwent repetitive FNACs by the EUS and ERCPs, and it was negative for the malignancy. IgG4 was highly raised in this patient. CBD stenting to palliate the obstruction was done, and the patient was treated with steroids, and the patient was asymptomatic, and the cholangiogram has become normal. And mind you, if the surgeons are there and the physicians also, 15 years back, the patient like this who comes to our clinic, who comes to our practice, straight away we used to send these patients for a very advanced surgical procedure like Whipple procedure. However, in the current technology and the current evaluation which we have, we can just pinpoint the exact diagnosis and manage these patients medically too. This is the representative image of the cholangiogram and the cholangioscopic picture of tuberculosis of biliary tract in the form of some nodularity and thickening of mucosa, and the patient was treated with ATT and the patient became all right. This is the another patients where the cholangioscopy have helped for the management of the patients. This ascariasis has migrated from the cystic duct into the gallbladder. In normal setting, we need cholecystectomy or a surgical procedure for this. However, with the advancement in the cholangioscopic technique, we were be able to remove this ascariasis from the cystic duct and thus avoided surgery. Cholangioscopy is not only diagnostic, therapeutic implications are also and applications are also present. In the unresectable cholangiocarcinomas and the advanced malignancies, we can have radiofrequency ablation which can be delivered locally to the tumor to control the tumor. We can have various laser techniques which can be applied to the malignancies. We can drain complex strictures after the post-liver transplant patients which are not able to handle with the ERCP alone. And we can evaluate the patients who have hemobilia, bleeding through the bile duct. We have also done a couple of cases in that. Endobiliary radiofrequency ablation, this is the representative pictures in the patients who had advanced cholangiocarcinoma, and when we ablated with the cholangioscopic therapeutic modality, then the patient has a better survival and the better quality of life, and the palliation of jaundice was there with this technique. Now I am coming to the second part of my presentation, that is the difficult bile duct stones. As I have mentioned, with the ERCP, 85 to 95% of the time we are able to clear our CBD with this stone and the patient can go ahead with the cholecystectomy. However, few type of stones we cannot extract with the ERCP alone. Difficult bile stones commonly referred to the stone which are more than 15 millimeter in diameters because we cannot make this sphincterotomy or the biliary dilatation more than 15 mm. However, the stones which are less than 15 mm can be considered difficult if they are proximal to a stricture, if they are impacted, if they are intrahepatic, or if they have some anatomical or some previous surgery has been done, so that limits the removal of stones in these patients. These are the various cholangioscopic pictures where, representative pictures where I have, just depicted the difficult biliary duct stones. It is a real problem because in various series, 5 to 10% of all CBD stones are difficult CBD stones. And to handle that, we have various lithotripsy techniques available to us: mechanical, electrohydraulic, laser lithotripsy, and extracorporeal shock wave lithotripsy. We have various equipments available to us in the form of mechanical lithotripters which can salvage us from the emergency situation like Sohindra type of when the basket is impacted, we can really take out and do the elective procedure later on. However, I'm sorry, can you just help me out? But nowadays we have very good, technique of spyglass or the cholangioscopic guided lithotripsy in the form of laser lithotripsy and EHL lithotripsy. This is the representative image of laser lithotripsy. Here you can see a large CBD stone which is present, has been broken or pulverized into the CBD and later on extracted with the help of basket and balloon extraction. And this is the another image. This is the image of laser lithotripsy which you can see. And we have cholangioscopic guided baskets, smaller baskets available which can take out all the fragments or the residual stones which are there, which we have fragmented with the help of mechanical lithotripsy with the cholangioscopic technique. The another major advantage of cholangioscopy is that it does not have any radiation. You can have the direct visualization of that mucosa and tissue, abnormal tissue, pathological tissue. You can access that tissue for the histopathological confirmation. As I have mentioned, we can really do some therapeutic directed therapy either in the form of RFA, radiofrequency ablation, or other laser therapeutic modalities for these. And these are the consensus statements for the uses of per-oral cholangioscopy. Per-oral cholangioscopy is an important additional tool during the ERCP. In patients who have indeterminate biliary strictures, this can have targeted biopsy and help in establishing a definitive diagnosis. And per-oral cholangioscopic guided lithotripsy is recommended for the treatment of difficult CBD stones when other standard techniques with the ERCP fails. However, not all stones can be removed, as you agree, depending on the total local expertise and the facilities available, because all these things are advanced endoscopic techniques, may not be available in every center. So our surgical colleagues can take care of that either with the laparoscopy and surgery. Thank you for your time and thank you for your kind attention. Thank you.
Two questions, if there are any. Welcome Dr. Sareen and Dr. N.P. Singh, Dr. Makkar, Dr. Upadhyay as our chief guests. We are honored to have them here. And almost everybody sitting on this dais is the student of Sareen sir. The good part of these techniques is that they are not experimental now and are in routine clinical use. So we don't have questions. I'll spend 1 minute in what, yes sir, please. How many of the persons sitting in this hall think of endoscopic ultrasound if they have such patient? Please raise your hands. So we have still 80% of our colleagues who have to consider endoscopic ultrasound, and how many think of third space endoscopy and cholangioscopy if they have some patient like that? Very few. So our efforts may bring some insight in sharing with you all that these techniques are not experimental now and in normal clinical use. Dr. Makkar, please.
Question is on endoscopic ultrasound, Dr. Naresh, and thanks for the nice talk. For the physicians sitting in the clinic seeing certain, these GI cases, what are some of the indications where we can send patients to you for endoscopic ultrasound? Some of the indications that we clinically see in our common practice.
Sir, any person with prolonged fever and weight loss suggestive of some chronic illness with lymphadenopathy, whether it is in mediastinum or peripancreatic, and we send them for percutaneous biopsy, these cases. Second, chronic pancreatitis, pancreatic neoplasms, fluid collections of pancreas, or difficult CBD stones. A patient is claustrophobic from MRI. EUS is a wonderful technique in lieu of MRI. And some therapeutic uses taking biopsies from these lymph nodes, treating pancreatic fluid collections, or doing difficult ERCPs, and so on.
Right. Are there any contraindications to EUS or no?
So contraindications are similar to contraindications of endoscopy. Patient is so much hemodynamically stable, or there is no major contraindication, but of course, unstable patient or patient is having coagulopathy, we cannot perform therapeutic procedures, but just like that.
And one quick question on the third space endoscopy or procedures. What are the indications where we think the third space endoscopy comes in from the physician's perspective?
Yes, sir. Dr. Nitin. Dr. Ramesh, please come.
So as far as third space is concerned, today the most common indication is achalasia cardia. And you actually also now more and more we are dealing with early esophageal cancers and subepithelial cancers like GISTs or leiomyomas of the esophagus and stomach. So these are the usual common indications for third space endoscopy. Gastroparesis refractory to medical treatment, especially non-diabetic gastroparesis, idiopathic or post-operative, post-vagotomy gastroparesis. These are the conditions where third space is coming up in a bigger way.
Can hand over the organizers.
Excellent.
Thank you.
Excellent talks, and I'm so impressed and happy that all of you have been doing very well. I think there'll be an era now when the names of so-called CTVS surgeons and GI surgeons will get eliminated from this world.
Nothing like that. Nothing like that.
It looks like we've not left anything. I'm just reminded of the CPC which I attended in Ames and you know, the case which Ramesh described, similar, the discussant was also excellent clinician, and cholangiocarcinoma was for the final diagnosis made, but it turned out to be tuberculosis. So I think now with these modalities, we can almost reach everywhere and anywhere where even the surgeons were not able to. Congratulations.
I hope in 10 or 15 years, surgery and the interventional medical fields will merge and there will be no different fields.
That's what I said,
Because,
MCH will go begging with...
because hoping to robot to come in endoscopy.
No, sir, the surgeon work is increasing because now we are able to diagnose more and more. I mean, even the subtle, smaller lesions which are amenable for the resection because this is also there. Thank you, sir.
So we hand over to the organizers and complete this session. Thank you so much.
Thank you for the enriching talk. Now I would like to request Dr. Rajiv Bansal sir to felicitate our chairpersons and speakers. And I will hand over the mic to Dr. Swati for further proceedings.
Good afternoon. So now we'll proceed to our next session, which is actually going to be our inauguration ceremony. So now I request all the executive members of EDPA, President Dr. Paras Bansal, Dr. Paras Gangwal, Vice President Dr. Anirudh Lochan, Dr. Ashok Kumar, Treasurer Dr. Viresh Mehta, Chairman Scientific Committee Dr. Rajiv Bansal, Editor Dr. Aman Rothgi, Immediate Past President Dr. Vijay Arora, Past President Dr. Rajiv Gupta, all the past presidents of EDPA, Dr. Saroj Prakash ma'am is with us here, Dr. Prakash Gera, Dr. Ashok Grover, Dr. BK Gupta, Dr. NK Govil, Dr. Rajiv Lochan. I request all of you to please kindly join us for the lamp lighting. I also request organizing chairman Dr. Pankaj, both are organizing secretaries Dr. Sumesh Sharma and Dr. Ankit Bhatia, and our joint organizing secretaries Dr. Tushar Gupta and Dr. Anvita to kindly join us for the lamp lighting. Also, we have two stalwarts of medicine, our esteemed chief guest Dr. S.K. Sareen and our guest of honor Dr. B.M. Makkad. I request, sir, please kindly join us for the lamp lighting.
And all the dignitaries from RSDI Delhi, Dr. J.K. Sharma sir, from IMA Ghaziabad, Dr. Kuldeep is there. Please join us for the lamp lighting.
I also request Dr. N.P. Singh to kindly join us for the lamp lighting. Sir, please.
Our honored speaker of Bela Devi Oration Talk, Dr. Chaturvedi sir, to be joining us for the lamp lighting, and Dr. Anil Chaturvedi sir also, please.
Thank you. Now I call upon the executive members of EDPA, President Dr. Paras, both the Vice Presidents, Dr. Anirudh Lochan and Dr. Ashok, Treasurer Dr. Viresh, Chairman Scientific Committee Dr. Paras, Dr. Rajiv Bansal, Immediate Past President Dr. Vijay Arora, Past President Dr. Rajiv Gupta. Sir, I request all of you to kindly come over to the stage. I also request Pankaj, Dr. Pankaj, our organizing chairman, and also Dr. Sumer and Dr. Ankit, our organizing secretaries, to kindly come over and take seat. I request all of you to please come over to the stage. Dr. Ankit, Dr. Sumer, Dr. Anirudh, Dr. Viresh, sir. Extra. So now comes the most prestigious award ceremony of EDPA, the Lifetime Achievement Award. So we've been conferring this award to our senior most members in EDPA who have contributed much to the society and who've been a great contribution even to the medical fraternity. So this year, I feel really happy to confer this award to Dr. N.K. Govil. Dr. N.K. Govil is a graduate, he was a graduate and postgraduate of GR Medical College, Gwalior. He joined MBBS in 1973 and he completed his postgraduation in 1982. After working in Lady Harding and Sri Gangaram Hospital, sir worked for some time as a medical officer in Delhi administration. Later on, he started with his private practice as a consultant physician. He joined EDPA in 1999 and worked in various positions and went on to become the president of the organization. Sir has been an active member of various academic, sports and cultural committees of EDPA. Sir is now running his own clinic in Naveen Shadra. I request our Senior Vice President, Dr. Ashok, to kindly even escort Dr. Manju Govil to the dais. Ma'am is better half of Dr. N.K. Govil.
I think Dr. N.K. Govil is the most fittest person of our association. In every time in 10,000 step challenge, he's the first person to win.
Now I request all the executives to felicitate Dr. N.K. Govil.
I request Dr. Sareen sir to felicitate with the medallion to Dr. Govil sir. Please, sir. So I request Dr. Govind sir to say a few words for motivation.
Thank you very much. It's both a profound honor and deeply humbling experience to stand before you today as the recipient of this Lifetime Achievement Award. As I reflect on my journey that led me here, I cannot help but feel an overwhelming sense of gratitude to all my seniors, teachers, both here as well as my alma mater. Started my journey in the medical profession where you did not have the liberty to choose your career yourself, but it was thrust upon you by your parents as compared to now. Even I joined BSc Physics in Delhi University, but as luck would have it, I got the news that I have been selected for MBBS, and I had to leave that and join MBBS as per wishes of my parents. I was not very brilliant in academics, but could pass my exam comfortably. I had a passion for sports in my early life, but things started changing after completing MBBS, but I still pursue sports wherever and wherever possible. My journey with EDPA started in 1999, and in 2005, I reluctantly became the organizing secretary of the conference in 2005, but I liked the experience and journey, and eventually had the privilege of working as the president of this well-oiled machinery known as EDPA. This has allowed me to witness the remarkable dedication and resilience of our community of physicians in EDPA. But I have not been alone in my journey. It has been graced by lifelong friends which I have made in this organization. There's a long list of people and individuals who have stood by me and given me counsel as and when I needed it. Their unwavering support, guidance, and camaraderie has been invaluable. Receiving this honor is not just a recognition of my individual efforts. It symbolizes the collective dedication and relentless pursuit of excellence of all my colleagues in EDPA. In the end, I am grateful to my parents who would have been very happy to see me receiving this award. Also, I would also mention my wife, Dr. Manju, and my children, Abhishek and Akshat, for their all-round support. Thank you very much. Thank you.
Thank you, sir. Now I conclude the inauguration is complete. So now I take great pride in extending a warm welcome to our esteemed chief guest, Dr. S.K. Sareen, and guest of honor, Dr. B.M. Makkad. The presence adds immense value to our gathering, as we are truly privileged to have someone of their stature among us. I now request Dr. Vijay Arora to escort Dr. B.M. Makkad to the stage.
Dr. Naresh, are you here? Dr. Naresh, kindly escort Dr. S.K. Sareen.
I request the executives to kindly felicitate the guests. Now I request Dr. Paras Gangwal to give his presidential address.
So, welcome everyone on behalf of East Delhi Physician Association. We are really grateful to all of you, all the delegates, all the dignitaries on the dais to receive our invitation wholeheartedly and be here in full strength. See, EDPA is an emotional association actually. I think maybe E stands for the emotional, right? And we here are a big team, a team of orchestra creating the great symphony, the great music which is presented to here in form of these conferences and the CMEs. And we are such a good team that seniors here are listening to what their juniors say, and the juniors are always agile to perform the best, deliver the best. We follow one motto: do it as per you, over to you. Because it's not just the liberty to perform anything, it's the responsibility which is taken up with this motto to deliver the best. That's how we are functioning in this association. This team has always inspired us great values of practice, living life to us, and have collected few pearls of wisdom from walking alongside of such high-end clinicians, great human beings in this association and around me that I would like to share. The first lesson that we have been taught is be empathetic, compassionate to the patient care, which we all do with great passion. At the same time, in changing times, we have been cautioned now to take care of ourselves, that while we give all the empathy, compassionate care, parallelly we take care of ourselves, that if we see during this discussion and compassionate care any resistance from the side of the patients, it's better that we make our team larger. Better we do things like group practice to ease the burden or on our mind. Better that we involve cross consults. Better we pass on the best benefit to our patients. Let's pass on the best benefit of second opinion, review opinion to our patients. It surely improves patient care and will help us going a big way in saving ourselves and saving our patients also. Then the next lesson is how to attain longevity. Can we defy death? Can we deny the mortality? So this is what we all are working on. So the first is that we breathe healthy, drink healthy, eat healthy, which we all know that we have to say no to all toxins, preservatives, and infused nutrients to us in various colors and forms that the nature has provided, which most of us who are looking agile, healthy, like Dr. Govil, Dr. Lalit, and the modesty of Dr. Gera sir, Dr. Rajiv sir, Dr. Sareen sir, we learn from that a lot, that how to live life in a smooth, balanced way, being mentally and physically fit. It's time, at times, we need to take out time to sit idle and do nothing. Just spend time with yourself for a while. That's important. We need to embrace this holistic health. I think this all is going to provide, listen to the music, feel free, be happy for no reasons, be with your mates, be candid. So leave all the taboos. I think that is going to give us more of vascular and metabolic health probably. So embracing this holistic health, inculcate the herbs, the condiments, the superfood which nature has provided, and surely take care of your posture and ergonomics while sitting long hours in your clinic. Do a bit of yoga, meditation daily. Let's make it all religiously happening. Let's be child within ourselves. Let's embrace the childlike behavior at any stage of our life. When we were a child, in the middle age or the later age, we need to inculcate that behavior to enjoy every moment. And let's be cautious when we drive. Never drink and drive. Never touch electrical installations in a hurry. So be wary of the gadgets which gives you security, the seat belts, the helmets, wherever they are needed. It's good to be part of adventure sports, but during that time it's important that we ensure that every gadget is safe and sound. Let's not be in a hurry of all the adventures. Let's follow the safety gears properly. We do need to keep technology as our aid in surviving longer. Now we have the wristbands, wristwatches, which can monitor our health. It is a constant 24 hours ICU that you have on your wrist while you're sleeping. That ensures safety in many ways, and these technologies are going to evolve. I think we need to take them up front in ensuring the longevity. They would be our partners. We also have a responsibility. Dr. Saroj Prakash has always been saying, let's give back to the society, which all our seniors are always ensuring that we need to give back to the society, and we all are giving back in form of various public education lectures, public education activities, various videos that we circulate. At the same time, since we are the gem of the people, since we are very passionate for the patient care, I think when we say that we give back to the society, at the same time, prioritize self-care, because we who are genuine people, who are compassionate, we need to live longer so that we can take care of the society for a longer duration. So just imbibe those concepts and practice those. And always, all the time, chasing the money is not the right thing. We chase money a lot and then we dump it. I think we need to be wise in these eras and times. When there are so many investment portfolios, we need to invest wisely our time and resources and let your money be earner so that you can enjoy the luxuries of life. You can play golf or cricket, and you have a lot of coins and gold stacked with you to take care of your future. It's not always, all the time, running and practicing is not good. I think we need to understand the concept of investing things in time. And there were a lot of hiccups about AI coming and taking up your jobs. I think for the doctors, it is going to be, if we know it, we better tame it to evolve into a augmented human intelligence rather than only just human intelligence. AI is going to be a big supporter of us. It will be giving us, making us superhuman, super doctors. I think we need to imbibe that. And finally, let's be one. East Delhi, whole Delhi, the whole India, one nation and one world. That's Vasudev Kutumbakam. We all come together. That's why we are happy to welcome all the dignitaries across every walk of life from all the associations in Delhi, be it RSDI, be it RDMA, be it API Delhi chapter, be Noida and Ghaziabad. We all are one, and we are working towards improvement of the mankind. Thank you very much.
I would like to next go ahead with our souvenir release in the presence of our esteemed guests. I request the members of Souvenir Committee, Dr. Aman Rohtagi, Dr. Ashok Kumar, and Dr. Anil Chaturvedi, sir, please come over to the stage. Now,
So in the morning we have a very interesting quiz. I request Dr. Shubha to announce the winner so that they can be facilitated by our chief guest.
Thank you, sir. So winner for our quiz was Team LHMC, Lady Harding Medical College, Dr. Srinivas, Dr. Neeraj, Dr. Abhishek. Please come forward. And
I request Dr. S.K. Sareen to kindly give the prize trophy to the quiz winner team. Sareen. Congratulations to the winners.
Dr. Srinivas, Dr. Neeraj, and Dr. Abhishek.
Now I request Dr. B.M. Makkar, sir, to say a few words.
Good morning, friends. Professor Sareen, Professor Saroj Kumari Prakash, dignitaries on the dais and off the dais, my dear colleagues and friends. It's indeed a great honor and pleasure to be here at the annual conference of EDPA. And I must thank Dr. Vijay Arora and the organizing committee for the very kind invitation and all the honor that I have received here. It's truly humbling. I think I knew very little about EDP earlier, but since I got associated with Dr. Vijay and others, I realized this is one of the most vibrant and active association of physicians in this part of Delhi. And I must congratulate EDPA for keeping up the tempo and activities in the field of medicine and updating the fellow colleagues on regular basis on different aspects of medicine. I think they are doing a wonderful job, and I congratulate them for everything, the way they are doing, and wish them all the best. Thank you.
I request our Chief Guest, Dr. S.K. Sareen, to say a few words. Sir, please.
Thank you, East Delhi branch, Dr. Gangwal, the whole organizing team for inviting me. I'll share a few thoughts. I was in Jaipur and my teacher was Dr. R.M. Kasliwal. Some of you might know the legendary amoeba and cardiology, whose son is Ravi, who works there. So I wanted to join All India Institute after MBBS. So he gave me a letter for Dr. M.L. Bhatia, who was the head of cardiology at AIIMS. So I went to his room, sent a message, he called me in. He saw the letter written by Dr. Kasliwal. He was sitting, बैठे हुए थे आराम से अकेले. अभी तो कवर देखा और कासलीवाल साहब की हैंडराइटिंग तो वो खड़े हो गए. लेटर खोला, पूरा पढ़ा, तो दोनों पैर और दोनों हाथ अटेंशन में खड़े हो गए. एज इफ कि कासलीवाल साहब वहीं खड़े. मेरा पूरा उन्होंने पढ़ा, फिर कहा भाई देखो तुम एमडी में तो मैं कुछ नहीं कर सकता, पर हाँ तुम डीएम के लिए कार्डियो में आओगे तो मैं ज़रूर तुम्हें पढ़ा दूंगा. सर को मेरी नमस्ते कहना. Today I came here. I had thought that students have lost respect for their teachers in last 30 years. But when I came, all of my colleagues They could greet me, they got down and they wished me. Thank you all. I'm really touched. I could partly hear what Nitin or Ramesh said, and I missed some of what I think Naresh had said and Ramesh had said. But they outsmart all of us, and it's a privilege for me to see the next gen being better, smarter, more educated, but well connected to us. Thank you. My second story, real story, is for Dr. Makkad and all those. So it was my third day in All India Institute, Makkad sir. तो मैं नीचे था और मुझे I had joined DM, तो मैं एप्रन में था और लिफ्ट ले रहा था. So somebody came, tapped me on my shoulder. भाई तुझे कहाँ जाना है? मैंने कहा सर C7 में डॉक्टर भाटिया के वार्ड में कंसल्टेशन देखने जाना है, चल मेरे साथ. So 7 stairs चढ़ के ऊपर गए. उन्होंने वार्ड दिखाया. This is the ward of Dr. Bhatia. And then he said, in case next time I see you taking the lift, I will break your legs. Imagine who was this man.
Dr. Bhatia.
No, your diabetologist. MMS Ahuja. He used to walk. That day until date, whenever I see a lift, and he said lift is for patients. Stairs is for doctors. The story closes. I just thought I will share with you. The third thing I might say briefly, I'm very proud to be part of this celebration. I have come here sometimes thanks to the East Delhi branch, and I'm told 25th year is next year. So Dr. Gangwal and the team, I have a work for you. I hope you can do it in next 1 year. I see everyone has a symbol, has a jacket, whichever Modi or Nehru. If each of the physician in East Delhi takes one school and does a survey of 200 people, let's say 200 physicians join and they survey each one 500, you will survey 1 lakh people and 200 schools. This will become the best paper in Nature or Science of a community survey of health parameters in the country. There is no such survey. How? Can the East Delhi branch do it?
Yes, sir. Yes, sir.
Will you do it?
Yes. With your inspiration, surely we can do it.
I'll tell you why it is important. We did a survey called Smiles, Stronger India through million educated students. We launched it last year. This is just few months. Smiles is a survey where 18 to 21-year-old were asked telephonically in Delhi. We did about 13,000 students. Of these 13,000, 31% are in the red line or in the yellow line. Only 69% of the children today can be called so what healthy. Either these 31% are obese, have hypertension, or blah blah blah. 1/3 of the 18 to 21 are unhealthy. What will happen to their children? Therefore, it is my humble request, and I will design this survey and you can improve upon it, but please carry one school and 200 or 300 people. One survey, form fill up, and you will have 100,000, and you will have a voice of East Delhi branch all over the world. And one small message, I know she wants me to quit, but I will in 1 second. Doesn't matter. One more message I would like you to also do, and which I heard from a lady, Pallavi, who is that infectious diseases DM here. Someone was here. Anahita. She is an infectious diseases DM, and she said that she's joined Gangaram, but people don't recognize. I also work for the National Academy of Medical Sciences. NP is part of that, and I want to tell you, every DM MCH can become a member of the National Academy, which involves all branches. And every MD, MS can become an associate member of the National Academy. And I was telling the quiz people, there is a national quiz, which last year 7,000 people, students across India joined that national quiz. And I will tell to the East Delhi branch, this will occur somewhere in November. These national quizzes connect you to 800,000 students, 8 lakh students who compete for a medical national quiz. So keep quizzing, keep winning, and keep contributing. Thank you for inviting me.
Thank you, sir. Now I just request everybody to join for a group photograph with sir. Thank you, sir. Now we'll proceed to the next session. I request all the executives to kindly remain seated on stage. I request the executives to remain seated. So now our next session is our prestigious oration. So this is Srimati Bela Devi Memorial Oration. The oration is dedicated by Dr. Saroj Prakash to her late mother, Srimati Bela Devi ji. I request Dr. Ashok Grover to hand over a bouquet to Dr. Saroj Prakash ma'am. So all the senior members of EDPA do know Dr. Saroj Prakash. There are a few members who have joined recently. They may not be knowing ma'am. So ma'am is one of the founder members of EDPA and founder president of EDPA. So she served as a faculty of medicine at LHMC, and she was a professor of medicine at LHMC, and she is superannuated as professor of medicine in MAMC. Ma'am is a member of various societies of internal medicine and cardiology, and she has many awards and special achievements. She was felicitated by MOHFW for outstanding and valuable contribution as a doctor to the society on National Doctors' Day in July 2022. And she was also facilitated by multiple forums like LHMC Alumni Association and East Delhi Gynec Forum. And Srimati Bela Devi Memorial Oration was instituted by Dr. Saroj Prakash, as I already told, in year 2000. Srimati Bela Devi belonged to Khurja, then a small town of UP. After marriage at the age of 15, Mrs. Bela Devi came to live in Shadra in the mid-20s. At that time, Shadra was a small satellite town of Delhi with a population of around 10,000. The place was rampant with malaria, enteric fever, and other communicable diseases, with very little, if any, by way of health facilities. Education was not considered important, and there was only a primary school for girls. Although herself minimally educated, Bela Devi believed in girls' education. She had to take a very bold step of educating them beyond 5th class because it meant sending her young 10-year-old daughter to Delhi daily by train. This was against all financial or social odds, but she persisted. The family shifted to Delhi in 1942. This was a very difficult period for a middle-class family due to the ongoing Second World War, with rationing, shortage of food and clothes. Agitation for national independence was also at its peak. However, Bela Devi managed to educate her 7 daughters and 1 son without any gender bias, practicing what is now being preached today about the importance of girls' education and health. A lady ahead of time, Srimati Bela Devi did not hesitate to even send her daughters overseas for higher education. She believed in financial independence for girls and succeeded in her effort as all her daughters received good education, achieving their desired position in life in various fields of education and arts. This oration is dedicated towards his brave and visionary mother by her daughter, Dr. Saroj Prakash. As I already mentioned, Dr. Saroj Prakash is a graduate from LHMC with a postgraduate training in UK with membership and fellowship of Royal College of London and Edinburgh. And she was on faculty of medicine at LHMC and MAMC. And as Dr. Saroj Prakash herself had said, and I quote, "As a child, I was considered a harbinger of luck by my father. But I believe that it was me who was lucky to have a mother like mine. She made me what I am today." So now, I just want to declare that the oration is conferred to Dr. Lieutenant General Ved Chaturvedi ji. I request Dr. Our Senior Vice President, Dr. Ashok, to kindly escort Dr. Ved Chaturvedi to the stage. And I request Dr. Paras to say a few words.
Slide.
I request all the executives to felicitate Dr. Ved Chaturvedi.
We know Dr. Professor Ved Chaturvedi. He has been one of the first DM in rheumatology from SGPGI. He is first rheumatologist in the country to use biologics. He is the first one to introduce musculoskeletal ultrasound in India. And he has many papers in national and international journals. He has been ex-editor, Manual of Rheumatology. He is recipient of highest Presidential Peacetime Award. And he's ex-vice president and vice president. He's currently vice president, Asia Pacific League of Rheumatology, APLAR. He has been ex-vice president of MSK Ultrasound Society of India. So we welcome Dr. Ved Chaturvedi.
I now request Dr. Ved Chaturvedi to start with the oration lecture. Welcome, sir.
Good morning, ladies and gentlemen. At the outset, I must thank the local committee to give this honor, especially people here present, Dr. Professor S.K. Sareen, whom I know from many years, Dr. Paras Gangwal, Dr. Swati, Secretary, and Madam, she was teacher of my wife, so I just knew about this oration. I didn't know, frankly speaking. So I was, that time I was young captain in the army, so I used to go to Lady Harding. That is how I knew about Madam. And of course, very senior people like Dr. Makkar and Dr. Pankaj, and my friends, Dr. Ashok Grover, and my seniors, Dr. Chaturvedi, sir, sitting here. This paper is very important. मैं आपको एक छोटा सा वाकया बताता हूँ. I was doing a cricket commentary. There was a match between army officers and member of parliament. तो ऐसा कागज मेरे पास था and commentary went off very well, 5-6 hours जो भी मैच था. उसके बाद क्या होता है कि वो एक अवार्ड सेरेमनी होती है, तो आप उसको नीचे आना पड़ता है कमेंटेटर को एक माइक लेके. वो कागज में ऊपर भूल के आ गया. अब जो चीफ गेस्ट थे वो सबको वो दे रहे थे, क्या कहते हैं, कैप. एंड उन्होंने एक को दिया, उसका नाम मुझे मालूम था, दूसरे को, तीसरे को, और चौथा वाज माय बॉस. And I forgot the name of my boss. And you don't tell me, then I went to Guwahati after that because he said, नहीं यार तुम्हें नाम याद नहीं रहता, मेरा याद नहीं तुझे. So that is how, so sometime it happens. I was in uniform for many years, and after that I joined this hospital, equally prestigious hospital, Gangaram Hospital. And this was my department in Army Hospital. When I came, I still remember, actually after my DM, I went to Calcutta. So my boss told me there, यार rheumatologist की तो कोई ज़रूरत नहीं है, तुम एक काम करो, तुम दीमापुर चले जाओ, Nagaland. So when Dr. Sareen was talking about that girl, about infectious disease specialist, so don't lose heart. It takes time to establish yourself. And I can tell you, God moves it like this, the whole clock. जब मैं दीमापुर से आया, तो मैंने देखा कि वहाँ my boss' daughter developed rheumatoid arthritis, and he retired that day. And I was the only person to see him off on the railway station. उस समय तो ट्रेन का ज़माना था. So he started crying that I didn't know about rheumatology. I said, no, sir, it happens with all of us. And my brief is to talk about not rheumatology, what is changing face of rheumatology over a period of time. I'll tell you, when this film, I am very sure, very senior people sitting in the front row, and I don't know about juniors, if they have seen this movie, Raj Kapoor, Mera Naam Joker. You tell me why it didn't click. It didn't click because we knew the culture of Bollywood was like Bobby. So he made the next movie Bobby, and it super hit. What was the difference? The reason was the society was not prepared that one hero can have 3 girlfriends also. So that if you do anything ahead of time, it doesn't click. And that happens when I joined rheumatology. I was selected for cardiology, and Army conducts an exam. I said, no, I want to join rheumatology. And my whole house, and later on, including me, when ultimately I was selected in SGPGI, I joined, I was very depressed because this science I didn't know, frankly speaking. It was not very well taught to us, anything which is not taught to you. So, because teachers also, we always thought, my brother is an orthopedic surgeon, so I used to refer patient to orthopedic. So we were surprised with the choice. People were going to cardiology, gastroenterology. It was about 1989 or 1990, and people had endoscopy and the scopes, echocardiography, all those. Rheumatology had probably more of antibodies. So what has changed in rheumatology? First thing which has changed, I can tell you, even today you do survey. You do survey in your own hospital. You need not to go anywhere. You are not physician. You talk to a normal doctor, talk to an eye specialist, talk to an ophthalmologist or ENT, or you do a survey that if your mother is suffering from arthritis, where you will take, they will say, okay, I'll show to so-and-so, he's my neighbor, he's an orthopedic surgeon. So after, without realizing that a person, you know the difference between surgeon and physician, we all know the mindset and everything. So what has changed in probably the practice, that patient started reading more. When the patient start reading more than doctors, they know the difference between orthopedic and rheumatology. So that has changed, and that has as a very war. Another is infection. Now, our generation knew about infection very well, including rheumatoid arthritis, which was considered as tuberculosis because of tuberculosis. That's why gold therapy came into account. So infection to autoimmunity, and of course there are new markers, new cytokines, newer things, genetics, which we all know. So this is how, when I did my DM, the rheumatology was taught, rheumatoid arthritis was diagnosed like this. Now this is, even painter can paint like this. This is a complication of rheumatoid arthritis. It's like somebody says, you have ischemic cardiomyopathy, your heart becomes so much, but you have to diagnose the ischemia very early, ST elevation, some enzymes, some markers. So what has developed is that we diagnose rheumatoid arthritis, we used to diagnose that somebody has a arthritis of hand joint, both joints, morning stiffness, and disability. And all those disabilities were taught to us, Duchenne, that all those boutonniere deformity and all, it was conducted in the examination also. So examination also, this was, so disability was considered as, while that was a complication, And this is how it was treated actually. My own mother had arthritis, and you know what was the treatment of arthritis? They used to have frogs, and they used to put it here. I have seen, my mother used to tell me that, so this is like in even the Western literature also, it is described, and today is treating like arthritis, treating like diabetes or hypertension. So it was called as Vat Rog, and we realized probably it's an infective agent. And over a period of time, we learned that the quest for finding an infective agent is still there, but they did everything. They did for virus, bacteria, tuberculosis. They didn't find, and gradually came the concept of autoimmunity. Now, immune system for a beginner, which I always say to non-medical people, but it is better to learn small things in life. So I always say, look, it is something like this. A musician was, there was a musician Naushad, and there was another musician O.P. Nair. O.P. Nair used to make very simple tune. So Naushad was his, Naushad के cook थे, वो खाना बना रहे थे और वो गाना गा रहे थे O.P. नैयर साहब की फिल्म का. तो नौशाद साहब ने, उस ज़माने में तो गैस थी नहीं, उन्होंने लकड़ी उठा के उसको मारा कि मेरे पास तू काम करता है और O.P. नैयर के गाने गाता है. उसने कहा सर आप इतनी डिफ़िकल्ट चीज़ें बनाते हैं, गज़ल वज़ल, वो मेरे समझ में नहीं आती, मेरे समझ में सिंपल चीज़ आती है. तो यदि कोई सिंपल चीज़ पढ़ाता है वो बहुत इम्पोर्टेंट है. So what is the immune system, which I always tell people, it is something like a steering wheel. Now, steering wheel goes like this, that is a autoimmune disease. And if steering wheel goes whole circle, that is a cancer. So that is how the most of the immune therapy in cancer, which I'll talk about, CAR T cell and all those, that is how it come. So all drugs which you are giving, you are putting the immune system back to normal. So that is how the autoimmunity concept has come. And of course, hormone, we have grown through hormones. Nobody used to knew about 100 years back what is a hormone. And our generation grew with cytokine, and now still growing the new generation cytokine, and how the signal grows from cell to the nucleus, which is called as signal transduction. तो simple है, एक कोई cytokine है जो छोटी मात्रा में होता है, एक signal है जो cell से जाता है nucleus तक, और एक genetics है which we all know about. So this is how the changing face of rheumatology, which I learned, how I am very sure the new generation knows better than us, but seniors sitting here, we must know how things have changed and what changes because of these cells. Look, in our time, it was a lymphocyte and neutrophil. That is how the cells were diagnosed. This is, neutrophils means polymorph, which is a morphologically polys. And lymphocyte was a big cell and a big nucleus inside. That is how the cells were recognized. Neutrophil and lymphocyte. How things developed this side? No. The lymphocytes are the major cells for the immunology. And they said, okay, there are two types of cell, T cell and B cell, and then further classification, sub-classification, and these cells talk to each other. So this is a T cell, which is a lymphocyte. Lymphocyte, our generation also knew lymphocyte. Then there are T cells, they talk to B cells, and B cells produce autoantibodies, which can be normal antibodies, it can be pathological antibody. And this is a macrophage. Now, macrophage is what? It's a monocyte. Monocyte in the tissue is called as macrophage. So this is an antigen presentation cell. So basically, some antigen, which we call it, maybe you can call it some infective agent. So some infective agent, forget about that infection, we don't know. But we know about, we call it antigen. Antigen is presented to T cell, and T cell stimulate the B cell, and that's the story. That is how most of the work has been done on this basic platform. It is something like this. If you want to stop the communication between these two cells, if you want these cells should not talk, then you must do something. Various measures can be done. You can cut off the communication by various means, and that is what exactly has been done in science then you stop the communication. And these are all things, no need of even cramming them up, no need of knowing the names. Concept, this is a macrophage, this is a T cell, and this has been photographed. It's not hypothesis. It has been photographed beautifully that they talk to each other by various means, by A, B, C, D, E. I don't want to bore you with the name, but that is how. And if you can block these, probably you can block the further pathology. So then they photographed and worked further, and they realized that these are the cytokines released when there's activation. So this cell talked to this cell, and this cell is activated, so called activated T cell. So when the T cell is activated, these cytokines are produced, and these cytokines are called as A, B, C, D. But you must remember this TNF. Now, why it is called tumor necrosis factor? Because initially when they were working, any discovery is done about 100 years of research. So 100 years people were working, and they realized there is this hormone, you can call it cytokine. Cyto means cell, kine means it's like chasni. Cell se nikli hui chasni. So basically they realized there is a tumor necrosis factor. If you put in the tumor, it gets lysed, and that is how the name came. It could have been any name. So tumor necrosis factor, that they realized this is the bandmaster of orchestra. And it regulates many inflammation in the rheumatology. And then came many other, and they have many functions on everything. In rheumatology, they can have a pannus formation, they can have swelling, inflammation, morning stiffness, and erosions, and everything. So TNF, and then many others came into the, and the man who was this man is an Indian. That's why we must know. And these drugs which came after research, and they make anti-TNF drugs. Anti-TNF drugs came because this man believed that rheumatoid arthritis is because of increased TNF. Look, TNF in general medicine came into being because there's no treatment for septic shock. Even in US, the septic shock mortality is 90%. So if some people die in nursing home, and we always keep blaming, even in US, even today, the mortality of septic shock is this much. So they were searching for a drug, and they realized TNF is high. When the TNF is high, let's make a drug against TNF, and they made a drug which called infliximab, and when they start giving, it didn't work. When it didn't work, the company Schering-Plough was keeping this medicine, and this man realized that TNF is high in rheumatoid arthritis also. It didn't work in septic shock, but it worked in rheumatoid arthritis, and he got the Nobel Prize of US, Ravindra Mani. I called him to Delhi. I told my boss that I was junior, I was in army, junior means about lieutenant colonel. So I said, I was just came after DM, 2-3 years, so I said, sir, I'm calling him. And my own boss in SGPGI, he says he doesn't go anywhere. He's a third generation Indian. Don't think he's an Indian. He's a more of an Englishman. Uski कहते हैं ना, उसकी नाक अंग्रेज से भी बड़ी है. He doesn't go anywhere. Even in London, he does not go anywhere. But I called him. I wrote a repeated mail, about 100 of mail I wrote. I said, look, and he came to Delhi. My boss told me I am not coming as a chief guest. I don't have time, so you carry on. So I carried on. Morning, he delivered lecture. Whole Delhi was there. All scientific community of Delhi was there. And in the morning, he delivered lecture. In the evening, he got knighthood. And whole TV, media, everything was flared up that Ravindra Mani got the knighthood. Sir Ravindra Mani. And then my boss rang up in the evening. Yaar, ye wahi hai jo subah tumne bulaya tha? मैंने कहा कहता I want to meet him. मैंने कहा sir, no, you can't meet him. So that is Ravindra Mani, and he was the man who published the first study on infliximab in rheumatoid arthritis, and that time it came on the main cover as a wonder drug, and of course he came on the main cover of Arthritis Rheumatism, which is like New England Journal of Medicine, with a high impact factor. They don't publish human photographs, They publish human photographs very rarely, like who discovered the asteroid, Philip Hench. His photograph came on in 100 years of publication. 100 years of publication, human photographs, only this. This is Mark Feldman, who was a basic scientist, and Ravindra Mani on the main cover of Arthritis Rheumatism for infliximab in rheumatoid arthritis. After that, we improved the understanding of the disease and targeting, and we realized that we are diagnosing here. Probably we have to diagnose it basically in the preclinical or early rheumatoid arthritis. As you diagnose diabetes, you say pre-diabetic. So you say, yaar, diabetes ki dawa matlo, thoda ghumo ghamo, thoda ye karo. So we are trying to diagnose this rheumatoid arthritis early by set of antibodies. So that is how the... Is it for me? Okay. Okay. So treat to target rheumatoid arthritis, and multiple drugs came after that. After all, last 10 years have witnessed exponential drug discovery in rheumatology, and that is how the drugs came, A, B, C, D. If you talk about this, we all knew we knew about these drugs, cyclosporin, methotrexate, this. But what is happening new is all this tissue engineering and anti-cytokine therapy, and so many things which are developing, CAR T cell therapy, regenerative therapy. And my own heart is this. Why I do this? Because I was serving in an organization which had 1.2 million people, army, males. And what was their age? 17 years. He 17 साल में उसकी भर्ती होती है और 34 साल में वो रिटायर हो जाता है. And this was basically young soldiers. I wrote an article long back, spinal arthritis of young soldiers. I wrote in India Today. Basically, we knew about this. We always say ankylosing spondylitis, bamboo spine, whatever. And we used to see a lot of, now nobody has this. Both are Dubai, son and father. And he always asks me, sir, will I become like this? I say, chances are less if you treat. They both are on biologics, both are taking treatment. We really don't know whether really the structural progression is stopped or not, but we have certainly drug which can. It's like osteoarthritis. It's like a white hair. You tell me what is the treatment for white hair? Otherwise, सफेद बाल का treatment होता तो देवानंद भी ले सकता था, हेमा मालिनी भी ले सकती थी. Even today, we know exactly what is a white hair, but we know the treatment. Exactly same osteoarthritis. Everybody working on osteoarthritis, there's no treatment. Exactly same situation was there for this disease when I joined rheumatology. And why when I start using, my own boss did not believe that you are using infliximab, and that story is different. And now everybody does not progress. So there are a lot of classification response, which I don't want to bore this organization, but lot of you call early RA, you can call clinical ankylosing spondylitis, pre-radiographic, all same like diabetes you diagnose, pre-radiographic, pre-diabetic. So many things have come, but more interesting is this man. We must salute the medicine people. Must salute this man. These patients were going to orthopedic surgeon, and this man was working not in an academic institute. He was working in a district hospital. I met him recently when he told me whole story. And he said, I was working in a district hospital, and what he did biopsy of sacroiliac joint. Now, sacroiliac joint is involved where the story begins in sacroiliac joint, and he demonstrated that TNF is high. If TNF is high, use the anti-TNF drug. He wanted to conduct a trial. He rang up Ravindra Mani, and Ravindra Mani said it will not work. Now, this is the jhagda of like India and Pakistan. The French people, Germans and English people, they fight with each other. So he says, look, your theory is useless. I think you did a SI joint biopsy, and this is all useless. He didn't, and he made sure this Ravindra Mani told the drug company, don't give him drugs for the trial. So he didn't get the drug. So he went to America, purchased the drug, and rest is the story. He published in Lancet, and this is Jürgen Braun from Germany, And today, infliximab and related drugs, anti-TNF, it is more used in this disease than any other disease. So today, anti-TNF drugs is more used in this than rheumatoid arthritis. And I was lucky. I was in army, and we had 200 hospitals and had a good referral system, unbiased. And all patients used to come to me. I was that time sitting in RR hospital. So whole lot of every day about 50 infusions of infliximab, and whole from country, like some patient is there in Jammu, somebody is in Guwahati, somebody is from Chennai. They will all come, young soldiers, and developed a huge database that yes, they are effective. So anti-TNF drug, and this was the paper Lancet in 2002. It's not a new story. It is 20 years old story. So you must remember that today ankylosing spondylitis is treatable. And believe me, he had just 27 patients. He didn't have money. And around same time, since I had the drug, I had already drug for rheumatoid arthritis because I was using for rheumatoid arthritis. And immediately in 2 years' time, I had about 127 patients, which I presented also American College of Rheumatology and Asia Pacific Rheumatology. And people were surprised, who's giving that amount of patients and that amount of, that time it was very costly. But that is a history, that is we almost had about 3,000 patients, and this was our first patient which so we developed over a period of time we realized anti-TNF does not work in every patient. We realized, now we are working, my own student today in Gangaram is working on the difference in male and female SPA. And I'm very sure at this age also I'm missing a lot of women in ankylosing spondylitis. They present differently. And you will always dump them, fibromyalgia, you will dump them. So be watch, next 10 years, we'll know how the differences is. They have more of the cervical pain, which will be dumped as a OA cervical spine, while they have a ankylosing spondylitis. Female present differently, and they have a lot of aches and pains. But if you do MRI, X-ray, everything will be normal. So the activity is this much, pain activity, and cervical spine involvement, women, and that is what I presented in last APLAR, that yes, they are different diseases. And we realize it is not the MRI of the SI joint. You have to do the low dose CT also. Biggest problem with the CT scan was CT scan gives this much radiation. So you use low dose CT scan. So you do both. So the message for this is that you do MRI of the SI joint, you do low dose CT scan, then probably you can pick up. And of course, the ultrasound. Ultrasound come in a big way. Whenever you do things advanced, I purchase the ultrasound machine and I start doing it. My own boss was unhappy with me. Why you was using ultrasound? And rest is the history. Today, Americans, Europeans, when this, in fact, Philips company was searching for who was the first person who did ultrasound of the joints. So as it is, we don't keep record, we don't publish also. So ultimately they zoomed in, and there was a society of radiologists, which is called Musculoskeletal Society of India. And they made me the vice president of that because radiologists also, they were not doing it. And for about 6-7 years, I remained the vice president of that organization of the radiologist. So ultrasound has come in big way, and why ultrasound come in a big way, that's a different story. And newer therapy, that TNF is not the only drugs. There are a lot of other drugs which are, like suppose you call it A, it should be called as B, and they are called as IL-17 inhibitors. So another cytokine, like another hormone. You have one hormone, TNF, another hormone is called as IL-17. Both drugs are used now extensively for ankylosing spondylitis. So basically, which we realize after using this, that some people anti-TNF does not work, then anti-IL-17 will work. And we learn about why it happens. So that is how exactly. You remember this photograph, very important photograph for youngsters. I can tell you why it is important. That TNF everybody knew that causes immune inflammation. There are shant rahiye, please. Just a minute, just shant rahiye. TNF causes inflammation, which we all learn in 20 years. Over a period of time, we learned there is another thing which causes IL-17. Now, so you make a drug for IL-17 which is called secukinumab, that is available in this country also, popularly called Scafo. So IL-17 and these two medicines and IL-23 which is used in dermatology. So we realize that IL-23, this is A, B, C or whatever. Just remember these words: interleukin 17, interleukin 23 and TNF. They are most of the drugs are coming around them. So this is IL-17 pathway and this is the TNF pathway, which will not. Now another story started. The story started is that you don't block one cytokine. If you block multiple cytokines, because it's not that rheumatoid arthritis is a story of only one cytokine. There may be bandmaster of orchestra, but there are other players also. One player, if you block rheumatoid arthritis, will not be blocked. So alone bandmaster will not do anything. So they realize that maybe a oral drug, maybe a drug which can block multiple cytokines and it will work in everything. So that is what is the JAK inhibitors, which we call tofacitinib, popular drug tofa, there's that JAK inhibitors. Now what is a JAK inhibitors? Why it is effective in many of, you call it rheumatoid arthritis, they are effective in juvenile arthritis, they are effective in ankylosing spondylitis, they are effective in muscle disease, SLE. So it's like a steroid. Tell me steroid is effective? That's why quacks are so popular. वो कहता ना वो साहब मैं वैद्य की पुड़िया ले रहा था. That is how the JAK inhibitors have come, because they block multiple cytokines. And why they block multiple cytokines? This is a cell, this is a nucleus, and the signal goes from here to there, and this is, in the science word, is called signal transduction. Now, basically there are a lot of pathways for this. This is one pathway. So they are blocking one pathway, they are called as JAK inhibitors, and this is the cytokine, which cytokine comes and this rests on this cell receptors. These are the receptors, and JAKs are activated. So these are the JAKs which are activated, and ultimately what happens, that the nucleus is activated, and once nucleus is activated, a lot of cytokines are formed, and when cytokines are formed, like nucleus has genes and there is gene activation and there is cytokine. So basically you block this. If you block somewhere here, that it will work. So that is how they have done. So they made a drug which can, so this is the drug which is called JAK inhibition. So JAK inhibitor sits here and they block the signal transduction. So that is how it is done, and they reduce the gene production and cytokine production. So we were working on these TNF, anti-TNF, there's that, anti-B cell. Now came JAK inhibitors. The first question patient asks, and even I will ask anybody, safety. So you must, if you're using a drug, anybody can use a drug, whether you're MBBS, MD, DM, whatever. I must tell you, if you're using aspirin, you must read about aspirin. If you don't read, patients are reading much more than you. The time has come, patients are reading much more, and don't brush aside, nahi yaar, ye kuch nahi, wo Google doctor. Nahi. Google, why not? It's a, you answer to that. Otherwise, I always tell patient, yaar kholo to, मैं भी पढ़ूंगा. It's not that कि मैं भी सब कुछ जानता हूँ. कई बार patient बोलता है, साहब मैं एक इंजेक्शन लगा रहा था, एक बार इंट्रा-आर्टिकुलर इंजेक्शन. मैं सोचता मैंने, the world record is 40,000 joint injection. I have given 2 lakhs. So I was always thinking, oh, I'm a big. So he asked me, he was a young IIT graduate. I was giving to mother, कि डॉक्टर साहब इसका कोई साइड इफेक्ट होता है? मैं कह नहीं यार इसका कोई साइड इफेक्ट नहीं होता. मैंने कहा मैंने आज तक नहीं देखा, मैंने 2.5 लाख इंजेक्शन लगाया. He showed me the Google, 1, 2, 3, 4. Then I became more humble. I became more wiser. Whenever people say, I said, look यार Google में खोलो, मैं भी पढ़ता हूँ, कुछ हो नया होगा तो. So safety is very important, and you must accept. SLE, what is happening? Another disease. So I told you about rheumatoid arthritis. I told you about ankylosing spondylitis. I must tell you about SLE. What is happening is, in our time, somebody has a photosensitivity, somebody has a hair loss, somebody has an oral ulcer. That is how we used to diagnose SLE. But today, for our crowd, we must learn that ANA positivity is very important. So entry criteria is ANA. Like कोई कहना diabetes कैसे diagnose होती है? कोई कहता भाई polyuria, polydipsia, ये. But blood sugar तो ज़्यादा होना चाहिए. So entry criteria is blood sugar. So entry criteria for the SLE is ANA positivity. Now that has changed. ANA, like any other, it is a ANA can attack any cell. Cells are present, nucleus is where? Nucleus is ubiquitous. It is present in a hair cell, it is present in your mucosa. So anything can happen. So you can have hair loss because this ANA is attacking your cells here, it is attacking your mouth, oral ulcers, it is affecting your joints, kidney, heart. And I was just reading today because that you can imagine that if somebody has a nephritis, glomerulonephritis 3 or 4, and just it's got a huge point that mostly even one single, he doesn't have fever, he doesn't have a skin manifestation, so lupus can be diagnosed even if somebody has just a kidney biopsy shows class 3 or class 4 nephritis and ANA positivity. ANA positivity has to be there in significant titer. So that has changed about SLE. We started with some criteria and then gradually over a period of time we gave seizures like neurophysicians. I can tell you a lot of people sitting here, somebody has seizures. It has got so much chances of lupus. If a young boy comes with the seizures, must be done ANA. Because seizure is idiopathic less, a young population has more chances of lupus. Somebody has a glomerulonephritis, as I said. Somebody has a acute cutaneous lesions, most likely fever, PUO. So that all those things are for the somebody acute pericarditis. Now, this crowd must know if somebody has acute pericarditis, a young person, the chances are almost 100% you are dealing with the lupus or tuberculosis. So that is the now, what is happening in lupus? I have not come to teach you lupus. Lupus, everybody knows how it is treated. Hydroxychloroquine is steroid. So now people realize it's not working. The lupus is the nephritis and so many, it's not working. So then came the T cell. Now in our time it was talked T cell immunization. So we already knew that T cell does all the things. T cell is it's like a chaser. It has to be somehow modified, so they started giving T cell vaccine. It didn't work. Now came the CAR T cell therapy. You must be reading CAR T cell therapy. This is basically in the word is Shimra, chimeric antigen. Now Shimra is a word for fusion. The fusion. So basically T cell is modified. So you modify the T cell and then tell him to attack there. And that is how the CAR T cell is working. So CAR T cell is, the T cell is modified and then infused and then it goes and that is how the CAR T cell works. Myositis. So another disease is myositis. What is happening? Now myositis is a rare disease. Don't worry about myositis much. Even All Institute Medical Science or Army Hospital or Gangaram, we get about 10 cases or 10-15 cases a year. So I'll skip this. Just remember what is happening in myositis is probably it is confused with the other things. You always feel it is rheumatoid arthritis. So for you, you must remember that beyond the joint, there is a disease which is called inflammatory myositis, which can kill actually. It's a serious disease and a lot of work is going on. Autoantibodies, A, B, C, D antibodies. When I was appearing for DM examination, I just rattled out of these antibodies. The examiner stood up, he was from South, and he said, what A, joke, see the name, see the name of the antibody, Me2, PL7, PL12, SRP, OJ, EJ, all these antibodies, probably youngsters have to learn if he has to appear in the exam for MD entrance also. So myositis specific antibody and myositis associated antibody, which we must learn about that. And this is how the future myositis classification will be both. If somebody is a Me2, he will have more skin involvement. Somebody MD5, some malignancy. And even our generation did not believe it, but that is how the research is. Research won't stop here. It will keep going. Whatever we know it today, tomorrow something else will happen. So that is how the myositis, the ANCA testing. Now ANCA, ANA I think we have learned. We have learned about rheumatoid factor. We have learned about, but ANCA testing also, you must remember for vasculitis, it is important. Vasculitis clinically is like you have a joint involvement, you call it arthritis. If somebody has a vessel involvement, it's called vasculitis, can be small and large. And ANCA testing, it actually further subclassify. So ANCA testing is also a whole lot of story why ANCA has become more important. So very specific antibodies. So this is I'll skip. And of course, a lot of work is going on the vasculitis. This I told you anti-IL-17 story. Scleroderma also a lot of work is going on. And I must tell you this stem cell, because it was done in Army Hospital my time. So we had scleroderma and we had 10, 12 patients who were not doing well. They were about to die actually, very severe ILD. And so this was the work which was done in Army Hospital, stem cell transplant in systemic sclerosis. All 10 people are doing well. This is one died. So this was done long back. It was ANA. This I'll also skip. We know about ANA, but a lot of work is going on ANA. We call it anti-nuclear antibody. Probably we should call it further subclassify, because my title of the talk was what is happening new in rheumatology. So ANA testing is also defined more fine tuning is being done. So that is how the ANA is the maybe artificial intelligence. Today morning I was hearing a lecture on what is going to happen the moment you put a probe of your ultrasound probe, and he will say it is a synovitis, it is this. So that may help you gradually over a period of time. So maybe people who are reporting ANA, they may become probably the intervention. I'll just take 5 minutes more. The intervention, and it is not new, it is old, 2003. We did a lot of arthroscopy. A lot of people say, why you are doing arthroscopy? It is job of, no. The tool is same. It's like वो चोर होता है ना, चोर टॉर्च से दूसरी तरह काम करता है, आप दूसरी तरह काम करते हो. The tool is same, but you can do a lot of good work about, and we published also in the JAPI, we published the medical arthroscopy. In 2004, it was long back, it was editorial by Handa. Chaturvedi and colleagues report their experience with medical arthroscopy in this issue. This is the first set of arthroscopy performed. Intervention in rheumatology. That is happening in other science also. So we did a lot of arthroscopy long back, and we came, yes, it can be done by physician in a local theater. You don't require a GA. It is like a joint injection. You just have to learn how to put this scope inside, which is much easier. So we did a lot of scopies and diagnosed many arthritis like amyloid, onchronosis, hematochromosis, willow nodule. So a lot of other cause of arthritis which could, and artificial intelligence I don't want to discuss because that is in every field it is coming. And this is the last few minutes, that we used to have a lot of patients who had arthritis but used to have swelling in the back. कई लोग आएंगे, आपके mother, sister, they will say कि मेरे पीछे दर्द होता है. You will say नहीं, पीछे कुछ नहीं है. And we used to send, that is in rheumatology called as Baker cyst. जब बहुत ज़्यादा pressure knee में बढ़ जाता है, तो वो जो fluid है पीछे चला जाता है. That is called Baker cyst. And what I learned, radiologists are too busy for this. So what I did, this is how the Baker cyst looks like a football. So in 2000, in this 3, I purchased this machine. This is an old photograph. I was colonel that time, and I started doing ultrasound, and rest is the history. When I went for a workshop in Europe, they said, you have a machine? You are doing yourself? I said, yes, I am doing myself. So we did a lot of ultrasound, and we call it joint probe because I never wanted to fight with the radiologist. Otherwise, they will catch my neck. So I called it joint probe. We started doing and did it. Now still doing for this thing. So joint probe we call it, and it was a self-learning, and this is how it is done. And I'll remove this. I'll just come back to. So this was almost 2003, 2004 when Europeans were learning ultrasound of the joint. We did a lot of ultrasound, and now we are publishing. We didn't publish at that time. I didn't know that I have done a big job. Now we are publishing now, and this was the first workshop I did in Chennai. So I think I have come to the, and that is how the history of ultrasound of joints in this country is starting from 2003. So many things we did, and is it useful? Sometimes people say, is it useful? Or so I'll tell you one example. This was a girl which was diagnosed as rheumatoid arthritis, and she came because she was not responding. We did ultrasound, found a thorn, foreign body, in both the knee. She fell on cycle, and she had come to us to give the biologics. I said, this is a thorn. So this was another case. Our own Gangaram hospital employee who she had swelling like this. I think that, he had a hydrated cyst. This was a cysticercosis in the wrist joint. So this was the first case in the literature, world literature, which even a radiologist came to me, how you diagnose, Dr. I said, no, it's medicine. I always thought this cysticercosis can happen in brain, it can happen in the joint also. This is recently, we presented in our, of course, so many things. My own boss, after retirement, he started driving. He was very honest person. He had a scooter. So long back, he says, I'll drive a scooter. That time car was considered as very, so he suddenly developed pain in the Achilles. So he came to me, I have arthritis. So this was a tear of Achilles tendon. So that is we published also in the, I think this was the patient who had a Gangaram patient, which I thought tenosynovitis, but once I did ultrasound, this was a cysticercosis. So I think this is the patient, that is the, so I think I have come to last slide. I think I have, because I am not marking the time, I'll just come the last slide, I think. So this is the learning about new diseases. Now, the personalized medicine, which probably must be discussed in this forum. I am very sure there are that lot of, suddenly you heard VAXA syndrome, DADA2. What are these? Why sometimes you feel shy of talking to a young person because you feel you are senior, why should I ask it? I'll read it. So basically, the medicine is becoming personalized, means genetic. It's like, वो कहते हैं ना भाई हर आदमी का अंगूठा अलग है, हर आदमी का genes अलग है. So lot of syndromes cannot be classified. They are not known. भाई एक patient है, उसका बाल भी झड़ता है, कान भी टेढ़ा हो गया है, आँख भी बंद है. We don't know what is this. So over a period of time, realize that this is the gene which is causing it. So they start classifying A, B, C, D. So it is the polyarthritis nodosa. Now polyarthritis nodosa, everybody knows. It's a medium vessel vasculitis. Now if it is in young age, and suddenly a young boy comes with the vasculitis, सब stroke हो गया था इस patient को young age में, and over इसके भाई को भी हुआ था. Then you start suspecting genes in the polyarthritis nodosa. That is called DADA2. And when first time I saw a patient in Gangaram, frankly speaking, I couldn't diagnose. He was a VIP, a child. Just I read it. Why a stroke in young? That is written DADA2. I sent to my friend in Chandigarh that the blood test, it was positive. So DADA2. So basically, a whole lot of things are happening at the genes level, and that is how the medicine will progress. Earlier, we knew about phenotypes. कोई कहता है ना कि मुझे ठंड लगती है या ठंड लगती है, बुखार है, गुवाहाटी से आया है, मलेरिया होगा. So diagnosis was, that time was done like this. Then came the blood test, A, B, C, D infection, typhoid, this, malaria. Then came the hormones, then came the cytokines, and then came the personalized medicine, that is the genes. So ladies and gentlemen, I finish here, and thank you so much for calling me. Thanks.
Thank you, sir. Now I request Dr. Ajay Bedi, Secretary DMA, Dr. Kuldeep Dhar, Secretary IMA Noida, Dr. Deepa Gupta, Secretary IMA EDB, Dr. Ashwini Goyal and Dr. B.B. Vadhva, Past President IMA EDB. I request all of you to kindly proceed to the felicitation desk. These are all.
I'll request all the dignitaries here to come on the dais from IMA EDB, the already announced name, from RSDI Secretariat, Dr. Makkar, Dr. J.K. Sharma, from API Noida, Dr. Kuldeep Dhar, Dr. Ajay Bedi, DMA Secretary. All together, we wish to honor you all. Before we break for the lunch, please be on the stage, sir, for a group photograph. That would be fond memory of EDPA, that we all come together for one Delhi, one nation.
We thank you all.
All the organizing team of EDPCon 2023, please quickly on the stage. Quickly on the stage, EDPCon 2023 organizing team. Come on, please.
We thank you all for gracing our conference and accepting our invite. So we want to honor all the respected faculty invitees. Now,
so we break for the lunch, and you can collect yours
delegate kits.
Delegate kits with souvenir from the reception.
And we'll be meeting at sharp 3:15 to start with the next session. I request everybody to kindly be on time so that we can start the session on time. 3:15. Also, we'll be having PG paper presentation here. I request all the PGs to join us for paper presentation. I request Dr. Hemant Sharma, Dr. Saurabh Srivastava and Dr. Ashok Kumar, who is going to judge the paper presentation, to kindly come over. Dr. Hemant and Dr. Saurabh Srivastava.
All the students to be seated in the front rows.
Hello.
afternoon, everyone. Now we are starting paper presentation by postgraduates. We have, for your presentation, you have allotted 5 minutes time to speak.
Okay,
After
sir.
that, you have to just conclude, and only 1 or 2 questions will be done by us. Okay, na?
Yes, okay.
No questions should be asked from the audience.
Okay. Can I start now?
First presentation by Suhail from?
From Saraswati Institute of Medical
Saraswati.
Sciences, Hapur. Myself, Dr. Suhail, from Saraswati Institute of Medical Sciences, and I'm going to present my paper on thyroid hormone profile in patients with fibromyalgia, a comprehensive analysis of TSH, T3 and T4 levels. Fibromyalgia is a debilitating chronic pain disorder characterized by widespread musculoskeletal pain, tenderness, fatigue, sleep disturbances, and cognitive dysfunctions. Despite its high prevalence and impact on quality of life, the underlying etiology and pathophysiology of fibromyalgia is remained poorly understood. Recent researches have suggested a potential link between the thyroid function test and fibromyalgia, implicating thyroid stimulating hormone T3, T4 levels. Thyroid hormone plays a crucial role in regulating metabolic processes, include energy production, thermoregulation, and protein synthesis. Altered thyroid function has been associated with a range of musculoskeletal and neurological disorder, making it a plausible candidate for investigation in fibromyalgia. Previous studies have reported conflicting findings regarding thyroid hormone levels in fibromyalgia patients, necessitating a comprehensive and systematic analysis of T3, TSH, and T4 levels. My study design is cross-sectional study. I have taken the 200 participants, 100 cases and 100 are the controls. Inclusion criteria of fibromyalgia patient included diagnostic according to the American College of Rheumatology based on the use of two scales, the WPI and SSS scale. Control participants were recruited from the attendant of the patients and screened for the absence of chronic pain conditions. Biochemical analysis, fasting blood, venous blood samples were collected from all the participants and serum was separated from analysis of TSH, T3 and T4 levels using the standard immunoassay. Clinical assessment, fibromyalgia patient underwent comprehensive clinical assessment including pain scores using the VOS score, fatigue levels using the MFI score inventory. Statistical analysis, statistical comparison were performed using the independent t-test for the continuous variable respectively. Subgroup analysis were conducted based on TSH and T3 levels. P-value less than 0.05 with 95% confidence interval was considered for statistical significance difference. The result of my study is that in the fibromyalgia patients, the TSH level is comparatively high and T3 level is comparatively low. There was no significant difference observed in the T4 level between the two groups. This is a VOS score for among the patients with fibromyalgia. Subgroup analysis revealed that fibromyalgia patient with elevated TSH level has significantly higher pain scores compared to those with normal TSH levels. And MFI score, additionally fibromyalgia patients with reduced T3 levels reported significantly higher fatigue levels compared to those with normal T3 levels. The study provides compelling evidence of altered thyroid hormone levels in the fibromyalgia patients with elevated TSH and reduced T3 levels being associated with severe clinical manifestations. These findings underscore the importance of thorough thyroid function assessment in the clinical management of fibromyalgia and suggest a potential avenue for the targeted therapeutic interventions. Further, the research is warranted to elucidate the underlying mechanism and explore the potential benefits of thyroid hormone modulation in the fibromyalgia patients. Thank you, sir.
What is your recommendation after your study? Fibromyalgia patients, your group has slightly higher TSH level than the normal ones. This is your conclusion.
Yes, sir.
So can you recommend thyroid hormone therapy for them?
No, sir. Initially, if the symptoms are less, we are not giving any thyroid hormone therapy to these patients.
How many gross hypothyroid patient after you got in the fibromyalgia?
Actually, in fibromyalgia patient, I am not research on the thyroid patient. I am researching on the fibromyalgia patient. In these fibromyalgia,
you did to take out the fibromyalgic patient, and
yes,
then you did TSH level, na? That is what you have done. You must have got some higher levels of substance.
more than 10.
Have you grouped them?
No, no, sir.
You should have presented here how many fibromyalgia
No,
have
no.
subclinical. In that case, subgroup you might have recommended third hormone therapy. That and you have to see the effect also.
Yes, sir. Maybe there are.
Have you compared a study with the other studies also in the world? Has this study been done previously by anyone in this?
No, sir.
No past studies in this? Well, have you compared a study with any study done anywhere in the world or India?
Yes, sir. I have some evidence. I have some studies in my mobile phone. For that.
Results are similar or different?
Results are similar, sir.
So there are less studies in India, that's why you did the study here, no? But that means there are less studies done in India, that's why you have done this study.
Yes, sir. I have references also in that. Sorry.
Okay, fine, thank you.
Thank you.
Good morning, sir. Good morning, everyone. Yes, sir. Yes, sir. Good morning, everyone. My presentation is on iron profile in diabetes mellitus and its relation with HbA1c. Introduction. Diabetes mellitus refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. Diabetes mellitus has several categories including type 1, type 2, maturity onset diabetes of the young, gestational diabetes, neonatal diabetes, and secondary causes due to endocrinopathies, steroids use, etc. HbA1c is glycated hemoglobin that is used as an indicator of a patient's glycemic status over the previous 3 months. There is currently no evidence that HbA1c serves any physiological purpose. Iron deficiency is a condition in which the iron content of the body falls below normal levels. The first stage of iron deficiency is iron stores depletion, in which serum iron, transferrin saturation, and hemoglobin levels are normal, but iron storage is reduced or absent. The subsequent stage is iron deficiency without anemia, which is marked by depletion iron stores, low serum iron, and transferrin saturation, but not anemia. Anemia due to iron deficiency is the farthest progressed stage of iron deficiency. It is distinguished by the lack of iron stores, low serum iron levels, and low transferrin saturation, in addition to low hemoglobin levels. In region where meat consumption is low, food is not fortified with iron, malaria, intestinal infections, and parasitic worms are prevalent, and women and children are disproportionately affected by iron deficiency anemia. Serum ferritin concentrations represents total iron stores. It is possible for the serum iron ferritin level to drop as low as 10 mcg per liter when a person has iron deficiency. In inflammatory disorders such as rheumatoid arthritis, chronic kidney disease, and malignancy, the ferritin concentration is significantly increased, and normal range for serum ferritin varies depending on the individual's age as well as their gender. Aim: effect of the iron deficiency anemia on HbA1c in patients suffering from diabetes mellitus. Objective: to observe and analyze the effect of RBC indices on HbA1c1 in diabetics, to study how HbA1c is a crucial marker for diagnosis of diabetes and its deciding treatment plan. Material, the method, study place. The study was conducted in Department of Medicine, Santosh Medical College, Ghaziabad. Study frame: study was observed in diabetes mellitus patient who was attending the medicine OPD on Santosh Hospital. Study design: cross-section study. In this study, as we want to observe and analyze iron deficiency anemia in diabetes mellitus and its effect on HbA1c, therefore, in order to calculate the sample size, we need to have the estimated prevalence of type 2 diabetes mellitus as well as prevalence of iron deficiency anemia in type 2 diabetes mellitus. Methodology: we are going to do HbA1c, FBS and PPBS, ferritin, transferrin saturation, iron and TIBC. Inclusion criteria are HbA1c more than or equal to 6.5, fasting plasma glucose equal or above 126 mg per dl, 2 hours plasma glucose ranging 200 mg per dl or above, random plasma glucose ranging 200 mg per dl or above, where random is defined as blood glucose without regard to time since the last meal. Exclusion criteria: failure to obtain informed consent, pregnancy, and type 1 diabetes mellitus. Results and observations: out of 56 patients, 32 were diagnosed as anemic, less than 12 and less than 13 female and males respectively, with a mean of 53, whereas 24 had normal hemoglobin. Participants' mean age was 51 years old, mean HB was 11, HbA1c was 9, serum iron levels were 66.91, ferritin was 291, and eGFR was 67 respectively. In our study, it was found that 57% of patients had anemia, out of which 62 were normocytic and normochromic, and 38 were microcytic and hypochromic, and non-anemic cases were found to be 43%. The mean eGFR of patients with anemia was 63.13 plus minus 18, and non-anemic was 72.92 plus minus 17. There was a moderate positive correlation between eGFR and HB values. Between HbA1 and iron profile, it was positive correlation. No significant statistical correlation was found between eGFR and type of anemia, which in our case was microcytic hypochromic and normocytic normochromic. There is a table showing descriptive status of variables of anemic patients. Another table showing descriptive statistics, clinic variables of non-anemic patients. A bar graph showing mean age of case and control subjects and hemoglobin against case and control in subjects. Discussion: the HbA1c fraction of hemoglobin A1 is bar 5. Conclusion: the results of our research indicates that diabetes patients with iron deficient anemia do not have any changes in their HbA1c. Thus, HbA1c may be used in making treatment decisions for diabetes mellitus even when iron deficiency anemia is present. Given how common IDA is in India, our study suggests that measuring iron, Hb, and HbA1c simultaneously may be optional to get a good idea of glycemic status. Some studies have found that people with IDA have much higher HbA1c level than people with diabetes who don't have IDA. However, other studies have shown that monitoring these people with HbA1c could be misleading because their real HbA1c levels could be less or more than the true value. Anemia caused by lack of iron and diabetes is a widespread health concern. Therefore, iron deficiency is a significant factor in diabetes diagnosis and therapy. Even though this topic has only been studied in a few studies, many of which had relatively small sample size, in which evident more research into relationship between anemia and HbA1c is warranted. As demonstrated by the studies discussed, more evidence is needed to guide doctors and scientists on handling anomalies and erythrocyte indices in clinical practice. While more information is being collected, we have come up with few suggestions for making
Devansh, have you excluded hemolytic anemias in this patient?
Sir?
Patients of hemolytic anemias you have excluded in this study?
Yes, sir.
But your exclusion criteria doesn't mention this, you know?
Yes.
So few studies show that in IDA, HbA1c is higher as compared to normal this thing, but
Yes,
your
sir.
studies is not
Yes, sir.
finding with this.
Yes, sir. So major studies show that there is no change, but very few studies are showing that there is a change. It may vary.
Okay, thank you.
Thank you, sir.
Dr. Prashant, Jay, Srinivas, Akshat, Abhishek, and Vikas, please load your presentation and come in the front row.
A hearty good afternoon to everyone sitting over here. Today I am presenting my paper on this to study the profile of metabolic syndrome in young patients of acute coronary syndrome. Young patients with ACS on coronary angiography shows a relative increased incidence of single vessel disease and non-obstructive stenosis. The risk as well as the clinical factor profile and the arterial involvement pattern differs between young and elderly CAD patients. Metabolic, genetic, and conventional causes may result in CAD occurring at a younger age in India. In India, the prevalence of acute MI in this population is between 2 to 10%. Now, the material and methods for the study were, it was a cross-sectional study performed in Department of Medicine in LRR Medical College Meerut, and we took a sample size of 120 patients attending medicine OPD, IPD, or cardiology OPD as per the criteria. Inclusion criteria include people who give consent, age between 18 to 45 years, and patients having acute coronary syndrome. Exclusion criteria include patients on anti-lipidemic drugs, patients with impaired renal function, cardiomyopathies, and patients with thyroid dysfunction, and pregnant patients. Procedure: a pre-structured performer was filled up for the study. Each subject was given a thorough workup for history and physical examination To fulfill the inclusion and the exclusion criteria, routine hematological and biochemical investigations were carried out, which included CBC, fasting lipid profile, blood sugar, fasting, postprandial and random blood sugars, HbA1c, kidney function test, serum electrolytes, liver function test, PTINR, and a 12-lead ECG along with the cardiac markers. Results of this study were distribution of participants in terms of metabolic syndrome. In 48.3% of the participants, metabolic syndrome was present, and in 51% of the participants, metabolic syndrome was absent. These are the graphs which are showing the distribution in percentage and in the frequency. Distribution of participants in terms of raised BP were 29.2% of participants has deranged blood pressure, and 70.8% of participants have the blood pressure within the normal limit. Distribution of BP in patients with and without metabolic syndrome were 51.7% of the patients in the group having metabolic syndrome have deranged BP, and 48.3% of the participants in the group having metabolic syndrome has BP within normal limit. 8.1% of the participants in the group not having metabolic syndrome have deranged BP. 91.9% of the participants in the group not having metabolic syndrome have BP within normal limit. There was a significant difference between the various groups in terms of distribution of BP, that is p-value less than 0.001%. Distribution of participants in terms of triglycerides. 83.3% of the participants has deranged triglyceride. 16.7% of the participants had do not have the triglyceride in deranged values. Association of triglyceride with patients with and without metabolic syndrome. 93.1% of patients in the group having metabolic syndrome had deranged triglyceride. 6.9% in the group having metabolic syndrome have triglycerides within normal limit. 74.2% of the participants in the group not having metabolic syndrome had triglyceride deranged, and 25.8% of the participants in the group not having metabolic syndrome had triglyceride within normal limit. There was a significant difference between the various groups in terms of distribution of triglyceride, that is p-value equals to 0.005%. Distribution of participants in terms of waist circumference, which was taken less than 14 minutes. 48.3% of the participants has deranged waist circumference, and 51.7% of the participants had normal waist circumference. In the group having metabolic syndrome, 72% of the participants has deranged waist circumference, and 27.6% of the participants had normal waist circumference. 25.8% of the participants not having metabolic syndrome had deranged waist circumference, and 74.2% had the waist circumference within normal limit. It was also significant with p-value less than 0.001. Distribution of participants in terms of fasting blood sugar. 28.3% of the participants have deranged fasting blood sugars, 71% were normal. In the group having metabolic syndrome, 32.8% of the participants has deranged fasting blood sugar, and 67.2% have normal fasting blood sugars. 24.2% of the participants in the group not having metabolic syndrome has deranged FBS, and 75.8% had fasting blood sugar normal. There was no significant difference between the various groups in terms of the fasting blood sugar. Yes, sir. In terms of HDL, 39.2% had deranged HDL, and 60.8% has the HDL within the normal limit. To conclude, we can say that the prevalence of the metabolic syndrome in young patients presented with acute coronary syndrome was found to be around 48.3, out of which the highest out of the components of the metabolic syndrome, triglyceride level was the commonest component which was elevated, that was 83.3%. When the full spectrum of the various etiological factors and the risk markers for the cardiovascular disease in the metabolic syndrome is uncovered, we can effectively implement preventive strategy in the community on a wide scale.
Have you compared your study with the past study?
Yes, sir, I have compared.
So,
Sir,
was it
past studies have shown this same data with 64.8% patients having acute coronary metabolic syndrome, sir.
You have used a terminology like deranged.
Yes, sir.
It is not a better terminology. You can have like hypertension or hypotension. You can have mentioned how many of the patient is hypertensive or hypotensive. So it is not derangement. It is beyond. It is you have to devise something. It is whether they are hypertensive or not. So what do the audience understand with the derangement?
Sir, derangement. Sir, according to the definition of metabolic syndrome of NT.
Hypertension, you have mentioned deranged. Why? It could have better terminology.
Can be hypertension also, no?
Yes, sir.
So what is the implication of your study? What is the final message to the after your study?
Sir, final message is that metabolic syndrome possesses a great risk for the young patients in ACS, and out of which triglyceride is the most important factor. So, but more studies are needed so that we could come to any conclusions.
But if we see the most important factors are like hypertension or diabetes could have been the most important, other in the other study, most of the studies. But in your study, it comes out to be TG.
It comes out to be, sir, triglycerides.
Okay, thank you so much. Next presenter,
Dr. Prashant.
Prashant, to kindly come. See, your timer is in front of you. Just stick to your time, please.
Yes, sir. Good afternoon, sir. Today, I, Dr. Kodala Prashant from SIMS Hapur, and today I am presenting paper on very commonly seen but very threatened complications, hypoglycemia in elderly patient with risk factors. Start with the introduction. Elderly patients have a reduced physiological response to hypoglycemia due to several precipitating factors. Hypoglycemia can even cause nocturnal death apart from its disastrous effect on brain and heart. Even though there are guidelines to keep HbA1c level at a flexible range in elderly patients, hypoglycemia still remain the major complications. My aim of this study was to analyze the various risk factors predisposing to geriatric population with the diabetes mellitus to hypoglycemia in comparison with the age and sex matched control who did not experience ever hypoglycemia. The method and material used is 50% who experience hypoglycemia was enrolled as a study group, and 50 age and sex matched patients formed to a control group. Patients whose age was more than 60 years, know to have diabetes mellitus, and those with the blood sugar level less than or equal to 70 mg per dl was included in a case of this study. These patients were admitted in a hospital with the hypoglycemia or developed hypoglycemia while in the hospital. Study pro forma include the detail of the age, demographic, duration of the diabetes mellitus, detail of the treatment of diabetes at a time of hypoglycemia, detail of the hypoglycemic episode like symptoms, severity, glucose level, identification of the risk factor, treatment, outcome, comorbidity, and polypharmacy and alcohol use. The result is there were 21 male and 29 female in the both group with a mean age of the 68 year plus or minus 5 year. In study group, the most commonly used sulfonylurea was glimepiride 31%, followed by gliclazide, glipizide, and glibenclamide. 29 patients were brought to the hospital with hypoglycemia, and 21 developed hypoglycemia while in the hospital. Of the 50 patients were asymptomatic and low glucose level and determined routine monitoring. 10 patients have autonomic symptoms and neurological symptoms, and 9 patients have both neurological and autonomical. 40 patients were treated with IV dextrose, 6 with oral, and 4 with the dose adjustment of the medicine. All of the patients recovered without any observed sequelae. Infection and renal failure was statistically significant of the precipitating factor. Mean HbA1c was lower in a patient who experienced hypoglycemia. 6.33 study group versus 7.61 in a control group, and correlate with the major clinical trials such as ACCORD, ADVANCE, VADT, and SDIS, where they have demonstrated up to the 3-fold risk in patients of intensive glucose control. In our study, duration of the diabetes was noted to be significantly higher in the study group compared to the control group. association between the asymptomatic hypoglycemic episode and duration of the diabetes has been observed in UK hypoglycemic study. In our study, infection emerged as a major risk factor of the hypoglycemia. This is important as infection in the elderly may not manifest with the florid feature as in the young adult. Hence, tight glycemic control and precipitating factors may result in a low blood glucose level in a geriatric population irrespective of the drug regimen. Conclusion is awareness of the risk factor of the hypoglycemia is a cornerstone in the management of the diabetes in elderly. Over treatment of the diabetes is a major risk factor for the hypoglycemia in elderly. HbA1c target level in a geriatric population should be set as modified by the ADA based on the patient compliance without compromising the quality of the life. Early anticipation and prompt treatment of the infection can prevent hypoglycemia in elderly. Thank you.
Liver disease and
Yes,
dementia
sir.
in your
Liver,
patient?
हाँ, but majorly sir इसमें देखने को मिला है जिसमें infection हो and chronic renal failure as well as liver CLD, CHF इन सब में भी मतलब देखने को मिला.
So your was commonest was infection, you say?
हाँ, common is मतलब I saw infection on medication पे है, oral hypoglycemic medication पे है और वो घर पे ट्रीटमेंट ले रहे हैं, साथ में अचानक से इन्फेक्शन हो जाता है, हाइपोग्लाइसीमिया के साथ बहुत बार प्रेजेंट हुआ है विथ न्यूरोलॉजिकल सिम्टम्स.
What are the control groups?
कंट्रोल ग्रुप सेम सर एज वाले, बट वो जिन्होंने कभी हाइपोग्लाइसीमिया पहले नहीं हुआ है.
You have not mentioned regarding the control group. What controls you have taken? Mention नहीं किया आपने. You have taken control group. Control group में specification क्या है?
More than 60 years who never experienced hypoglycemia before that.
Diabetic patients.
Diabetic, हाँ.
That you have not mentioned in your slides.
Okay.
But you have not. I think if you have presented some of the graphs and tables of what are the that would have been made to present it quite good. So that was the missing from your presentation.
Okay, sir.
Okay. Thank you very much.
Thank you, sir.
Next presenter is Dr. Jai Patel.
Good afternoon, sir. Today my topic of presentation is Indian Diabetic Risk Score as a screening tool for assessment of opportunistic screening of type 2 diabetics patient. Sir, introduction. Diabetics, a global epidemic, involves elevated blood sugar causing long-term damage to vital organs, presently affecting 425 million worldwide. Projection estimate the rise to 629 million by 2045. The Indian population faces a highlighted diabetic risk due to genetic predisposition and unhealthy lifestyles, making it the second most prevalent disease, impacting 73 million individuals with an 8.8% adult incidence. Indian Diabetic Risk Score as a valuable tool for assessing and categorizing diabetic risk. Together, let's unravel the complexities of diabetes, understand the risk factors, and discuss the strategies for early identification and prevention. So, aim of the study is Indian Diabetic Risk Score as a screening tool for assessment of opportunistic screening of type 2 diabetes patient. Objective correlation of Indian Diabetic Risk Score with other study variables including age, physical activity score, waist circumference, BMI, waist, hip, mean blood pressure, and random blood sugar levels. So study design is a cross-sectional observational study. Study place was conducted in Department of Medicine, Santosh Medical College and Hospital, and study was done in all population who attended medicine OPD of Santosh Hospital, fulfilling the inclusion and exclusion criteria below. So inclusion criteria includes age above 25 years, study population attends medicine OPD, both genders were included, and RBS and other anthropometric parameters was assessed for all patients attending OPD basis. Exclusion criteria is that we have not done HbA1c level, blood sugar, fasting and postprandial, failure to obtain informed consent, age below 25 years, recent MI, stroke, surgery in last 6 months, patient with known case of diabetes mellitus or those who need urgent need of medical attention. So 503 patients meeting inclusion criteria selected, underwent detailed history and examination, and vitals were taken, underwent investigations like RBS score, RBS second anthropometric parameter, and third is IDRS score calculation. So IDRS score is one of the best indicator of incident diabetes in India, is the Indian diabetic risk score. This is a streamlined risk score that uses 4 basic factors: 1, age; 2, waist circumference; 3rd, family history of diabetes; and 4th is activity. So result, total number of study population was 503. So the result indicate that in terms of age, the majority fell within the 30 to 40 years of age, and 28.2% are below, falling in the age of 40 to 50. Gender wise, there was a more female 63.8% than males 36.2%, and most of the subjects resided in urban areas as opposed to rural areas. In terms of physical activity, a significant portion reported rare exercise, slight work, while 21.5 reported no physical exercise. So this is table 1 showing distribution of study subject according to risk of diabetes according to IDRS score. So out of 503, 92 patients fall in the low risk category, 155 in medium risk, and 256 are high risk. And this table 2 showing correlation of IDRS score with other study variables. Includes positive correlation between age, physical activity, other anthropometric parameters, and RBS, except waist hip ratio. So this is the table showing that out of 503 patients, I have found 94 are diabetic. Newly diagnosed diabetes are 14 patients, and impaired glucose tolerance is 70%, and normal out of 325 out of 503. So continued in a summary, the IDRS score showed significant correlation with several study variables, including age, physical activity score, waist circumference, BMI, mean blood pressure, and RBS levels. These findings provides a valuable insight into a relationship between these variables and a risk of diabetes in the study population. So this is the article published before, shows also similar results, but they have done sequential screening, and in conclusion, the IDRS is a straightforward and practical tool for early screening that is accessible even in remote location. And this study also shows a person's diet, lifestyle choices can have a significant impact on their risk of having diabetes, as evidenced by the finding that participants with sedentary lifestyle and high BMI values had a higher risk of developing diabetes. Thus, utilizing IDRS for early risk assessment and implementing small lifestyle changes lessen the financial impact. Thank you.
So what is the learning point from the study? What do you recommendation to the society for this,
Sir, learning point is, sir, by doing this scoring, we can minimize the economical burden, and those who are only at high risk, only those who are getting investigated further for further evaluation for diabetes.
This can be very useful screen tool in school also,
Yes, sir.
Especially when India is getting a capital of diabetes day by day. And when you compare with other studies of India also, what is the population you have catered which comes to your hospital only, Have you compared this study with other community-based studies also?
Yes, sir. This was study which I have read, I have gone through. That is also showing they have gone, sir, sequential screening. First, sir, first they have done IDRS score. Then secondly, they have done IDRS scoring with RBS. And then on sequential screening, they have gone through IDRS, RBS, sequential screening. So, sir, in that case, sensitivity and specificity is higher than sensitivity when they have done a sequential screening.
Okay, fine. Thank you.
Thank you, sir.
Yes. Next participant.
Next is Dr. Srinivas to kindly come and give his presentation.
Good afternoon, everyone. Today I'm going to present. Today I'm going to present on topic SOFA score, Q-SOFA score, and procalcitonin as predictor of outcome in patients of sepsis with diabetes mellitus and without diabetes mellitus. And sepsis is defined as a life-threatening organ dysfunction owing to dysregulated host response. And sepsis is associated with 1/10 of a mortality within a hospital, as diabetes is very prevalent and potential condition that alters the critical elements of sepsis pathophysiology. That is why diabetes is likely an important comorbid condition in this disease. At the exact influence of diabetes on infection and the development of sepsis remain undefined. That's why I'm doing this study, and my primary objective is to determine the SOFA and QSOFA score in patients of sepsis in diabetes and non-diabetic, and to determine the procalcitonin levels in patients of sepsis with diabetes and without diabetes. And my secondary objective is to compare SCOFA, QSCOFA and procalcitonin with the hospital outcome of the patients with sepsis. And my study is an observational cross-sectional study, and I selected my patients based on the sepsis 3 guidelines, fulfilling 2 out of the 3 criteria. All subjects who agreed to participate in the study will be provided a written informed consent, and all the subjects will undergo detailed clinical history, examination, routine blood investigations, and along with PCT. And the sample for the result will be drawn within 24 hours of admission. And the outcome will be recorded, and data will be collected and will be analyzed statistically. And this, I have collected the data from total 100 patients, which includes 60 patients from non-diabetic group and 40 patients from diabetic group. In this study, the SOFA score, I divided the patients into 3 categories with SOFA score as 0 to 6, 7 to 12, and greater than 12. In this study indicates that patients of diabetes, the mortality is more in patients with diabetes at a low SOFA score compared to patients of non-diabetes. And this is regarding QSOFA, and the results indicate that the mortality rate is much in patients of diabetes as compared to non-diabetics at low QSOFA. And this is regarding procalcitonin, and this I divided into 3 groups based on the levels 0 to 10, greater than 10 to 20, greater than 20. And this also indicates that the patient is having more mortality at low levels compared to patients of non-diabetics. Unfortunately, there is no gold standard for diagnosis of sepsis. SOFA score helps in premature identification of potentially fatal infection. As the mortality is more in cases of sepsis, which early identification and decision making is very important. And in my study, I came to know that in patients of diabetes, even the SOFA score, QSOFA score, and procalcitonin are less. We should treat them aggressively for better outcome of the patient. And thank you.
So in your study, obviously diabetic patient has shown poor outcome. So how does your study matter? So what is your message from your study?
Sir,
how is going to affect the diabetic or non-diabetic population for future? Yeah, you want to have further one?
Sir, I just want to tell that the patients who are presenting to the emergency in sepsis who are diabetic, I want them to treat aggressively for better outcome of the patient. As the prognosis is poor in patients of diabetes compared to non-diabetics, I just want them to treat aggressively and with better judgments.
So what is the difference between the SOFA score of diabetics versus non-diabetic in
Sir,
your study?
The SOFA score, sir,
are they higher or lesser, or significantly higher or not?
Sir, in patients of diabetes, in my study, I observed that at low SOFA score, there is much more, the prognosis is not that good as compared to non-diabetes. And due to, sir, as diabetes also causes end organ dysfunction, it can already, it deteriorates the prognosis of the patients.
Presence of diabetes, you mean to say that even in the lowest SOFA score, diabetic patients are performing bad.
Okay.
That is your message.
Thank you.
Thank you. Dr. Akshat to kindly come and do his presentation.
Good afternoon, sir. Good afternoon, everyone. Today I am presenting the case of my thesis on to study the prevalence and prognostic significance of microalbuminuria in non-diabetic ischemic stroke. Microalbuminuria is defined as increase in the urinary albumin excretion ranging from 30 to 300 milligram per 24 hour or 30 to 300 milligram per gram of creatinine on spot urine sample. Association of microalbuminuria, marker of vascular endothelial dysfunction, an important prognostic marker for kidney disease in diabetic mellitus, in hypertension in post-streptococcal glomerulonephritis. Increasing microalbuminuria during the first 48 hours after admission to an intensive care unit predicts elevated risk for acute respiratory failure, multiple organ failure, and overall mortality. A risk factor for venous thromboembolism. Stroke is one of the leading causes of mortality and morbidity in adults worldwide, posing serious medical, socioeconomic, and rehabilitation problems. WHO defines stroke as a rapidly progressing, developing clinical signs of focal disturbance of cerebral function lasting for more than 24 hours with no apparent cause other than the vascular origin. Stroke, also called the brain attack, because it involves an insult to the brain, is a major disabling disease. Numerous risk factors has been found to be associated with an increased occurrence of stroke, but the realization that the atherosclerosis is an inflammatory disease has led to the search for the new stroke risk factors and treatment. The markers of inflammation like C-reactive protein, lipoprotein-associated phospholipase A2, elevated WBC, interleukin, endothelial nitric oxide synthase, homocysteine, renin-angiotensin system, fibrinogen, lipoprotein, etc. have been proposed as a new risk factors for stroke. One of a more addition to the growing list is microalbuminuria. Many studies were conducted in different parts of the world to determine the potential use of microalbuminuria as a marker of stroke risk. Aims and objectives to study the prevalence of microalbuminuria is in non-diabetic acute ischemic stroke patient to correlate the degree of microalbuminuria with the severity of stroke, to evaluate the prognostic significance of microalbuminuria by comparing the patients with microalbuminuria and patients without microalbuminuria with calculated NIHSS and MRS score. This is cross-sectional study. 50 cases of non-diabetic ischemic strokes were taken. The inclusion criteria: patient of any age, both sexes, were with the first time ischemic stroke within 72 hours of onset of symptoms. The diagnosis of stroke being established by the WHO definition of stroke, and ischemic lesion is confirmed by the CT scan, brain, and MRI. Exclusion: diabetic mellitus, intracranial hemorrhage, earlier renal insufficiency, neoplastic disease, inflammatory rheumatic disease, pregnant women, or oral contraceptive patient. The routine investigation, urine ACR was the investigation most important one was done, and MRI and NCCT were other investigations. Results: comparison of mean urine ACRs with MRS score of study groups. Group A were non-diabetic ischemic stroke patients with microalbuminuria. Group B were the non-diabetic ischemic stroke patient without microalbuminuria and then correlated with the MRS score. The comparison of the mean urine ACR with mean NIHSS score between the study groups were: mean group of NIHSS score of group A was 19.9 plus minus 3.59, and group B was 10.37 plus minus 3.145. It was found that the correlation between the NIHS score and urine ACR ratio has been significant, p-value of less than 0.01 in group A, but no such correlation was seen in group B.
Akshat, kindly conclude, please. Kindly conclude.
Yes, sir?
Kindly conclude.
Okay. So it was found that urine albumin excretion has the strongest correlation with the NIHSS score of the patient in AI stroke. Those with a higher NIHSS score has a higher rate of urine albumin excretion and vice versa. The presence of microalbumin is associated with higher MRS, and the higher the MRS score, higher the urine ACR level, and vice versa. Same was seen in the both NIHSS and the MRS score compared to the absence of the microalbuminuria.
Thank you. Dr. Vivek would like to answer a question from you. Any question from your side, Dr. Vivek? Yeah. Any question?
So what is the learning point from the study right now?
So we have defined a cheaper marker like urine microalbuminuria for seeing the further prognosis, or further we can detect the patient can undergo for stroke or not. So this is a marker we can earlier see in patients. Okay, if there is an endothelial injury.
Your results are as compared to other studies and
yes, sir. They were when in different parts of the world when the study was done, results were same.
We can say कि prognostic marker अभी तो validation as such तो नहीं है.
So,
it need to be validated by the larger study, I guess.
Yes, sir. It's not validated, but the studies when done in different parts of the world, results were same. So it is an upcoming marker, ma'am, sir.
Okay, thank you.
Thank you, sir.
So moving to the last presentation, I invite Dr. Vikas to kindly come and do his presentation. Kindly finish your presentation as early as possible. Less than 5 minutes.
Good afternoon, sir. So a very good afternoon to all of you. Myself Vikas Kumar, and I am a final year MBBS student from AV WIMS and Dr. RML Hospital. So I am here presenting my research paper, which is on the pulmonary artery hypertension in patients of cirrhosis with portal hypertension and its association with other cirrhosis-related complications. The portopulmonary hypertension is a well-known complication of liver cirrhosis. In order to say the patient is suffering from POPH, it needs to follow all the three criteria that is mentioned below. The first is mean pulmonary arterial pressure should be greater than 20 mm of Hg. The second one is mean pulmonary capillary wedge pressure should be less than 15 mm of Hg. And the last one, that is the pulmonary vascular resistance should be greater than 3 Uts unit. However, another complication of liver cirrhosis is pulmonary arterial hypertension, which requires two criteria to be diagnosed. The first is MPAP greater than 20 mm of Hg, and the second one is the PVRI greater than 2 Uts unit. So, it has been proposed that in liver disease, the pulmonary vasculature may be exposed to vasoactive substances that are normally metabolized by the liver. But in cases of liver cirrhosis, since the hepatocytes are not functioning well, these vasoactive substances enter the lungs through portosystemic or portopulmonary channels and leads to vasoconstriction or damage to the walls of small pulmonary arteries. The symptoms of PAH are non-specific, that are basically the exertional dyspnea, fatigue, weakness, chest pain, lightheadedness, syncope, and less frequently the cough. The diagnosis of PAH can be done by Doppler 2D echo, but right heart catheterization continues to be the gold standard. Currently approved therapy for the PAH, that is pulmonary arterial hypertension, consists of drug that enhances the nitric oxide GMP pathway, that is basically the sildenafil or tadalafil. The second one is the prostacyclin pathway agonist, for example epoprostenol, and the third one is the endothelin pathway antagonist, example like bosentan. So most of the studies have been done on the POPH in liver disease patients. As it has been noted, even the PAH, that is the pulmonary arterial hypertension, can have adverse transplant outcomes in the cirrhotics and on their overall prognosis. So a recent report from the US-based Reveal registry supports the notion that patients presenting with POPH have a worse outcome than those with idiopathic pulmonary arterial hypertension. Given the poor prognosis associated with POPH and the limited medical therapies available, liver transplantation has been proposed as a means of potentially preventing disease progression and providing an opportunity for pulmonary hemodynamics to normalize. So this study aims to find the occurrence of PAH in patients of cirrhosis with portal hypertension and assess the association of PAH with other complication of cirrhosis having portal hypertension. So there is hardly few studies worldwide which has evaluated PAH in liver cirrhosis along with portal hypertension. In India, no such study has been conducted. That is why we are presenting this. Now moving on to the methodology part. So our inclusion criteria was patients of any gender with cirrhosis and portal hypertension, either newly diagnosed or pre-existing, irrespective of the etiology of CLD and portal hypertension. And their age should be between 80 to 70 years of age. Now, the exclusion criteria were the patients with cirrhosis without portal hypertension and those having...
Because kindly go to the conclusion, what you have concluded from the study, because this is thick, we know all that.
Okay.
So just go to conclusion.
So from all this study, we have concluded that in Indian setting also, most of the patients who have developed liver cirrhosis as well as portal hypertension, they are not follow-up or they are not given initial treatment. So by the time the patient develops POPH, that is the portopulmonary hypertension, and when the patient develops POPH, it is associated with poor prognosis, and the only medical treatment that is left, that is the liver transplantation. So in other cases, if we start following up the patient with the 2D echocardiography that can be done, that can be used to calculate the MPAP to find out whether the patient is suffering from PAH or not, and start the medication early in those group of people, then we can decrease the...
Right, so what you have done, right, what is the study conclude like in your patients?
So we have concluded in our study that we should follow up the patient periodically so that we can start the treatment early in those patients so that we can increase the survival rate as well as decrease the mortality of those patients.
I think it's a compliment because he's a final year MBA student and he is a student of our own Dr. Nitin Sinha, So Nitisana requested us to present, and I think it's a great platform for the students to come up with this novel ideas. I think you have done a very good study. I've read your study.
Thank you so much.
It's compliments for our side. Thank you very much.
Thank you so much.
We thank all the presenters, presenting students who has presented the presentation. They all did very well. And we hand over the mic to the organizers for the next session. Over to Dr. Anvita. Thank you.
The result will be announced in the evaluatory function after the 3 sessions. Thank you.
Thank you, sir. I would like you to hold on. I would call up Dr. Makkar, sir, to kindly felicitate the judges for the poster presentation. So, moving on, welcome back from this delicious meal, and we will be now starting our neurology session. So, as we all know, chronic migraine causes severe reductions in quality of life, and it is a very debilitating disorder. So, here we shall be discussing the various pharmacological and non-pharmacological interventions for chronic migraine by our eminent team of neurologists. So, I hereby call upon our chairpersons to please come up on the stage. Dr. B.K. Gupta, sir. Dr. Vijay Arora, sir. Dr. K.S. Anand, sir. Dr. Rajiv Lochan, sir. And Dr. Vivek Kumar, sir. I request our chairpersons to kindly introduce our speaker.
Hello. Thank you, Dr. Anvita. Without wasting time, so the topic has already been introduced, recent advances in management of chronic migraine. As we all know that the migraine is the most common headache in neurology practice, and as the episodic headaches keeps on increasing in frequency, it becomes chronic. So to deliver a talk, we have eminent speaker, Dr. Ashish Duggal. He is Associate Professor of Neurology at ABWIMS and RML Hospital, formerly Associate Professor of Neurology at G.V. Pant Hospital, and has been trained at Australia New Zealand Headache Master's School, Sydney, 2018. He has over 50 publications in peer-reviewed national and international journals and has been convener of headache subsection of Indian Academy of Neurology. He is a executive member of Delhi Neurological Association and awarded the Eminent Medical and Health Education Teacher Award by DMA. So with these words, I request you to deliver your talk.
Thank you, sir. Thank you for the kind introduction, and thanks for giving me an opportunity to speak about migraine. And because I believe migraine is grossly underdiagnosed, undertreated, not only by neurologists, even by neurologists, in fact. So I'm going to talk about the recent advances in the management of chronic migraine. And as Dr. Gupta just told, migraine usually starts as an episodic migraine. So initially the patients will have a few headaches per month, 1, 2. But if they are untreated, if we do not properly treat them with acute medications, then this may chronify, transform into chronic migraine, and this usually occurs at the rate of around 2 to 3% per year. So 2% of patients with episodic migraine will transform into chronic migraine. And this will cause huge disability, and there is huge economic impact, social impact on the patients and on the society as well. So as a result, chronic migraine is largely a preventable disease. So first attempt should be to prevent the occurrence of chronic migraine, the transformation of chronic migraine, and then obviously we have to treat it in a proper way. So this slide just shows how migraine evolves. So as a patient with migraine develops increased attacks, the activity in the dorsolateral pons is initially during the episodic migraine, it's episodic. So while the patient does not have headache, there is no activity. But in chronic migraine, activity is continuous, and CGRP, which has come up in a big way, is a molecule that has a very significant role in the pathophysiology of migraine. Its level continues to rise, and then they are very high in patients with chronic migraine. So patients with chronic migraine will progress from low frequency episodic migraine to high frequency episodic migraine, then finally to chronic migraine. There will be a decrease in pain threshold, and there will be an increase in CGRP levels. So what are the risk factors? Some are non-modifiable, for example, age, female sex, but what we are concerned with are the modifiable risk factors. And two most important modifiable risk factors are the attack frequency and ineffective acute medications. So it has been seen that patients who have more than 4 attacks per month, they are more likely to transform into chronic migraine. So this is the group of patients you need to catch who have more than 4 attacks per month. And the second important factor is ineffective acute medications. So if we are not treating the acute migraine properly, then these patients again will have a more risk of transforming into chronic migraine, and this has been shown in the American Migraine Prevalence and Prevention Study, where they found that those who had ineffective acute migraine treatment were again 2 times more likely to progress to chronic migraine. So we all know what are the diagnostic criteria of migraine. So that requires that patient has a headache which lasts for 4 to 72 hours, could be hemicranial, that could be throbbing moderate to severe in intensity, prohibits activity, and there could be associated nausea, vomiting, photophobia, and phonophobia. So for chronic migraine, it requires that the patient should have headache for more than 15 days per month, and of those 15 days, 8 days should have a migrainous phenotype of headache, which I had just told. But how do we came up to this number of 15? This is not a magical number. This was just probably a number of convenience, that patients with more than 15 days will have a chronic daily headache and less than 15 will have an episodic headache. But it has been seen by proven in studies that even patients who have 8 to 15 days of migraine days per month, they are also significantly disabled, almost as disabled as patients with chronic migraine. So even this group of high frequency episodic migraine needs to be targeted and treated so that their disability is decreased and they are treated properly. So because of this, there was a proposal to change the diagnostic criteria of chronic migraine. This has not been accepted, but even if the patients, the point here is that patients with more than 8 days of migraine per month should be treated almost same as patients with chronic migraine. So this slide shows the challenges we have in treating patients with chronic migraine. Foremost, there is a management. We should address the management of medication overuse. There are a lot of comorbidities associated with chronic migraine which needs to be taken care of, not only because they will help in decreasing migraine, because many of the drugs which we use for migraine can have a role in these chronic comorbidities. Then we need a safe and effective preventive therapy, which is a very big challenge, and appropriate use of acute medications so that we provide pain relief but do not promote medication overuse. And then most importantly, adherence to lifestyle to therapy and lifestyle modification is also needed. So this is a multimodal approach which is required for management of chronic migraine. So as I told, appropriate use of acute medications is very important. We all know what are the acute medications, but what is important is that patients should be advised to maintain a headache diary. And we should on all visits try to look whether the acute medication that we have prescribed is working or not, whether it is enabling the patient, the pain relief is complete at 2 hours or not, and whether the patient can go on with his life after taking an acute medication or not. Because ineffective acute medication, if we just keep on continuing, repeating the treatment, it's not going to help. It will just lead to more chances of converting to chronic migraine. And then there are certain scores available where we can use that to assess the effectiveness of the acute medication. Then the other thing is that patients who have episodic migraine, they should be put on to preventive treatment as soon as possible. So if they are having 4 attacks per month, they definitely need preventive treatment. But otherwise also, if the 1 or 2 attacks they have, but they are severe disabling attacks, even those patients should be either considered or offered a preventive medication. So the problem with the preventive medications is that most of the drugs are repurposed drugs. They have been used for hypertension, epilepsy, antidepressants. These are the drugs that are being used in chronic migraine and episodic migraine. Now these have limited efficacy, and there are serious adverse events which lead to discontinuation of the therapy by most of the patients. And they have significant drug interactions. So these are the drugs which have been used in episodic migraine for prevention. And as you see, valproate, metoprolol, propranolol, topiramate, all these are repurposed drugs. So how to start these drugs? Usually start them at a low dose, titrate it up. What is important? To take the patient into confidence. Migraine treatment requires patience. So we won't get results immediately. Most of these drugs will take 4 to 8 weeks to show some effect. And what is the effect that we are expecting? We are expecting that there is a 50% decrease in the migraine frequency and headache frequency. This should be explained to the patient, because otherwise they will leave the drug because they feel that we are still having headaches, so I should leave this drug, this is not helping. So this should be explained to the patient. Patience is important because it requires at least 2 months of continuous therapy before we can say that this drug is not working. And if there is a partial effect, we can add on another drug. If there is no effect, we can change the class of the drug. So in chronic migraine, very few studies have been done for assessment of efficacy of the drugs. Only oral drug that has been approved for treatment of chronic migraine is topiramate. There were 2 trials, and there was some improvement in headache around 4 to 7 days decrease in headache days per month. But topiramate has significant side effects like paresthesias and cognitive difficulties, so it's not a very useful drug because patients often leave it early. Propranolol, on the other hand, is a cheap, effective drug, and in this study we compared propranolol with topiramate for patients with chronic migraine and found that it was non-inferior to topiramate. So propranolol also has a good effect in chronic migraine besides episodic migraine. The other drug which is used in chronic migraine, approved in chronic migraine, is the botulinum toxin. And there is a preempt protocol, 155 units are given at 31 sites. And the decrease in headache days is around 8.4 headache days. But when there were real world studies, it was found that the effect again tends to increase over time. So with repeated injections, there was a significant improvement in patients with chronic migraine. And botulinum toxin is now an approved therapy for chronic migraine. So the marker of efficacy here is that there should be a greater than 30% decrease in the monthly headache days in the month before and the month after the injections. Those patients who do not respond can be given a higher dose of 195 units at 39 sites. And it can be stopped if the patient does not have a response for at least 2 to 3 cycles. Some predictors are that if there is a unilateral pain, allodynia, pericranial tenderness, triptan responsiveness is particularly important. If these patients have these kind of features, then they are more likely to respond to botulinum toxin. And then when we give a botulinum toxin, it has been seen that some patients there is a wearing off effect. Botulinum toxin is given once every 3 months. But some patients may develop increase in headache by the month 2. So they can be given, either they can be given early, or you can add some prophylactic agent, or for the time of 1 month you can use a greater occipital nerve block, about which I will be talking a bit later. So this just shows the protocol for how to use Botox. More importantly, if the patients have a less than 30% effect, then you can add a prophylactic agent and continue. But if they don't have effect even after that, then you can switch off to a monoclonal antibody. Secondly, again, Botox also needs to be given for an extended period of time. So most patients will require botulinum toxin for at least 2 years. It can be decreased once the headache frequency decreases to less than 8 to 10 days per month, so that they are not in the high frequency or chronic migraine range. And Botox has also been used in high frequency episodic migraine, though it is not approved for that, but it has been used and the results were favorable, but more studies are required before it gets approved for the treatment of high frequency episodic migraine. Currently, it's approved only for chronic migraine when there are more than 15 days of headache per month. The next important recent update is the CGRP monoclonal antibodies. We were listening about the antibodies in rheumatology. Now headache also has headache specialists also have their own monoclonal antibodies. So CGRP, as I told, has an important role in the pathophysiology of migraine. And it is responsible for the central sensitization and the peripheral sensitization of headache phase in the migraine. So antibodies have been developed against the CGRP ligand as well as the receptor. So there are 4 antibodies. Erenumab is the antibody, monoclonal antibody, which was available in India, and it acts against the CGRP receptor. The other 3, fremanezumab, galcanezumab, and eptinezumab, they act against the CGRP peptide. They are injectables. Other than eptinezumab, they are given by subcutaneous injection. Eptinezumab is given by IV injections, and more or less they have a similar efficacy, although it is believed that eptinezumab has a higher efficacy, probably because it is given in an IV injection. So this I will skip. And the decrease in monthly migraine days is again shown here, and it ranges from 4 to 8. and the 50% responder rate, that is term used for number of patients who have a 50% decrease in the headache frequency. So this also varies from 44 to 57% in these pivotal trials that were done. But it is important to understand here, these patients were included in the trials. They had already had failed to other preventive medications. So the real world data is slightly more better than what has been shown here. But another important thing is that these monoclonal antibodies, there are some patients who are super responders. So they will have a very good effect after the first dose. Some of them may have 75% decrease in headache frequency, and some of them may even get free of migraine attacks just after a single injection. So this is an important thing, but not all patients respond so wonderfully. So, and in the real world data, it has been seen that patients who have failed multiple drugs, like 2 to 4 preventive agents earlier, they also have a significantly good response to these monoclonal antibodies. These are the doses. Erinumab is available, but it's difficult to get nowadays for some pharmacological reasons. And the dose is either monthly or quarterly, and it's given by an injection. So, which monoclonal antibody is most efficacious? So, real world data suggests that almost all are equally efficacious. It is believed that pharmacologically, erinumab, because it acts on the receptor, could be slightly better efficacious than the ligand antibodies, but real world data has suggested that the ligand antibodies are probably better. So there is no correct answer here, and probably all the antibodies are equally efficacious. And even in fact, it has been seen that some patients who may not respond to the monoclonal antibody, one monoclonal antibody, they can be switched off to another monoclonal antibody. So when these are compared with other prophylactic agents like topiramate, the decrease in headache frequency, 50% responder rate, is almost equal to what was seen with topiramate. But the benefit here is that these are more safer, and there is the number needed to treat is almost same for both topiramate and the monoclonal antibodies. But then there is a number needed to cause significant adverse effect or discontinuation. This is much high for topiramate and much less for the monoclonal antibodies. So we calculate a likelihood to help versus harm ratio, which you can see is very high for the monoclonal antibodies and very low for the patients who were on topiramate, 1.6 as compared to almost 70 for the monoclonal antibodies. And this again shows there was a trial which compared erinumab with topiramate, and the discontinuation rate in the trial was around 11% for erinumab, but 39% for topiramate. But in the real world scenario, after extended use, probably due to inefficacy and other side effects and cost factors, the discontinuation rate almost comes down to the same thing. So it would be better if we could identify patients who have, we can find that patients who would respond to these monoclonal antibodies. So there are some predictors, and probably the most important one is the response to triptan. So if a patient's headache is responding to triptan, then they are more likely to respond to the monoclonal antibodies as well. So can we combine monoclonal antibodies with these prophylactic, with the other prophylactic agents? So in chronic migraine, it is advisable that the prophylactic agent which is being continued should be continued, and monoclonal antibodies should be used as an additive therapy. For high frequency episodic migraine, if the prophylactic agent was working, then it can be continued, but if it was not effective, then it can be removed also, and the monoclonal antibody can be continued alone. And then it has been seen that the monoclonal antibodies act on the A delta fibers, botulinum toxin acts on the C fibers, so there is a synergistic effect also. So patients with monoclonal antibodies who have a partial response, or vice versa, with Botox they have a partial response, they can be added on to given the other agent. However, this will be a very cost prohibitive factor because both botulinum toxin and monoclonal antibodies are very costly for now. So these, what are the benefits? One is that there is a rapid onset. We no need to titrate, unlike the other preventive medications which we need to titrate. The titration itself may take 1 to 2 months. There is better tolerability, no drug interactions. There is infrequent administration is required, so patients require once monthly or quarterly injections. So this will improve the compliance. And some patients may have a 100% response. And even speaking economically, although these are expensive, but the amount of economic backlog because of the economic loss because of the migraine days. So even if this was suggested, even if the whole population of Germany was given these antibodies for free, it would still be cheaper than the economic loss occurring because of the migraine days lost. The most important adverse effect is CGRP is a ubiquitous molecule, so found all over the body. The most important side effect is constipation, and this should be watched out for because it can even cause obstruction, intestinal obstruction. And the other side effect is hypertension with irinumab. So this is also very important because previously undiagnosed hypertensives may become hypertensive, and then other patients could have an acceleration of hypertension. So blood pressure should be monitored. So skip in this. I would go on to Gone block. So this is something which is very helpful in the Indian scenario. This is a cheap medication, local anesthetic, lidocaine or bupivacaine, can be given in the greater occipital nerve and or the lesser occipital nerve, and has excellent benefit in patients with chronic migraine. So there were 2 studies which we had done, and one we compared with the greater occipital nerve block with topiramate, and the other was a placebo-controlled trial. And the greater occipital nerve block, when added to topiramate, was much better than topiramate monotherapy. And when compared to placebo also, there was a significant, much better improvement in mean headache days as compared to the placebo. So these 2 studies, this led to, in the up-to-date platform, this was reported as a practice-changing update that Gone block should be used in patients with chronic migraine. So who are the patients with chronic migraine or episodic migraine which can be given Gone block? So it can be used as a short-term prevention for chronic migraine till the effect of oral medication starts. It can be used as a long-term preventive if the patients, if the alternative medications are either ineffective, intolerable, or contraindicated. Patients who do not want to take regular oral pills, they can be offered Gone block. And it is elderly patients who may have significant contraindications to the other drugs like amitriptyline, valproate, they can also be given this Gone block. And it is equally efficacious in patients with medication overuse headache. So this is how we give Gone block. We use 2 ml of either lignocaine or bupivacaine, and the injection is given at a site measured from the external occipital protuberance to the mastoid process, and 2/3 of that distance lies the greater occipital nerve. We give either 2 ml of lignocaine or 2 ml of bupivacaine. For migraine, it is given bilaterally. If a patient has a unilateral headache, then you can give unilaterally. And it can be repeated depending upon the response. For patients with chronic migraine, it can be repeated at 28 days. But if they have a significant medication overuse component, then it can also be repeated at every 14 days. It's very safe. There are relatively no contraindications except allergy for local anesthetic or a craniotomy defect in the skull. And it is very effective also. So next I will go on to the neuromodulation devices, which are also a recent update.
Dr. Ashish, please conclude.
Yes, sir, just a few slides more. Neuromodulation devices. These are devices which modulate the pain, trigeminal cervical complex and the pain pathway in the brain, which helps in decreasing. They can be used for both acute migraine as well as preventive migraine. And they are especially useful for patients with medication overuse headache because they help you to avoid the medications that are being acute medications that have a potential to cause medication overuse headache. And so currently, most of these devices are difficult to find in India, but this is a new device, remote electrical neuromodulation. This is now available in India, and what you have to do is you have to tie it to your arm, and through a mobile app, then you can start this remote electrical neuromodulation, and it works for around 45 minutes. It is approved for both acute migraine as well as preventive use of migraine. For preventive use, it's used every other day. For acute, whenever you need to have an attack, it can be used. So the main use of these neuromodulation devices is that patients with chronic migraine who are having a significant medication overuse, they can be either advised to go for on this device as a preventive model, or they can use this for as an acute medication, so thereby decreasing the medication overuse that is occurring in patients with chronic migraine. So this is my last slide. So how to manage chronic migraine? I cannot understate the importance of headache diary. It is very important that we ask our patients to make a headache diary so that we can keep track of what is happening to their headache frequency, severity, and the effectiveness of the acute medication. Then we should manage the comorbidities such as depression, insomnia, obesity, and it is important that whatever preventive medicines we are using, they should not increase the comorbidity, rather they should decrease the comorbidity. So if a patient has depression, amitriptyline or venlafaxine would be a better choice. Then efficacy of preventive therapy should be assessed by using the headache diary and the other scores that are available, and adverse effects should be monitored. And appropriate use of acute medications again is very important. We should look how to whether the patient is having the effect of acute medication is good or not. And finally, sleep, stress management, exercise, relaxation technique, yoga, all these have a very important role in management of migraine. Migraine can never be treated only pharmacologically. As I told earlier, it's a multimodal management. So we need to take a look at these things also. So thank you for your patience.
Thank you, Dr. Ashish, for an excellent talk. I think we are running out of time, so we can have questions later on. So I think two important points that I could see here, one is making a headache diary, because headache diary helps us identify the triggers, and modifying triggers is a real help in managing these patients of migraine. And other thing is the high frequency episodic migraine should be treated aggressively like chronic migraine.
Yes, sir.
So these are two important things.
Dr. Ashish, the migraine is so common here.
Sorry.
So migraine is very common. Like sometimes we miss, like sometimes chronically headaches, right? They are classified as migraine. Other headaches are classified as migraine. So is there any biomarker available so that we can efficiently say, or is the history why we can classify this common?
There is no biomarker available, unfortunately, and history is the gold standard. And most of the patients who are classified as diagnosed as sinus headaches, most of them actually have migraine. So a good history goes a long way in if history is elicited properly, then you can make a diagnosis of migraine. And if we have a biomarker, obviously, then that would be very good. But CGRP may come in if you can measure, but it's not possible right now.
And do you find that many of our patients of chronic migraine actually are medication overuse headache?
Yes, sir.
And does the approach changes if the patient is having medication overuse headache?
So if the patient has medication overuse headache, mainly we will need to give him a preventive therapy. And as I said, the neuromodulation devices could be helpful because they can help in controlling the medication overuse part.
So one question, that what is the cost of this neuromodulation that you have shown right now?
That costs around 18,000 rupees, and that will work for, I think, 45 sessions. So
45, you have to buy it again?
Yeah, you have to buy the device again. For something, yes, sir.
I think the golden rule to be taken home for physicians is that it is the history.
History.
Which is the most important still for the diagnosis of migraine or any headache.
Pardon, sir?
No, history.
So if there are certain red flags, if they are present, then you should go in for investigations like imaging. But a patient with a long-standing headache and typical migrainous features, actually there is no need. Right. The ICHD, the last line is exclusion of all other diagnoses. So you need to exclude all other diagnoses, but that can be done, most of the time it can be done clinically. Yeah. There are certain red flags. If they are present, then obviously you need to investigate. For example, an acute severe thunderclap type of headache. So that kind of things, so you need to investigate.
Even patient tells you, I am having the migraine.
Yes, history is the best.
Is there an increase in the frequency of headache with the use of increased screen time?
Obviously, sir, the patients who have migraine, so they have photophobia, and light and sound both can trigger a migraine. So they can have increased frequency. So obviously, now with increased use of mobile and other screens, there will be an increase in patients who have migraine. They may have increased frequency with this.
So we conclude the session, and thanks to Dr. Ashish for a very comprehensive overview of recent advances of chronic management.
Thank you.
Thank you.
Thank you, chairpersons and speaker. I now invite Dr. Prakash Gera sir to kindly felicitate our dignitaries. Now we shall proceed to our next session, which is honored and fond memories of Dr. M.K. Seth sir. Sir completed his graduation from GR Medical College, Gwalior, and his residency from Bel Kapoor Hospital, and he was practicing in Surya Hospital. He was one of the most respected physicians of our times, known for his sharp clinical skills and his profound knowledge. Now, with the enormous advances and progress that is happening in the field of artificial intelligence, including in the medical fraternity, our next session, we shall review whether this is actually a bane or a boon in our current scenario. So I invite our chairpersons for this next concomitant session, Dr. R.M. Chabra sir, Dr. R.P.S. Makkar sir, Dr. Meenakshi Jain ma'am, and Dr. Anupam Singh sir. I request our chairpersons to kindly introduce our speaker.
I request Dr. Mahajan to join as chair, please.
Can I slide of the speaker? Slide, yeah. So very important lecture, MK Memorial lecture by none other than dynamic person, Dr. S.V. Kulkarni. He is a consulting primary care physician since 1983 at Kopoli and faculty MDS University, GMC, Miraj and DY Patil and Navi Mumbai, and organized secretary of the EPICON 2017 at Goa, and faculty member of the ICP, and hosted API technology workshop since 2010, and 2 grants round of the in USA, Yale Middlesex Hospital, Harleshe, and the Penn State, and in test the artificial intelligence, biodata, and computing, and the technology means S.V. Kulkarni, I think. Come on, Dr. Kulkarni, am I right? And he is a good friend of mine also. And he is based out of Mumbai, the Nagari of the heroes, Mumbai. Now, Dr. S.K. Kulkarni.
Thank you. Thank you, organizers. Thank you, Dr. Chabra, for a very brisk and quick introduction. I'm really very happy to see so many of my old friends. Dr. Anil Kumar Chaturvedi, Dr. Singh, Dr. J.K. Sharma, of course, Dr. Chabra. Friends, I appreciate the vision of the organizers. You are a futurist. You are thinking ahead and you know what are the things which are going on. I bring you greetings from my institute, that is MGM Medical College, Navi Mumbai. If you are traveling from Pune to Mumbai on the expressway, my college is opposite to the McDonald's. That is easy to remember. And this is my love towards the subject. Many of the times my family member call that technology and AI is your first wife. Are there any conflicts of interest? No, zero. I would have made huge amount of money by propagating certain things. I'm not doing that. We are all obliged to be part of this time. हम बहुत खुश है कि हम ये ज़माने में पैदा हो गए. We have seen वो डब्बे वाला फ़ोन भी देखा है, ₹1 वाला PCO भी देखा है, और आज दुनिया मेरी मुट्ठी में. Won't believe the latest mobile which I have purchased has got 1 TB storage, 12 GB RAM, cost 27,000 rupees. It is cheaper than any laptop. And my humble journey in the technology, Dr. Singh and Dr. Chaturvedi are the witnesses for that. We started with one workshop in Kolkata. I think you have put a wrong timer. It is supposed to be 40 minutes. Okay. Kolkata, API. We expected only 10-15 people to attend, a cricket team. But not believe, the hall was full. People were sitting on the floor. Thanks to Dr. Sandhya Kamath. And I'm very proud to tell you that I have got a legacy of 5 teams. 30 साल के हैं, 40 के हैं, 50 के हैं, 60 के, मैं 70 का. And we are doing wonderful work in this field of technology. So this is the outline of my presentation. Why AI? what is AI, what are the simple basic principles which are used. I'm going to explain the boon by giving the examples. I'm going to talk about banes. Are they really exist? How to balance? I'm going to give a peephole of the future. And if the time permits, I can show you actually how the AI works on this screen. Take home, further readings. This presentation belongs to you. All the 110 slides are yours. So friends, AI is a boon. It is a benefit. It is a blessing. It is a gift. And it is a relief. I will ask you one question. What we are, what we have done, and what we need to do. As a medical professional, as a physician, we have achieved certain things. We have conquered some diseases. We have discovered new drugs, new diseases, prolonged life expectancy, patient का suffering कम किया है, well-being बढ़ाया है, quality of life improve किया है. Are you looking still something forward? A ray, a beacon, a magic wand of hope, but not a panacea. At the same time, we face challenges. The costs are rising, explosion of healthcare data. And remember this term, shrinkage of medical literature doubling time. I think you are listening this for the first time. The way in which the medical literature is coming up, it is impossible to keep the pace. There is a dynamic, rapid and continuous update. There is increased burnout of physicians. We have got prolonged drug discovery, prolonged vaccine discovery and drug trials. Is there any way for that? Yes, AI is the way. But before we go to AI, please try to understand this triangle. The data, information, knowledge and wisdom. There is a huge data, huge analytics. By January 23, 2023, 520 algorithms were already passed by FDA. So, at least the medical profession is accepting, it is adopting to that. The things are exponentially increasing. In COVID time, you must have seen the patient undergoes a CT at 8 p.m. and by 8:10 you have got a report in your mobile. The exponential increase is mostly in the visual, video analysis, medical image diagnosis, and there is a huge impact on the exponential publications, whatever are going on. So just to enumerate top few effects, positive benefits, it is an efficiency enhancer, data can be analyzed faster, it is available 24/7, unlike my residents. छुट्टी आ गया तो attached leave लेने का. No, accuracy at the best. There is a personalization. There are some safety and risk reduction. We will see how we can find it. There are some more advantages. It saves time, money and efforts, especially telemedicine. The trouble, torture of travel is reduced. Accuracy, definitely better. And friends, please remember, we have got so many people of different age groups here, from youngsters to 80s. It increases your serum levels of confidence. You cannot buy it into milligram or microgram. Start adopting technology, you will be confident. Concentration, competence. The air hostess was looking at me why I am not eating such a delicious food of Vistara. Because I was really immersed in making my presentation to a better way. Competence, enthusiasm, and most important, acceptability. Accept from the next young generation. Acceptability and learn from your grandchildren. They are the best teachers. उसका पाँव पकड़ के बोलने का भैया मुझे ये नहीं आता ये सीखा. You know, you are going to be masters. So it is everything together. It is a boon. Is artificial intelligence around you? Yes. The moment I type East, I get the word Delhi because I have been communicating with all these people for last so many days. This is a predictive typing. It is ubiquitous, it is universal, it is a true milestone. Abacus देखा होगा आपने, calculator. We have seen big disk computers to ChatGPT. This is a generative AI with an unimaginable outcome and potentials. but it has to be used in a very significant way. Many of the people might have read this editorial of mine that was digital technology in clinical medicine from calculators to chat GPT. Go to japi.org and you will get this editorial. So AI is in and around us. Now let us see how we can find. अपना इंडियन मेंटेलिटी बहुत अलग है. Disappointments start from expectations. So don't expect too much, too fast and easily. The greatest danger of artificial intelligence that people conclude too early that they have understood everything. समझ में आ गया सबको. नहीं, it's not that easy. If we ask our Indian population, they want a driverless car. But if you tell that we have got a small algorithm, get your health checkup done, we can predict your health problems, they will not accept. और एक सवाल उठता है, is AI a companion, competitor or a comprehender? Is it a catalyst? Yes, it is a catalyst. It is friendly. It is a fluid, functional facilitator. AI is adaptable, but not very adept at the true understanding. Adapt or adapt का difference समझ लीजिए. For a simple example, you are suspecting a patient of acute emphysematous pyelonephritis. You know that if you don't intervene at 12 o'clock in the afternoon, patient is going to die at 6 p.m. The AI will understand it is a serious disease, but cannot convince, counsel and comfort the relatives for a speedy intervention at earliest. So, again coming to the question, it is there, how you go about it. This is a famous curve. This is called as a Gartner's curve. कोई भी नया चीज़ मार्केट में आता है ना, there are 5 phases. Number 1, it gets visible. Then there is a peak of inflected expectation. Then that comes down. That is called as the trough of disillusionment. There is a slope of enlightenment. थोड़ा सा कम होने के बाद market चढ़ता है उसका. And there is a plateau of productivity. So this is what exactly happened. But one of the best example is about AI in medicine. It has remained at quite a steady pace. Why a physician like you should know about AI? There are various analyses. It shows that the things are going to increase and increase and increase only, nothing else. But is it a new phenomenon? Is it a new tsunami of technology, information, computer science? No. It is as old as me. 1956, John MacArthur, he coined the word AI. And these are the things which are useful, and they perform complex automated tasks, and they handle the big data. I will not call it as a artificial intelligence. I will call it as an augmented or assistive or affirmative add-on or accelerated intelligence. We are very intelligent right from our birth and our practice. There are so many things going on around. You can imagine the number of articles going up, the countries which are putting huge amount of money, and the type of results which are going, increasing focus on the research on artificial intelligence, machine learning, and the related components of it. The market is going to be very huge. So all the youngsters who don't want to practice, this is one of the things which is going to help them. This is not my word. Injecting artificial intelligence in medicine 2023. There was an endocrinologist in 1970 in US, by name William Schwartz. What he says, computing science will probably exert its major effect on augmenting, in some cases replacing the intelligent functions of the physician, and will influence in a fundamental fashion the problems of both physician manpower as well as quality of medical care. We will also inevitably exact important social cost, maybe psychological, organizational, legal, economical, technical. And this is the latest baby from NEGM, New England Journal of Medicine, AI. Let us, before trying to understand AI, just try to understand few basic terminologies. Algorithm, everybody knows. Machine learning. What X-ray is? X-ray reading is machine learning. Neural network, coming down to a conclusion. I recall my teacher, Dr. R.D. Lele. It was way back. हम ऐसा सोच रहे थे कि हिंदुस्तान में HIV आएगा ही नहीं. There was a patient who was admitted after giving 15 bottles of blood. He had undergone a CABG. He had lost weight. He was having loose motions. and he was having some skin lesions. Put everything together in a clinical decision-making system. Tap came the answer, transfusion-associated HIV. Whole country was shocked. But this is the beauty in which a human being cannot imagine the things. And this is called as a neural network like our brain. Then data mining and cloud technologies. आपका phone कितने का है? 256 GB ज़्यादा से ज़्यादा हो सकता है. But cloud computing is unimaginable. So there are 4 to 5 types of AI in healthcare, and this is an umbrella term covering variety of distinct but interrelated processes. Don't go into the details. These are the words which will hear on and off: narrow AI, general, generative, and super AI. But 5 main things: machine learning, deep learning, natural language processing. Even if somebody comes to Dr. J.K. Sharma and he talks Zulu, he will understand in chest, daylight Hindi, what that Zulu language is transferred. So language is no barrier. Large language processing and robotic process. My friend, he was detected to have 2.78 millimeter nodule in prostate. Young boy, 49 years old. He was successfully operated with robotic surgery without anything. Imagine 2.78 millimeters nodule which was detected. There is something called a weak AI, strong AI, super intelligence. There are many spectrums of our life which are going to be accompanied by AI, right from treatment, end-of-life care, research, training, early detection, diagnosis, and of course, decision-making. So just imagine these 3 words: narrow intelligence, artificial general intelligence, and super intelligence. There is a threat. There is a threat when the super intelligence is going to take over. Where we use it in hospitals practice, it is in descriptive. If you want to write an essay, if you want to write an essay on newer treatments of monoclonal antibodies in migraine, whatever doctor just before told, he can write an essay. Diagnostic, give the parameters, you will give a diagnosis. Predictive, prescriptive, as well as cognitive. Is it related only to Western world? No. In India, there is a lot of work going on, and these are certain references which will tell you that rapid transformation, artificial intelligence in Indian healthcare, a promising future with challenges. It had come into the lay press like Hindu. Now there are 2 types. There is a virtual and there is a physical. What is virtual? Machine learning, mathematical algorithms. It improves learning through experiences, and there are data can be supervised, unsupervised, or the data can be reinforced. The physical branch, everybody of us is there is around us. You know the sensors. You know even the watch, what it is picking up your pulse and stress levels. There are increasingly sophisticated robots, and robots or assisted surgeons or even as a performance is not a big problem. Now imagine the same hall. You are just supposed to look through a pinhole. There are 1,000 cats and only 1 tiger. How you can find it out? The computer vision syndrome will find it out within few milliseconds, and that's what they are doing. From our daily activities to the morning punch to the punching करते हैं ना medical college वाले सब, NMC बैठा है सर के ऊपर. Right down to when we see the MRI. Now imagine you got a huge OPD and some of the patients are not happy. The relatives are not happy. How you can pick it up? There are sensitive cameras which can pick up the facial recognition. And it is where Dr. Chabra is an expert in PG, violence against doctors, and he is going to be my brand ambassador for these cameras. There are face filters that detect and identify the order and provide secure access. The high security related areas we can pick it up, can recognize odd belongings. आपके क्लिनिक में अगर कोई क्रिकेट का बैट आ गया तो आपके साथ क्रिकेट खेलने के लिए नहीं आया, आपका शीशा तोड़ने के लिए आया. डेफिनेटली हॉकी स्टिक लेके आया बोले तो आपका सर फोड़ने के लिए आया. So we can have a happy person, negative, anxiety, not satisfied. Then the stages: argumentative, abusive, and finally the violent. And you can see all of them here. And how it has been picked up? This is called as a facial recognition of emotions in violence prevention. It was tried on animals, it was picked up in animals, it was worked on animals, and then it has come to. Now, this is just a picture recognition. There is something called as immersive technology. What do you mean by immersive technology? You have got a physiotherapist or a rehab person from Apollo, and he wants to show certain exercises. You are wearing the same type of goggle, and you can do the same type of exercises. This is called as a augmented reality, virtual reality. You can even practice and evaluate the surgical activities also. Where it is important, very useful. आपकी कोई तो आंटी रहेगी, कोई तो चाचा मामा रहेंगे, जिनको लिफ्ट में डर है, एस्केलेटर नहीं चढ़ सकते. In everybody's family there are people like this. तो उनको ये वेयर आप बनाएंगे ना, तो that will be one of the fantastic things. That is the augmented reality. Suppose if you want to enjoy a movie like Mughal Azam all on your own, you can put that goggle. This is a big screen, not even 70 millimeters, 140 millimeter screen in front of you. You are in the virtual world totally, and doesn't cost too much. 1400 रुपए. Jio virtual reality headset. You watch the cricket match, you feel that you are standing in the ground. And phantom limb syndrome and new limb transplants. My son-in-law is an expert in limb transplants. And the problem of this limb pain, it can be very well taken care with this. Go to your OPD.
Dr. Kulkarni, just a polite reminder, the time is up, but we'll have some time for some interactive sessions.
No, I have timed it up for 40 minutes. If you check the
with the question
pictures,
answers. We'll leave some,
if you check your brochure,
some time for the question.
Huh? I don't think so. Then I have to leave it halfway.
Please go on. Please go on.
I'll pick it up fast, don't worry. This is the way in which you can pick up a patient's COPD episode as early as possible. Because here my time shows is 20.05 minutes. I am halfway. This is the smart glucometer. So biomedicine for early detection of chest nodules. This is an established paper. You take a chest nodule and you can diagnose what kind of things are there. This is a more of technology in AI and chest diseases. CA bronchus can be detected. And there are a lot of other partners. Go to Google, health.google, and you will find all the details with this. And one of the expert in that is made. Okay. Then I have to just forward. Made Palm 2, it is an expert level medical large language model. So you can have a smart clinic. I'm just giving it small amount of time for a discuss. This is the thing which you can do everywhere. You have got patient parameters, you have got lab results. Can you predict the patient's outcome? It is very easily possible. There are a lot of things which we are surrounded by a lot of sensors, and 12 parameters can be measured, and these are the different kind of sensors which are evolved. You will get a machine like this, that there is a central unit, and then you can take all the parameters of the patient. These are the newer things which are there, like a skin patch which checks continuous electrolytes. Then these are the fall detectors, or even it is a Holter. I have got a pulse oximeter which measures your respiratory rate and your perfusion index. This height weight directly goes to your EHR. This stethoscope magnifies the sound by 16 times. This is possible only digital one. This BP apparatus can be used as an exercise BP apparatus. A mother also can see acute otitis media and diagnose. If somebody collapses here, I can take a 6-lead ECG within a second without leads, without jelly. There are glucometers which are attached to different kind of things, and you can get a CGMS. Everybody knows, but this is an Israeli company which is a non-invasive glucometer, as well as there are 15 parameter non-invasive things. You check the patient's strength with a digital hand grip meter. There are different kind of cameras, a dermatoscope which can use. Whatever you wear on the wrist, it grows faster. These are the rings. These are the AI rings which check your emotions and other things. Forget the word plagias, no mono, para, quadriplegia. This is called as the exoskeleton. A person thinks that I want to walk and he will start walking. Digital twinning is the possibility, day-to-day time. Google AI Muse. This is a word to picture. What I have done here, I have told him, I am skating around the ring of Saturn, and the picture comes here. So these are the different type of advantages if you adopt for AI, and it is a very useful thing in the medical education training also. There are ways in which you can peep into your body. This is called as oculomics. It can detect your cardiac health also. These are the standard papers which tell about it. Generative AI's potential is very, very massive. This is called as a ChatGPT. November 2022, it is formed, and it is one of the fastest growing. It can diagnose complex cases like CPC of New England Journal of Medicine. It can create awareness, and there's a lot of things which you can do for data security, swiping and selling. And this is the way in which where the AI has been used. Now the last part, 5 minutes, is AI bane for medical professional? All the galias, whatever you know, you can give for bane, but there are obstacles. What are the obstacles? And who is the obstacle? Our own. We have time frame of our own. Then it is the mindset which is important. So go along with quality data processing, your work will be very easier. How malleable and timeable you are, you just convert your data into a very simple way. The question asked is this, that is AI a threat to medical profession? No. AI cannot think, it cannot pass on the emotions. It is a supplement. But it will replace the physicians who are not going to use technology and AI. There are some perceived disadvantages like job displacement, but there was a bank strike when the computers were installed. But that is the same thing going to happen in our country also. It cannot replace human intelligence. It can replace healthcare professional. Again, strong no. From where you learn about AI. So these are the organizations. They are all online and free. These are the major APIs, and these are the journals. The best journal which is there is NEGM AI. The first is free. Go to NEGM AI. You publish as much as possible, H-index, and there are people who are in the academics, so support and encourage the use of large language models. This is our publication, Digital Technology in Clinical Medicine. So friends, it depends upon how you look at the things. There are n number of possibilities. These are the top 10 possibilities for the next generation, definitely. So these are the final practical pearls of wisdom. You have got a huge potential. You have to use it very carefully. Things like telemedicine, 3D printing are there. We are using it, and definitely there are few pros, there are few cons. Our Indian government has come out with something. I will request you to become member of Telemedicine Society of India and attend few conferences of American College of Physicians. Please stay fit physically, mentally, go digital, learn and use, and teach technology. Most important is you teach your technology. Be optimistic, informed, empowered, futuristic, build a bridge of knowledge, clinical acumen, experience, AI and technology. Incidentally, this bridge is going to be open on birthday of Atal Bihari Vajpayee, 26th of December, longest bridge in the country, 23.8 kilometers in front of my own house. So thank you very much. Really appreciate your presence. 26.
Thank you. Thank you, Dr. Kulkarni, and apologies for keeping it
it's okay,
a small time. But yeah, we'll have time for a quick question and answer session if we have one or two questions from the audience.
So Dr. Kulkarni, you just talked about.
In the meantime, should I? Can you just project the thing? I have already prepared one screen for you. Is it showing? Is it showing the screen? Yeah, please.
Dr. Kulkarni, what is the percentage of error in the artificial intelligence thing? Percentage of error. What is the medical implication if error is occurred and you have signed the report? And who is responsible, whether the AI or you?
This is a question asked very frequently. It is not the machine which is at fault, it is the man who is handling the machine who is at fault. I will just show you. This is the OpenAI ChatGPT screen which I opened for you. And what I have written, that write a letter of thanks to East Delhi API for the opportunity. My letter is ready within 1 second. Now I am not happy with this letter. No? So I am just asking you to do it, repeat, regenerate. I think it is not picking up the signal. Dr. Sharma, can you give my phone? It has to have a...
So while you're demonstrating this...
for all of you, I request you to check these things on your own. It's very easy. There is nothing like a learning curve, or you don't need to go to anybody. And especially your ChatGPT is helpful for your patients.
Please open up your phones if you can and try to follow the commands that Dr. Kulkarni is giving so that you can check live demonstration of ChatGPT on your phone.
Okay, I just told him that I'm not happy with this answer. Okay, so I'm asking him to regenerate it. Hands off. I am out of the screen.
Sir, would you read this letter before sending it?
You can order me any presentation, title 4 lines. I will make a presentation for you. That is possible. You feed the data and you want a 4 pages paper on it. It is possible. You can just, I'm just typing here. I have a patient of pancreatitis with triglycerides of 1800. It picks up certain simple mistakes. How I manage? You can copy it, you can do it in your own way, and please, I have a request for everybody of you to take out your mobile phones, put on the torch on. I want to take a picture, otherwise my wife will not believe. Take out your... Yes. Thank you very much. Thank you.
Dr. Anupam, your comments upon Dr. Anupam, your comments upon AI, because you have been using AI for long. So, what is your comment?
One of the one of the challenges with any new technology is sort of dependence. So we see it with biomarkers. For example, if procalcitonin is high, so it's spurious. Sometimes it doesn't fit in with our clinical picture. One of the possible side effects can be we are over dependent. Our generation, which is more familiar with the natural history, is familiar, but the new generation, which is suppose the guy who is directly doing MBBS, we see it all the time. So they have a tendency, instead of reading the textbooks, so they have a tendency, because AI has actually read the 10 TB of text, and entire up to date is 200 MB of text. But we have actually read Harrison. The AI has already read the text.
This is another AIDS syndrome. These are artificial intelligence prepared dumb students. Artificial intelligence following dumb students. So there is no replacement for teaching. There is no replacement for textbooks. These are all the things are add-ons to yours. And your observation is absolutely right. There is always a hype, then there is a dip, and there is a play.
Thank you, Dr. Kulkarni. Organizers are staring at me. अगली बार बुलाएंगे नहीं खत्म करो. Thank you very much,
Sir, one question.
In the last, Dr. Kulkarni, in the last, it is depend on the feed, whatever you feed in the computer, that will be a comparison. So thank you very much. In the last, I forgot to thank you.
I'm just going to give you a snapshot of how the AI is there in India since ages. We have started recognizing it just now. अगर आप कभी वाराणसी गए हों तो वहाँ पर रामचरितमानस की प्रतिलिपि जो है किसी ब्राह्मण के घर में रखी हुई है. वो किसी को अवेलेबल नहीं थी. Books were not available. Then we formulated the libraries. People can go there and sit down, take the knowledge, take home notes. Suddenly came the internet. You don't have to go anywhere. You have everything at your fingertips. You can download anything. They'll give you the links. And now we have the AI. You don't even have to download the links. You just type the question and it'll give you the answer. But you have to read it. What goes next? If you can make the things enter your brain without reading, and that is where the next step is. It may come down 50 years later, 20 years later, 30 years later, but it is going to come, and that's where the real danger stands. Thank you very much.
Thank you. Thank you, Dr. Kulkarni. We conclude the session. Handing over for the next
In the last, we forgot to thank you the organization for giving the opportunity. Special thank to the Dr. Gangwal, please. Thank you. On the behalf of our co-chairperson. Thank you.
Thank you. Thank you, sir.
Thank you so much. I think we all must agree that this was one of the most interesting sessions of the day. Here we talk about how our grandparents are technically challenged, and here I see a senior physician of my grandfather's age teaching us things that we could have never imagined. So I would request Dr. Lalit to felicitate our speakers and speaker and chairpersons, and I would hand over to Dr. Tushar for the next session.
So moving on to the next very interesting session of nephrology on Finrenon, a new treatment pillar for cardiorenal benefits in CKD and type 2 diabetes. For this session, I would like to call on stage our chairpersons, Dr. N.P. Singh, Dr. Dilip Bhalla, Dr. S.C. Chabra, Dr. Naresh Dang, and Dr. Meena Chabra. I request our chairpersons to kindly introduce the speaker.
Good evening, friends. And after technological advances, now we have some medical advances. And diabetes is an old age disease with prevalence starting from 2% to now almost touching 1/5 of our mankind, and it will keep on increasing thanks to the sumptuous lunch which we get. So medication also has been evaluating, and evolution is occurring, and what started with sulfonylureas, metformin, and now we have new and new molecules. So what is dreadful about diabetes is regarding its complications, and one of the most dreadful complication is diabetic kidney disease, which has a different phenotypes. Now we have patients without albuminuria, they're going into renal failure. Classical teaching of albuminuria and then renal failure is now changing. So newer medications have come up, and two important medications which have come up are SGLT2 inhibitors, which can not only prevent the progression but can also protect you from cardiovascular and renal issues. And we have the newer molecule Finrenon, and to talk about that we have Dr. Vishal Saxena. Vishal is a young bubbling nephrologist and has been all over the place. At present he is a senior director and HOD Department of Nephrology and Kidney Transplant at the BLK Hospital, and I understand he's got a separate unit just recently. So over to you, Vishal, for the presentation.
Good evening, and thanks to the organizers for inviting me to give my deliberation on Fenrenon, a new treatment pillar. I would like to thank, it's a great honor to be in presence of Dr. N.P. Singh, Dr. Chabra, who's been like teachers to me, and I've grown with them actually. So it's a real honor, sir, to be a part of the same podium, and I'm honored. And thank you, everybody. So we'll talk about Fenrenon, a new treatment pillar for cardiorenal benefits in CKD and type 2 diabetes. So this is my introduction. Dr. N.P. Singh has already announced that. So chronic kidney disease in type 2 diabetes has a high disease burden in India and has a major effect on health. India has second largest diabetes population after China, and by 2045 we will be the diabetic bowl or diabetic hub of the world. In India, around 2019, 77 million adults with diabetes and 100 million expected by 2030. Estimated 37 million adults are living with CKD in type 2 diabetes in 2017. So 48% prevalence of CKD in type 2 diabetes. And this is despite glycemic control and blood pressure control. More than 30% of patients with type 2 diabetes will develop CKD. So that made us think that there's some lacuna. Despite controlling sugars, despite controlling blood pressures, why are patients still keep on developing progression of chronic kidney disease? So if you look at this comparison between type 2 diabetes alone, comorbid CKD increases the cardiovascular mortality. It's not only about kidneys, it's about the heart, the adverse effect on the cardiovascular mortality. If you look at this table, standardized 10-year cumulative incidence of cardiovascular mortality by diabetes and kidney disease status shows that if you've got no diabetes or chronic kidney disease, the risk of developing a cardiovascular mortality is only 3.4%. If you've got type 2 diabetes alone, the risk increases, almost doubles to 6.7%. If you have CKD alone, the risk triples to 10%. And if you've got both CKD and diabetes type 2, the risk goes to 19.6%. So almost 6 times the risk doubles as you have both the disease of chronic kidney disease and type 2 diabetes. So what happens when you have a risk of cardiovascular events in patients with diabetes increases as albuminuria progresses and EGFR declines. So if you look at this slide, you say microalbuminuria when your urinary albumin is around 30 to 300 milligram per gram. But if you look at the cardiovascular risk, even the moment it has started becoming above 10 milligrams per gram, even the minimal of microalbuminuria, your cardiovascular mortality and morbidity starts increasing. So microalbuminuria per se is an independent risk factor for development of cardiovascular diseases. And other than that, the decline of GFR. As your GFR is declining, you can see that it's linearly progressing towards worsening of cardiovascular disease. It is said that if a 20-year boy develops chronic kidney disease, his heart condition will be equivalent to an 80-year-old man. So that is the effect of kidneys on heart diseases. So that is the point where cardiovascular and kidneys, they both go hand in glove. So that is the importance that albumin creatinine ratio and GFR, both are independent risk factors for developing cardiovascular diseases and mortality and morbidity. Now if you look at the increasing albuminuria, as I said, is associated with higher cardiovascular mortality across all GFR categories. You can look at albuminuria level. The GFR is more than 90, albuminuria. So this is moderate, this is severe, this is normal. So as your GFR is going down, your albuminuria is also increasing. So again, and this leads to higher cardiovascular mortality. So whenever you talk about kidney diseases, you cannot talk about kidney disease in isolation. You have to look at cardiovascular side effects of chronic kidney disease, especially in diabetic. Now, what are the international guidelines recommended that screening at least annually for kidney dysfunction patients with diabetes? So for type 1 diabetes, it said you start screening them after 5 years. For type 2 diabetes, right at the onset, and then every year you should monitor them. American Diabetic Association, KDIGO, and American Society of Cardiology, they recommend screening for kidney dysfunction by urinary albumin creatinine ratio and EGFR. Frequency, it says that if patients at least once a year in all patients with type 2 diabetes, regardless of treatment. KDIGO says screen more often in patients of higher risk of CKD progression, for example, 3 to 12 months.
ADAC is screened twice annually if urinary albumin creatinine ratio is more than 300 milligram per gram and our eGFR is 30 to 60 ml per minute per 1.73 meter square surface area. And to confirm, you need to have an albumin excretion and eGFR. It varies in people over time, and abnormal results should be confirmed to CKD stages. So in patients with CKD with urinary albumin creatinine ratio more than 300, ADA recommends a urinary albumin creatinine reduction of 30% or greater to slow the CKD progression. So the crux of delaying the progression of CKD is to reduce proteinuria. Now, what have we been doing till now? We were looking at the hemodynamic factors, so blood pressure. We would control the blood pressures. We had metabolic factors like poor glycemic control. We were controlling the sugars. But despite all this, the damage to the kidneys kept on happening. Why? Because something we were missing here: tubulointerstitial damage and inflammation, glomerular sclerosis, mesangial expansion, glomerular hypertrophy. So what we were missing was inflammation and fibrosis, which leads to CKD progression. And this answers the question that despite hemodynamic, like ACE inhibitors, thiazide-like diuretics, calcium channel blocker, SGLT2 inhibitors, despite metabolic control like metformin, GLP-1RAs, SGLT2 inhibitors, so both including hemodynamic and metabolic, you also need something to control the inflammation, which leads to fibrosis and further worsening of the kidney function. And that is where no existing treatments primarily target inflammation and fibrosis. So many studies have been done from time to time. There was a renal study, losartan versus placebo. The primary composite endpoint was doubling of serum creatinine, end-stage kidney death or death. Credence had canagliflozin plus ASARBs. Primary composite point again the same. DAPA CKD, DAPA with ASARBs, EMPA kidney, EMPA with ASARBs. And they all looked at cardiovascular points, renal decline, renal death. But if you see, despite attaining good control of blood pressure, sugars, the residual risk still kept on rising in all the studies. There was nothing that could slow down or reduce the risk. It could slow down, but could not really retard the progression of chronic kidney disease. So where were we missing? The point was that kidney and heart diseases and diabetes are associated with mineralocorticoid receptor overactivation through multiple mechanisms. And what are these mechanisms? One is an increased ligand-dependent MR activation by aldosterone. So aldosterone breakthrough in patients with CKD treated with ASARBs, increased ligand-dependent MR activation by cortisol, increased ligand-independent MR activation by RAC1 and oxidative stress, and increased MR expression with high albuminuria. So increased MR overactivation was the one which leads to fibrosis. So what do we do now? So MR overactivation in kidney and heart diseases becomes overactivated through multiple mechanisms. The downstream effects are kidney damage through glomerular damage, proteinuria, tubular injury, reduced renal blood flow, kidney injury, vascular damage like reduced remodeling, endothelial dysfunction, increased vascular stiffness, and heart damage like myocardial, ventricular remodeling, reduced coronary blood flow, ischemia infarction, and myocardial injury. So it was not only affecting the kidneys, the inflammation, the fibrosis, it was affecting the heart, the vessels, and the kidneys, all three. So what do you do now? So you need a molecule that can act against the MR overactivation. So we had a molecule, finerenone. It's a novel, non-steroidal, selective mineralocorticoid receptor antagonist. It's a bulky molecule. So bulky, so it stays there. It doesn't get disseminated. So it stays there and blocks the mRNA overactivation by genes transcription. And this is the finerenone specific gene expression. So bulky, non-steroidal molecule, unique structure results in selective and potent interaction with mRNA regulation of gene expression. Thereby, because it's a strong molecule, bulky molecule, lesser side effects as compared to the longer acting molecules like aldosterone or aldactone or eplerenone, and exhibits antifibrotic and anti-inflammatory effects. So what happens in the factors that contribute to kidney and cardiovascular progression is hyperglycemia, high salt load, oxidative stress, leading to MR overactivation, leading to phenomena where MR activation is stopped by finerenone, and this blocks the MR activation pathway. And in patients with CKD and type 2 diabetes, finerenone has been found to slow CKD progression reduces cardiovascular events compared with placebo. So it reduces the inflammation and fibrosis and sodium retention in cardiorenal diseases leading to kidney and cardiovascular damage. So what is the difference between the steroidal and the non-steroidal molecules? One, they are flat and this is a bulky molecule. It has got a short half-life, so lesser sexual side effects, lesser effects of gynecomastia, and lesser incidence of hyperkalemia is again a part of finerenone. And then effect on blood pressure was not very good as compared to spironolactone, and it has been used in CKD with type 2 diabetes so far. So short half-life and no metabolites leads to lower rates of hyperkalemia and manageable by either the drug withdrawal or by antikalemic measures. So in phase 2 studies, finerenone was associated with smaller increases in serum potassium compared with other MRAs. So ARCH safety trial showed the finerenone versus spironolactone and finerenone versus placebo, the p-value of less than 0.001, right? The mean change in the serum potassium was significantly lower with all doses of finerenone compared to spironolactone, p-value of less than 0.02 for all comparisons. And ARCH heart failure trial phase 2b showed the incidence of hyperkalemia was balanced between higher finerenone doses, 7.5 to 15 milligram. There was incidence of 3.7%, 10 to 20 milligram, 3.6%, 15 to 20 milligram, 6.3% versus eplerenone, 4.7%. So, as per the increasing doses concerned, the risk of hyperkalemia was less in all the finerenone dosing groups as compared to eplerenone. So, finerenone is indicated in adult patients in India with CKD associated with type 2 diabetes to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular disease, non-fatal MI, and hospitalization for heart failure. So there was this evidence of finerenone is documented by 2 phase 3 clinical trials with complementary kidney and cardiovascular. So one was Fidelio, where it looked at the renal side effects, and one was the Figaro, where the primary composite point was time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for heart failure. Fidelio used composite endpoint of time to onset of kidney failure, sustained decrease of eGFR of more than 40% for baseline, or death due to kidney disease. The secondary endpoints crossed in each of the trials. So key secondary endpoints were same as primary endpoints. Other endpoints were looked at all-cause mortality, all-cause hospitalization, change in urinary albumin-creatinine ratio, and composite was time to first occurrence of kidney failure, a sustained decrease in more than 50% from baseline over 4 weeks, or death due to kidney disease. So what did Fidelio consist of? Inclusion criteria was type 2 and CKD, either defined as albumin-creatinine ratio of 30 to 300 and eGFR of more than 25 to 60. So stage 4 to stage, you can say 2, and a history of diabetes retinopathy, or albumin-creatinine ratio of 300 to 5000 and eGFR of 25 to 75. So here the proteinuria has gone up and the eGFR is better. Here the eGFR is low, but albumin is better, low, but albuminuria is better. Treated with either an ACE or ARBs at maximal tolerated doses. So remember, the benefit is when you are using maximal doses of tolerable doses of ACE or ARBs, potassium was targeted as less than 4.8 millimole at a run-in and screening visits. Exclusion criteria were non-diabetic kidney patients, uncontrolled hypertension, chronic symptomatic HFrEF patients, recent cardiovascular event, dialysis for acute kidney failure, less than 12 weeks to run-in visit, kidney transplant or planned kidney transplant, treatment with eplerenone, spironolactone, any RAS inhibitor, or potassium-sparing diuretic, which cannot be discontinued less than 4 weeks before screening visit. So what they did, they had a run-in period. They took 5,734 patients and 1:2 randomization between finerenone and placebo. It was a randomized double-blind placebo-controlled event during phase 3 trial. Duration trial was 5.5 years. Treatment duration 44 to 48 months. If you look at the trial duration, it was almost same. Age mean was same. Males, females were more in Figaro as compared to Fidelio. Blood pressures were same. Heart rate was almost same. HbA1c same. potassium same. So more or less the control population was almost similar in both the trials. The medical conditions were also similar in both the trials. And if you look at the stages of CKD, more than 60, we had around 56 as compared to 4540 patients in Figaro. Again, depending on the GFRs, you have different kind of patient populations. And looking at the urinary albumin creatinine ratio, again different numbers in Figaro and Fidelio study. So this was the use of ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics, calcium antagonists, statins, platelet aggregation inhibitors, glucose lowering therapies, and insulin, metformin, carbo, sulfonylurea, DPP4, GLP, and SGLT2. I would like to mention SGLT2 inhibitors were also included in some trials. Mean follow-up for Fidelio was 2.6 years and 3.4 years for Figaro. 98 and 99% of patients were treated with a maximum tolerated dose of ACE inhibitors or ARBs respectively. Adherence to treatments was high, almost 92% in Finerenone and placebo groups. Cumulative treatment duration and number of permanent discontinuation was similar between Finerenone and placebo. So discontinuation rate was almost similar in both the groups. When we looked at the efficacy and safety outcomes, Finerenone, it was shown to reduce, if you look at the top of the maximum RAS therapy, kidney failure sustained more than 40% decrease in EGFR from baseline or renal death. Finerenone reduced it by almost 17.8%, which was a huge mark. So absolute reduction ratio after 3 years was 3.4%, and need to treat patients after 3 years were 29. So that gave the power to the study. So after 48 months, almost 18% you can delay the progression of chronic kidney disease. You can sustain a GFR of 40%. If you look at the forest plot, again it shows as far as the kidney failure was considered in Fidelio, in the Finerenone group, kidney failure, end-stage kidney disease, sustained decrease in GFR, sustained more than 40% decrease in GFR or renal death. They all favor the Finerenone group. So again, favoring the Finerenone. If you look at the albumin creatinine ratio, within the first 4 months, it showed a significant decline and remained sustained in the Finerenone group as compared to placebo, whereas the secondary composite point, the absolute risk reduction, in the Finerenone group, the time of first event was again reduced by 8.9%. So again, very good outcomes when you look at the secondary endpoints as compared to the albuminuria and the secondary composite endpoints. So Finerenone significantly reduced the risk of the key secondary endpoints by almost 13% in the Finerenone group. And the cardiovascular outcome, again, on top of the RAS blockade, Finerenone significantly reduced the risk of primary cardiovascular outcome by 13% versus placebo. So cardiovascular benefits in all, if you see, the best benefit that came out was hospitalization for heart failure. So the most important was hospitalization for heart failure. Otherwise, Finerenone and placebo, they were almost there. There was some inclination towards the Finerenone group in the forest curve also when you come about primary outcome or you talk about cardiovascular death. So Figaro study, secondary or renal outcomes, again showed that the time to first event, Finerenone reduced by 9.5%, and kidney failure sustained more than 57% decrease in 2.9%. So safety and vital things were, Finerenone had a modest effect on blood pressure, not a very potent blood pressure medication. HbA1c levels and body weight were similar in both the groups. There were no difference in acute kidney injury between groups. Sexual side effects like gynecomastia were rare and balanced between the groups. Finerenone was well tolerated. The overall incidence of treatment emergent adverse effects and serious adverse effects were similar. Finerenone led to mean increase in potassium by around 0.2 millimole. So not a very significant increase versus placebo. Although hyperkalemia was increased, by temporarily withholding Finerenone, it was manageable. So Fidelity is a big trial which composed both Figaro and Fidelio. I'll not into the details of that, but it again looked at the cardiovascular points and time to kidney failure. And Fidelity showed that hyperkalemia side effects were few in Finerenone group as compared to a placebo. There were no deaths related to hyperkalemia, and robust potassium maintaining strategy definitely worked in these patients. Even if SGLT2 was used, it had no impact in patients who were using Finerenone. So in Fidelity, it showed the Finerenone improved albumin creatinine ratio in patients who had CKD and type 2 diabetes irrespective of baseline SGLT2 use of inhibitor use.
Vishal, please wind up.
Yes, sir. So, Phenonon is contraindicated in patients who are receiving concomitant therapies like ketoconazole, itraconazole, or with Addison's disease. Fidelio and Figaro have both shown we need to keep the target of potassium less than 4.8. If it goes above 5 or 5.5, we need to withdraw the drug and restart it again in increasing doses. So, at a pre-spite of time, if you take the 5 key takeaways were, initiate treatment when potassium is less than 5, withhold treatment when potassium is more than 5.5, initiate treatment when GFR is more than 25. Phenonon reduces the risk of ESKD by 1 by 5, the 20%, and hospitalization for heart failure by 20%. These are other trials that are coming up for Phenonon, which are non-dialysis patients, Credence, Fiona. So the prevention of cardiovascular risk are 3 factors: RAS blockade, SGLT2 inhibitors, and non-steroidal mineral receptor agonist. These are the clinical recommendations. If you see, most of them are grade 1 recommendations, 1A and 2A. And European Society of Heartline, European Best Practice Guidelines, European Society of Cardiology, they've all given 1A recommendation to Phenonon. Thank you very much.
Thank you, Dr. Vishal, for an excellent lecture on this. But what I want to stress is that this effect is a class effect of these drugs. And if you remember, most of us have always been trying to stress on people that we have underutilized aldosterone antagonists all our lives. Because of a very strong fear of hyperkalemia, though I think there are people who've been using aldosterone, and we've used aldosterone to a very large extent, mainly in where we utilize as a diuretic in patients of nephrotic syndrome, and there we also found that it's good. All the good renal effects are practically the same with aldosterone, eplerenone, and finerenone, except the fact that finerenone is awfully expensive. So that is there. But yes, I think with the fact that the molecule is heavy and its half-life is less, maybe we have an advantage in hyperkalemia. But then most of the trials of finerenone has been versus placebo. One would love to see a head-to-head trial with the eplerenone or with aldosterone and see, do we really gain so much to spend that much cost, or can we go down to the basic molecule and have the same effect?
I could be said, because I think more studies are needed, more time is needed. They are just trials of 3.5 years, 4 years duration. So I agree by what you said, that we need more trials, especially not versus placebo, but other drugs also.
No, head-to-head trial is not going to come, because we have data for both these drugs, eplerenone and spironolactone. From 1999 to 2005, they were extensively used, and patients developed hyperkalemia because CKD, heart failure, they were used, and patients landed in ICU for hyperkalemia. That is why they were taken off. We have historical evidence of many trials from that era. And finerenone is a great drug. It is a drug which we must give. It is the third pillar that has been added for CKD management in diabetics for the moment. And I also found in one of my patients, progressive diabetic retinopathy was totally recovered. Glycemia remained same. And then I went to the literature and I found that in Fidelio and Figaro trial, they did a sub-analysis for their eye patients. The visual worsening was less, and the progression to progressive, proliferative diabetic retinopathy was also less. So it's a great drug. It's different from spironolactone and eplerenone, and I think it has a great future. And hyperkalemia is a major problem in CKD with heart failure, and that is where it scores. That is why you don't do a potassium check for next 4 weeks. You check it after 4 weeks, starting the drug, and check it after 4 weeks. It has a short half-life, so even if a patient develops hyperkalemia, you stop it, and it reverses very fast.
So you started with the premise that there's a residual risk. Has it been able to address that residual risk? It still remains, if you see that.
It still remains.
So this will remain ultimately.
Yeah, because we will need more data, more robust studies, head-to-head trials. But as I said, we were looking at hemodynamics. We have all been doing hemodynamics and metabolic factors. The problem, one especially in diabetic CKD, is they also have type 4 RTA. So that predisposes them to have a hyperkalemia. So by virtue, we keep on blaming the patient, आपने कुछ खाया होगा, कुछ चटनी पापड़ अचार खाया होगा, but they say हमने कुछ भी नहीं खाया. Most of them they say it. But type 4 RTA is still a problem, and it predisposes them to hyperkalemia, and on top of that there is a drug which can cause hyperkalemia. So when you talk of aldosterone and eplerenone, they're by molecule size and by their mode of action, they have a more predisposition towards hyperkalemia as compared to, as you rightly said, sir, you withdraw it and the hyperkalemia goes away, and then you can reintroduce this drug. So the beauty of this drug is that you can reintroduce it once you attain a potassium level of less than 5, and then you can monitor the potassium levels. Of course, that fear of hyperkalemia, and I think as a nephrologist, I always say two things scare me. One is fluid overload, the other is hyperkalemia. But that is the one where I jump and I start doing things. So if that fear goes away, I think that would be, this drug would become a panacea. But as of now, yes, more studies, more time. Maybe when next conference happens, we'll be having some more robust data. But there are other studies going on in non-diabetic patients, credence, in pediatric nephrology patients. So other data is also.
So while these drugs will keep on coming and we'll have more and more robust these conferences, but no one stops this patient from doing a good physical activity, a lifestyle management which is free and which will not add to our conferences as well. Thank you very much. It was really a pleasure listening to you and sharing the slides with each one of us.
Thank you very much.
Hand over to
Thank you, sir.
Thank you, chairpersons and speaker. I would request our chairperson speaker to move for the felicitation. I request Dr. N.K. Govil sir to please felicitate our speaker and chairpersons. So let's move to our next, last but not the least, very interesting session of CPC. For that, I would like to call upon stage our moderators, Dr. N.P. Singh sir, Dr. Ritika Sood, Dr. P. Lalita Jyotsna.
Dr. N.P. Singh is there, so actually we can wait for a while.
I request our chairperson to kindly introduce the speaker.
Thank you. And I think one of the most interesting aspects for a physician is when he's confronted with a patient where he's not able to make a diagnosis. So that is our first challenge. That is to try to give a diagnosis to our patient, and then comes the roles of these phenobarbital and other drugs which one can use. So many a times, it's very intriguing. The chapters are very clear when we read the books. This is diabetes, this is hypertension. But when the patient comes to us, he has different chapters in one patient. So we have to take out that challenge as to which chapter is he belonging to, and to solve that mystery, we need astute physicians like Dr. Sinha. I am very lucky to have been taught by him. I learned a lot from him when we were together in MAMC, and he's taken over my step very, very gracefully. I used to come and do the CPCs here. Now he's taken that challenge, and welcome Dr. Sinha. And he's not an unknown person to this forum. He's a very prominent personality of East Delhi Physician Forum and professor of RML Hospital, now which is known as AB Akhil Bhartiya.
The Atal Bihari Vajpayee Institute.
Atal Bihari Vajpayee, yeah. So over to you, Nitin. And as the protocol is that he'll be talking about the clinical discussion, and subsequently, we'll throw it open to you with the help of my colleagues and chairpersons, and then finally there will be the pathological discussion. Who's going to discuss? You will? Achha, you will discuss the person. Welcome.
Thank you, sir, and thank you to Dr. Anupam sir, Dr. Ritika ma'am. Actually, Dr. Anupam sir asked me, will you like to do the discussion of the CPC this time? I agreed. Sir has been a teacher, and it is actually an honor to present a CPC in front of Dr. N.P. Singh sir. My first CPC was with sir when I was a PG. Sir gave me a case of refractory iron deficiency anemia, I still remember. So with this, I start the CPC. Firstly, the patient details. The patient is a gentleman, 58 years old. With the he had 3 presenting complaints chiefly. One was the left shoulder pain, which was there for past 1 year. low back pain which was for 6 to 8 months, and swelling of left shoulder which was for 4 months. In the history of present illness, patient was apparently well when he experienced trauma. The nature of trauma is not known, following which the patient started experiencing pain in the left shoulder. The pain was probably sudden in onset. The exact site of pain is not mentioned, though it is written shoulder. So shoulder can be a diffuse area, but the exact pinpoint site of the pain is not mentioned. Any loss of sensation or anything is not mentioned. Intensity, character, radiation to arm is also not mentioned. He had a low back pain for 6 to 8 months, sharp shooting in character, radiating to bilateral lower limbs. It was also associated with change in his gait. But regarding any diurnal variation or any effect of prolonged rest on the pain or any other thing is not available in the history. The left shoulder swelling is there for 4 months, which is progressive, insidious in onset, and is associated with pain. But other relevant history like tenderness, redness, or any restriction of motion of the shoulder joint or any other history is not available. So we have 3 chief complaints. One is the pain in the left shoulder, which is there for 1 year following a trauma. There is a swelling in the left shoulder which is for 4 months, and there is a low back ache which is for 6 to 8 months, which is sharp radiating to the lower limbs, and there is some difficulty in the gait. So with this, the other history which has been given is that the patient has a history of weight loss which is about 6 to 7 kilogram in the last 1 year. Regarding the other histories, there is no history of any fever, night sweats, loss of appetite, any lump or body swelling, or any history of bleeding manifestation, any abdominal swelling, mass, any history of headache, seizures, loss of consciousness, and there is no history of any chemotherapy or radiation therapy in the past. However, history of cough, breathlessness, chest pain, and as which I have mentioned in the italics in the last, are not mentioned in the CPC given to me. There is a past history of tubercular lymphadenopathy for which the patient was treated 9 years ago. But no mention of diabetes, hypertension, even the ATT duration, whether it was completed, the patient resolved completely is not mentioned. There is the personal history is not mentioned in the CPC, whether he was a smoker or an alcoholic. Family history is mentioned as not significant. Treatment history, patient has been on empirical ATT for past 2 weeks for suspected pot spine. So probably at the time of presentation, patient had already been on some treatment and somebody had started him on treatment for ATT for some pot spine. Now, the examination of the patient which has been given in the CPC is that the temperature is 98 degree Fahrenheit, BP is 108/68, pulse is 92, saturation is 98% on room air. There is the general physical examination is essentially normal. The shoulder swelling, which the presenting complaint was, has been mentioned as it was a swelling over the shoulder with diffuse margins. Overlying skin was normal, and there was only mild tenderness. But actually, if the picture of any swelling has not been provided, if it would have been there, probably we would have been more wiser in our differential diagnosis. And also regarding the spine examination, since one of the complaint was the low back ache of this patient, which was for 6 to 8 months, the straight leg lazing test was positive, and the gait or Trendelenburg gait has been mentioned as being positive. However, there is no mention whether this test was positive on both the sides, right and left, or whether it was on just one side. Trendelenburg, it was whether it was the Trendelenburg gait, whether the fall of the pelvis was on the right side or the left side. That has not been mentioned. Other features of spinal examination have also not been mentioned. This is just a picture of the straight leg raising test. Just to recapitulate for the postgraduates, which I always do in a CPC, just straight leg raising test is that you have to raise the lower limb, keeping the knee straight, the limb goes up, and then there is a radiating pain. It should not be just low back pain. The catch is that it has to be a radiating pain, and once the foot is dorsiflex, the pain has to increase and there has to be a catch. So this is what is the straight leg raising test. Trendelenburg gait, which is there, which has been mentioned as positive. So just a brief word about what is Trendelenburg gait is that the Trendelenburg gait, as you can see in the picture, that pointer hai koi? Is there a pointer? Pointer hai? So at least the thing is that if you see that the gluteus medius is given on the right side and the left pelvis. So as the patient is lifting the left leg, the gluteus medius on the right side has to support the pelvis. Now if the gluteus medius is weakened or if the gluteus medius is weak, then probably the pelvis will tilt and the patient will have a tendency to fall. And for that, the patient compensates by tilting himself to the side of the lesion. That is, if the gluteus is weak on the right side, the patient, in order to prevent the fall, will tilt on the right side. So that is what is the Trendelenburg gait. The systemic examination has been mentioned as normal, that is respiratory, CVS, paradoman, and there is no CNS, there is no focal neurological deficit. So that means that the power, bulk, tone, reflexes, everything is normal. There is no clonus. So this is what I gathered, that even though the patient had low back pain, had a positive Trendelenburg, there was a radiating pain, but the entire neurological examination was essentially normal. So what are the differentials based on history and examination? So this is just that so that we can recapitulate on what we have done is that what we have available history in the CPC is that it can be a malignancy, 1 year history of pain in left shoulder, there is swelling in the left shoulder, there is pain in the lower back, which is there, which is radiating, which is leading to positive Trendelenburg. There is weight loss of around 6 to 7 kilograms, though there is no other history which is available. Or it could be a METS, whether it is in the shoulder or whether it is in the lower back, that we will have to gather with the help of some investigations. So that is just one of my first diagnosis. Second is patient had a history of tuberculosis. Probably this is all tuberculosis. He was already on empirical ATT for 2 weeks. Though it was empirical, probably we would like to confirm the diagnosis, and maybe whatever the reason was for starting empirical. Sir, abhi mujhe kuch bhi available nahi hai, sir. There was nothing which was available. So in CPC, whatever has been mentioned to me in the paper given, there is no image. So we will show you the image later, which I had, but ये जो ATT जिस basis पे start हुआ वो image मेरे पास नहीं है. This में. Okay. Third is probably there is a degenerative disc disease or spine disease, but then weight loss cannot be explained. So these are just 3 broad differentials which I had kept based on the history and examination that was available to me. Coming to the investigations. Now the investigations are that, the investigations need a mention. The HB is 10, now there are 2 investigations. One is of 13th October and one is of 29th November. Now it is not mentioned whether the patient received some treatment from 13th October to 29th November or what was the nature of treatment he was going on for last 1.5 months according to these investigations, that is not mentioned. So what I will do is I will try to analyze it that the patient has mild anemia which is still persisting in 1.5 months. Kindly look at the monocyte count. The monocyte count is 14% in the October report and the November report. So the monocyte is persistent. For postgraduates, any count which is more than 10% for 3 months is considered to be persistent monocytosis. Now I would like to believe that probably it is persisting, though it is just 1.5 months of his, the reports have a duration of interval of only 1.5 months. Then next is the patient has a normal platelet count. Look at the urea creatinine. The urea creatinine initially was 82 and 3, but now it has 58 and 1.3. Now the reason for this decline in KFT could be that he has received some treatment, he has been on some hydration. Unit for beta-2 microglobulin. To convert this into an SI unit, I have to multiply it by 10, which makes it 855. And in SI units, 607 to 2454 is the normal value for beta-2 microglobulin. So accordingly, this is a normal value. Now coming to the HIV antibodies, non-reactive, HBsAg anti-HCV is non-reactive, ESR is 65, it is on the higher side. Serum protein electrophoresis has been mentioned that it has decreased albumin but no M spike. So there is no rise of particular or there is no increase in M spike. Urine protein electrophoresis has been, though it is written electrophoresis, it is written negative for Benz-Jones. So serum ferritin is 315, which is normal. Serum PSA has been mentioned, it is normal. So these are the hematobiological investigation which are available to us in the CPC. Now, going to the next step. Now, what do the investigations tell us? Now, let us ponder over it. We had 3 differential diagnoses, and do these investigations lead us to somewhere, or we need more investigations? Patient has anemia, as mentioned, monocytosis, raised ESR, CRP, increased creatinine, hypercalcemia, low phosphate, high LDH, high SGOT, beta-2 microglobulin is normal. So, what are the other investigations that have been given in the CPC to me is that peripheral smear is normal, there are no atypical cells. So, shoulder aspirate analysis has been done. So, there was a shoulder swelling, probably some aspirate has been done from that. It has shown no pus cells and no malignant cells. So, neither it is infective nor it is malignant. So, what is it that we will probably lead to next investigations? Ultrasound KUB has been done, which means increased cortical echogenicity of just left kidney. Though size and all has not been mentioned. I don't even know whether the 2 kidneys are equal in size or unequal in size, and why only 1 kidney has raised echogenicity. Probably it was an old thing that is not mentioned, anything. NCCT abdomen has been done, which is showing cholelithiasis with dependent sludge in gallbladder, multiple lytic and sclerotic areas in L4 vertebra, query pot spine. Probably, I think based on this only the ATT was started. This is what my assumption is. Rest the moderators will tell once the cards are open. They further went ahead with the MRI. The MRIs of 2 areas have been done. One is of the left shoulder, which just show altered signal within the terminal segment of the tendon of the supraspinatus muscle with minimal fluid suggestive of partial tear. And there is a fluid along the tendon of subscapularis also. MRI LS spine has been done. I will just read it out because our further differentials or the final differential which I will present will be based on whatever investigation and this MRI report is. MRI LS spine is showing a large lobulated enhancing soft tissue mass lesion with central necrosis involving S1, S2 vertebra, more on the right side and right iliac bone, and well-defined enhancing lesion involving L4, L5 vertebra, more on the left side, suggestive of a neoplastic etiology, query metastasis. Now, diffuse disc bulge is also there in L4, L5, which is leading to thecal compression, and bilateral traversing L5 nerve root is also affected. However, I would like to mention here is that the Trendelenburg gate, which was positive, and if we talk about gluteus minimus and medius, which actually are the muscle involved, they have been supplied by S1, S2. They are not supplied by L5. They were superior gluteal nerve is the nerve which supplies them. Bilkul sir, definitely. So this is what has been given. Now I will be discussing the differential diagnosis now. What I have in mind based on all these. So shall I go ahead, sir? Actually, these are the MRI films which are available. Now, for me as a person, these were all sent to me on WhatsApp. Now, I am not able to, because whatever the thing is, if this would have been a magnified image or something, it would have been much better. But somehow the pointer, and if I can show you, this is what I could make. I have not, these are the L4, L5, S1 vertebra. There is some destruction of the pedicles posteriorly. Then there is some mass in the paravertebral, just near the vertebral, in the paraspinal area. In this particular image, this pointer is not working. कोई रेड वाला है पॉइंटर, क्योंकि तो वाइट है, इसमें तो दिखेगा ही नहीं. हाँ, ट्रैक पैड से करते हैं सर, बट वही है कि वो भी नहीं आ रहा. Yeah. हाँ, ये कर देते हैं सर. So look at this area. These are the images. Look at these. These are the vertebra. Look at the posterior parts of the vertebra. And look at this. Now these are the paravertebral collections which are there. Now all these images are like this. So these have been what have been given to me. So most of the things are the same. There are certain altered intensities in the kidney and all, but I think probably that was more of the flash which has when the image has been taken. This is probably I could make out. So coming to the differential diagnosis, now we have a history, we have some differential, now we have some examination findings and some investigation findings. Can we fit them all into one diagnosis, or there is only one, or there can be more than one diagnosis in this patient? Let me try and dissect it out. Is it a paraspinal soft tissue swelling? Now, firstly, what is the paraspinal area? Any area which is around the spine, which consists of fat, which consists of muscles, which consists of ligaments, which consists of blood vessels. Can it be a swelling of that area? Because there is no cord compression. It is only written that there is a disc pulp which has led to thecal sac indentation, and there is L5 nerve root which is exiting, which has been compressed. But this mass lesion has not shown to be compressing any cord. Moreover, the neurological examination down is absolutely normal. There is no upper motor neuron lesion, there is no lower motor neuron lesion, nothing at all. So probably can it be, and there are certain histories which are favoring. One is the history of weight loss, imaging suggestive of a neoplastic soft tissue swelling, vertebral bodies, increase SGOT, LDH, monocytes, all can be because of the neoplasm, and then there can be a paraneoplastic syndrome leading to increased calcium and low phosphorus. So all of them can be grouped into this, which this patient had. However, the shoulder still remains, a little bit suspicious to me, even though the MRI has been done. So then what is this MRI? So what I could make out is that this patient has a trauma 1 year back. Probably I don't know what treatment this patient was on, whether he continued to use his shoulder or not. There is a swelling, then there is supraspinatus tendon which is involved. So probably it is tendonitis which is there, or there is a partial rupture. So both these things are there. Probably it is just post-traumatic. There is no obvious swelling, and moreover an aspirate has already been done, which is showing no pus cells and no malignant cells. So probably for me it is more of a paraspinal mass lesion, and probably most of the findings can be explained with it. This is my first one of the differential diagnosis. Now let me move to the second one. There's some bit more I would like to tell you about paraspinal tumors. That the World Health Organization has classified the primary tumors of spine as osteogenic, chondrogenic, vascular. This I have already told you. They can be single and multiple lesions, and osteoid, osteoma, osteosarcoma, and osteoblastoma can produce lytic lesions and sclerosis around the area. So this is also there in our patient. This is just one of the tables which I could highlight from one of the oncology journals, is that it tells you about what all tumors can present as primary spinal tumors and in which age they can present. So if you can see that lymphoma and you can see lymphoma, vertebral body involvement, paraspinal involvement is seen in 5th to 7th decade. Our patient is 58 years old. So these are the most commonly seen. It's not that one tumor cannot present at any age. So some are more of childhood, some are more of early adulthood. But look at lymphoma, look at the chondromas. Then there are tumors like giant cell tumors. Then there is lymphangioma, hemangioendotheliomas. They can all present at even the advanced ages. Even osteosarcoma can present at the age of 60, 67. So there are many tumors which can present at this age, though many, like the earlier one, the osteoid, osteoma and all, they present at an earlier age. So usually they are not seen in the elderly patient. Our patient was 58. Then is there any differential for lytic lesions with surrounding sclerosis? In the CT abdomen, it was written that there is sclerotic areas as well as lytic areas. So there is a mnemonic for it. It is called as BOOST, which is Brody's abscess, osteoid, osteoma, osteoblastoma, osteosarcoma, stress fracture, and tuberculosis. So these can be few further differentials for our patient. Though already I have discussed some of the tumors as one of the primary diagnoses which I will make. So tuberculosis is another possibility. We will discuss it later. Can this patient be having metastasis which has been reported in the MRI? MRI people have written it is metastasis. There are 2 lesions, and again if it is 2, so anybody is likely to think it is a metastasis. So it can still be a metastasis. So, and moreover in spine, most of the tumors which we get are metastatic tumors, 97% of them, and the primary tumors which I talked about earlier are just 4 to 5%. So metastasis is still a possibility. Adenocarcinomas which arise from the lung, the breast, the prostate, the kidney, gastrointestinal tract and thyroid can metastasize to spine, and they are known to produce such kind of pictures. But here our history is not guiding us to any particular system involvement. The history was not, the entire history was absolutely normal. None of the organ system was, I could find out to be affected. However, but when I searched the literature for it, I found that can prostate cancer still be there if PSA is normal? So this is one of 58-year-old male, though he has no urinary complaints. There has been history of TB lymphadenopathy in the past. PSA levels are normal, but can still the patient be having a prostatic cancer? Then there has been a case report. I will just show you the next. So it could be one of the possibilities, but again, it is very, very rare. So when we think of even common and the rarer possibilities. That is why I am trying to present here. Prostate cancer presenting with normal serum PSA level and bony mets. So there have been case reports for that. So we should still keep in mind that there could be a malignancy elsewhere which has led to mets in the spine. So this is the second probable diagnosis from my side. One is the primary spine tumor, second is secondary tumor from anywhere which is presented to it. And being a 58-year-old male, though probably no urinary complaint, it could still be a prostatic CA. So this is my second differential diagnosis, because based on whatever history examination has been given. Can it be multiple myeloma? Multiple myeloma, because the features which are supporting are age, chronic low backache, history of weight loss, anemia, increased ESR, deranged KFT, hypercalcemia, osteolytic lesion. जो चाहिए सब है. फिर क्या नहीं है वो है no AG reversal, AG ratio was normal, serum protein electrophoresis was normal, urine negative for Benz Jones proteins. These are negative, but can still it be multiple myeloma? Let us find out. If we go with this, okay, so it can still be a multiple myeloma because there is an entity called as non-secretory multiple myeloma, in which we can get the myeloid related symptoms, but the bone marrow has plasma clonal cells. Bone marrow has not been, I have not been provided with the bone marrow. Bone marrow has plasma clonal cells, but there is no M spike. So there is an entity called as, that is what I have tried to, actually I had this picture but somehow it is not being displayed. It is called as non-secretory multiple myeloma. So that could still be a possibility. 58 years is an age where multiple myeloma can occur. So we have three differentials till now. Coming to the lymphoma. Lymphoma, though in this case I would like to keep lymphoma as a little down the order, because only mild anemia is there, ESR is raised, LDH is raised, but we have other reasons, more stronger reasons for for us to believe that they are raised rather than being lymphoma. But again, lymphoma can present anywhere, anytime. Even the diffuse large B-cell lymphoma can occur at this age. I have a case report also next which can present like this. So lymphoma can still be a possibility. It can present as vertebral lesions. It can lead to no enlarged lymph node. Though in our case there is no enlarged lymph node, no hepatosplenomegaly. And moreover, all the cell lines probably are not reduced, only it's mild anemia. But monocytosis is there. So lymphoma can still be a distant possibility. This is the case report I was talking about. My final or the fifth one would be a tuberculosis. Probably the shoulder thing is also tubercular. Maybe there is a fluid there. It might be tubercular environment, though it could be post-traumatic. And with 2 lesions there, he is already on 2 weeks empirical therapy, which probably will not relieve him of his symptom because 2 weeks is just a short time. So tuberculosis is one of the possibilities. It can lead to lytic lesions on the bone also. It can lead to anemia. It can lead to hypercalcemia also. So these all lesions can be seen in tuberculosis. So I have told you about 5 differential diagnoses. I will still like to keep the paraspinal tumor or the primary tumor of the spine as the first, though other 4 I have listed. What would help further to clinch the diagnosis according to me? One is the workup for anemia, that is a different thing, but bone marrow is definitely going to help, especially if we are talking of non-secretory myelomas and other than bone marrow with clonal plasma cells will definitely going to help. Ultrasound of the whole abdomen. Here liver has not been mentioned anywhere. No chest x-ray has been mentioned anywhere. Sir, what they have mentioned in the MRI is that there is a fluid in the tendon of supraspinatus and subscapularis, suggestive of partial tear. No, sir, there is no. So probably it is just related to the post-trauma. That is what is the most probable thing I thought of.
Shoulder pain is the first presentation.
1 year. 1 year, but 4 months se swelling is shoulder mein. But
4 months. And the back pain was for 8 months.
Back pain is for 8 months.
Why do you want to get the iron studies done? The B12?
Sir, actually this is a workup of for anemia. It is not, that is what I told you. For me, bone marrow aspirate and biopsy will be the clinching thing. It would help me more. Routine. So ultrasound definitely for liver, because no mention of liver. If it is a mets in the liver or something, that has not been mentioned. Chest x-ray is not there. So I don't know what was there in the chest x-ray, has not been given. A CT guided biopsy from the lesion will definitely clinch the diagnosis, whatever the vertebral lesions are. And maybe a prostatic ultrasound, maybe a truss could help. And secondly, if we are suspecting of mets from anywhere and there is a lesion somewhere else, probably a PET scan would also help. So these are the further investigation which I think have been done by the moderators to reach the diagnosis. Now, it is...
Thank you. You will get a chance. So thank you, Nitin, for giving a case. So out of the 5, which is your first?
The primary spine tumor, that is my first.
Right. So I think let's give a big hand to Nitin for dissecting the case very well and trying to give you the differential diagnosis and also teaching us about SLR and other things which are important in CPC exercises. Now the next phase is your phase, where you can give if you agree with him, fine. If you do not agree with him, if you want to give some more diagnosis, you already got a history and examination and investigation. So if you want to give something else as your differential diagnosis, now it's your turn, Professor Makkar.
with a history of weight loss, with the investigation suggesting that the
diagnosis.
the serum creatinine is raised. My first pointer would be towards possibility of a multiple myeloma. However, as you said, those two things are absent, but still my differential would still go
So
towards
that is what
multiple
he gave,
myeloma.
one of the Professor Paras.
I think we have I would say that it's likely to be multiple myeloma or some form of lymphoma, which we need to evaluate further. And there can be forms of multiple myeloma, as Nitin has said. There are a few other varieties of multiple myeloma, which can be with normal bench Johns and absence of spike.
Pankaj would like to add.
Right. I think this is a very important exercise for postgraduates. So how that CPC should be performed? I think a lot of PGs are still there because they're waiting for the trophies, right? So they must be sitting for the trophies. So actually, Nitin has shown that how the CPC is performed. We are given in a case, doesn't know about major investigation, nothing about the biopsies and nothing about the pathology report. So how you case, and this has been taught by Dr. M.P. Singh sir. I think we have started this CPC culture in our EDPA, I think long back, 5-6 years. We are doing regular CPC. And how the CPC is actually being taken up, I think it's beautifully done by Dr. Nitin. And sir, you are a master of CPC, and we have done a lot of CPC with you. And so in a country like India, right, tuberculosis is always, the first diagnosis. But whatsoever, like lymphoma in our country is still there, but you can't put top of it, right? So the history of tuberculosis, patient on empirical ATT for last 2 weeks, patient had a history of, and it was not there at, it was what a day number of months or we hope, maybe we are dealing with some MDR tuberculosis and, sometimes. So in top of it, definitely tuberculosis should be on the chart. Yeah, secondly, definitely bone mets, definitely the picture that is seen, the bone mets, and thirdly, primary somewhere, right? This is my take on.
Right.
So multiple myeloma still remains a possibility. There are various variants of myeloma which may still present. Probably a soft tissue swelling may be a part of an extramedullary myeloma. Also, we've seen patients with extramedullary myeloma.
Something like plasmacytoma or something.
Plasmacytoma, extramedullary.
Anyone from the back would like to give a...
Sir, can I just add one thing?
Yeah.
Sir, I thought of plasmacytoma, but plasmacytoma by definition means that it has to be a solitary lesion.
Solitary.
And then secondly, the symptoms, other symptom, myeloma-related symptoms like anemia, ESR, then they are normal. So that is why I did not give plasmacytoma as one of the differential diagnoses, because this patient had kidney involvement, anemia, ESR high. Usually those are not seen in solitary plasmacytoma as per the definition.
Extramedullary myeloma?
Sir, extramedullary myeloma will not present like this.
Extramedullary
which side? Like
what about histiocytosis? Histiocytosis as one of the possibilities. Histiocytosis.
Okay. Sir, from behind, any resident wants to give a differential diagnosis or wants to add something? Okay. So by and large, I think the whole house agrees that probably multiple myeloma and primary tumors of the spine or something else. Just to share with you that last week, almost similar CPC was given to Professor Sinha in the different forum. It was exactly the same, and he had made similar diagnosis in that case, and that turned out to be lymphoma, extranodal. There's a variety of lymphoma which is known as extranodal lymphoma, where the primary is not from the lymph nodes, but from elsewhere, and that can present in a various way. And also, similar to that, leukemias can also sometimes present with a similar presentation, where you have chloromas, acute myelogenous leukemias can present with, and they can be aleukemic leukemias where you may not have it. But the final answer will come from our lady sitting next to. Role of beta 2. So role of beta 2 microglobulin is, it is essential. No, that he has said that the values are within the normal limits.
It is normal, sir.
Beta 2 microglobulin is to try and assess the cell turnover, especially in terms of multiple myeloma, where you have hypercalcemia, you have anemia. Out of crab, you have 2 are there. Bony lesions are also there. So it is just that, and many of these are generally a red herring to take you away from the final diagnosis, which is always there on our left side. So she is going to give us the final diagnosis.
Sir, just Paras sir, actually the beta 2 microglobulin I think must have been done when the team was thinking of multiple myeloma, Now with beta 2 microglobulin, if it is less than 4 nanogram per ml, then the prognosis is considered to be good in multiple myeloma. But if it is more than 4, the prognosis is considered to be bad. So it is basically a prognostic marker for multiple myeloma. That is the thing. So that is why I think and moreover it aids in diagnosis. Agar wo bada hua. So they have written microgram per deciliter, but normally it is written as ng per ml. So if it is microgram, just multiplied by 10, it becomes ng per ml.
So typically it is nanogram per deciliter, right?
It is not a diagnosis. That is what I was saying.
So would you like to add something?
So I'll quickly just I'm doing no, she'll give us the final diagnosis. But since we were working up the case, and I think the way everybody has been thinking, we were also all thinking on the same lines. So this patient was referred to us from the Department of Orthopedics, where the patient came with this pain in the left shoulder, which was the main concern, the reason why the patient came. And along with that pain in the left shoulder, the low backache was the reason why, because there were 2 lesions that the orthopedic surgeon was looking at. So, and again looking at the anemia, the azotemia, which was probably new in onset, and the lytic suspecting bony involvement. So the patient was referred to us at the hematology clinic to rule out a plasma cell disorder. And that is the reason why all these investigations were done. And so one by one, and the patient was unwilling for a bone marrow. So we were unable to do a bone marrow to get that prerequisite of plasma cells in the bone marrow. And then we came down to this MRI, which was finally done. And this is because the patient kept jumping between Department of Orthopedics to medicine. And somewhere along the way, we got that CT scan, where a pot sign was suspected. So the patient was put on ATT so that we would not lose out on time. And the patient had earlier received ATT, so that was one of the reasons why the patient was put on ATT. And then we did, the next thing that we did was the guided biopsy, which will be discussed by the pathologist. And we did the FDG PET. So when we did the FDG PET, we, Dr. Ritika ka naam se. So the shoulder aspirate, as he's discussed earlier, did not reveal anything. And a lot of stress was being laid on this lesion which was there on the shoulder. And so a plasmacytopenia, multiple myeloma, METs, everything was looked at. But it just seemed to be a chronic inflammatory tear in the shoulder. And this was the non-contrast CT scan which was done because of the altered kidney function. So which gave us the possibility that it could be a tubercular lesion. And then the MRI, which gave us this lobulated lesion along the S1, S2 and the L4, L5. So, and then when this was done, we started looking for a primary. That maybe we were missing a primary, but during the entire workup and repeated history, we just could not locate a primary. And then when we did the PET scan, so there was a hypermetabolic uptake which was there in like a hyperdense left psoas muscle. So this was the lesion that came up, which I've highlighted on the FDG PET. So this was the lesion that came up on the FDG PET, which was eventually biopsied. And so Dr. Jyotsna would... And along with this, there was also a lymph node in the cervical region. That too was biopsied but turned out to be reactive.
Basically, as has already been mentioned by ma'am, so the focus was, it looked like a tubercular lesion, what we were told about, a left shoulder mass, however, the aspirate came out to be necrotic. There was some necrosis, but AFB was negative. From the lytic lesion that was there, we also have a biopsy from that. So though a bone marrow aspirate or a biopsy per se was not done, we have basically the vertebral biopsy, and from that it showed normal bone marrow, and it showed trilineage hematopoiesis, and there was no evidence of any increased plasma cells or multiple myeloma. So next our focus turned on to the paraspinal mass, again based on what the clinical picture and the radiological picture was telling us. So again, it was in terms of tuberculosis. But since it was a mass, again the aspirate which was there, it was showing some amount of necrosis and inflammatory infiltrate and some connective tissue, spindle cells. So again, we were at a loss as to what to do. And so a true cut biopsy was done from the mass. And this is the core that you can see, the cores that we had. And here you can see two colors, prominent colors. So this is an HE section. So you can see pink and blue, okay? So here you can see the hypocellular pink, and here the blue. Again, blue and pink alternating. So something happening here, we have to focus on this. So this is the histopathological section, and this is on the 10x field. So what do we see here? There are some blood vessels and a lot of these cells, small round blue cells we would say if it was a child, but here it appears as if it's full of lymphocytes. So again, we were thinking in terms of tuberculosis initially, so we thought that this could be some benign lymphoid hyperplasia. But so basically we have a monotonous population of blue cells. So this was a diffuse infiltration of the soft tissue. On a higher power, we can see that this, I have highlighted a lymphocyte for you. And the large cells that you can see, they are almost 2 to 3 times the size of this small mature lymphocyte. Okay, so these are not normal lymphoid population. This is something else. So these are large cells, 2 to 3 times the size of small mature lymphocytes with high NC ratio, coarse chromatin, and you can see 0 to 1 nucleoli. Central nucleoli in many cells were seen. So based on this, we kept differentials. Of course, benign lymphoid hyperplasia was almost out because the cell's size was quite large, okay? So some malignant process is taking place. So since this is a diffuse infiltrate of single cells, so lymphoma comes on the top based on morphology. However, the location is quite rare for that. So we kept also a differential, just like it was kept clinically also, a metastatic carcinoma. Poorly differentiated carcinoma, whether it is squamous cell carcinoma or an adenocarcinoma, can also show this picture of diffuse infiltration of single cells, single large cells. So metastatic carcinoma was definitely one of the differentials on the morphology. And of course, the soft tissue tumors, based on the location again, and the fact that undifferentiated sarcomas, okay, single line cells can also be seen, large cells can also be seen. So the next step after histopathology for us is to do the immunohistochemistry. So on immunohistochemistry, first to rule out the carcinomatous process, we did a pan-CK. So the pan-CK, it turned out negative. We also did an EMA, epithelial membrane antigen. So pan-CK is pan-cytokeratin. Both of these epithelial markers were negative, so effectively ruling out carcinoma. We had also done a CD138 just in case these cells are lymphoplasmacytoid or plasmacytoid, because plasmacytoma had also to be ruled out, but CD138 also came out similarly negative. Now, the next antibody that we put up was Vimentin. So Vimentin is for the soft tissues, and Vimentin also came out negative. Since on the aspirate we saw some spindle cells, we had to rule out also neural tumors, though it is rare in this age group at this site. So we also did chromogranin. Neural markers also came out negative. So we ruled out carcinoma, plasmacytoma or a multiple myeloma, and sarcoma was also ruled out based on immunohistochemistry. Next up, we did this marker, and you can see the beautiful brown cytoplasmic, accentuation. So it's effectively lighting up, okay? So as I hope you can all see the brown that is there. So in the center is the nucleus, and the brown is the cytoplasmic positivity. And to our surprise, this was LCA. So LCA is, as we all know, is leukocyte common antigen. So a lymphoma again came back in. It was ruled in. So what is the next step? What could it be? We did an MPO, which is a myeloperoxidase, and it came out negative.
What is this last slide stain?
This is LCA, leukocyte common antigen, which will be positive in all leukocytes. For myeloid, basically to rule out myeloid leukemia and lymphoma, both. So myeloid and lymphoid, both populations will come positive for CD45. However, this was negative for MPO, that is myeloperoxidase, so myeloid was ruled out. So now lymphoma is ruled in again. So for lineage assignment, the next step is lineage assignment. So lineage assignment, as we all know, we do by basic panel is CD20 and CD3. So we did a CD20, and again you can see it is diffuse positive. So this is also ruling out a benign lymphoid proliferation. Why? Because in a benign lymphoid proliferation, you will have a mix of CD3 and CD20, not such a diffuse positivity. So this is CD20, and it came out diffuse positive. Now what about CD3? Because we also have to simultaneously in the basic panel, we have to do a CD20, CD3. So you can see some cells, they are coming out positive. The brown positives that you can see are the CD3 positive cells. So what does this mean? Still I'm saying it's CD3 negative. Why? Because majority of the large cells that you see, those are negative for CD3. In fact, it is the small mature lymphocytes which are positive for CD3. This means these are the normal T cell population which are scattered in the lesion and showing positivity for CD3. So what we have seen till now is it is LCA positive, and lineage assignment, this lesion is CD20 diffuse positive, right? So after the lineage assignment, panel for the lymphoma, next panel that we did was BCL. This is not a very clear slide, but what you can see again, cytoplasmic positivity for this marker, which is BCL2. BCL2, as we all know, is an anti-apoptotic marker. So this came out positive in this lesion. And finally, we have Ki67, 90%. Absolute clincher that this is nothing but a lymphoma, and that too a B-cell lymphoma. Okay, so let me talk about Ki67. As we all know, in benign lymphoid proliferations, in mature cells, lymphoid cells, Ki67 or the proliferation index will never be this high. Okay, and in case of lymphomas, also you can have low Ki67 lymphomas and lymphomas with high proliferation index. So this was one with a very high proliferation index. So Ki67, this is a nuclear marker, and the nuclei are beautifully stained with this, and calculating the percentage of cells which are showing positive, it was 90% positive. Other markers that we did, CD10 came out negative, and BCL6 also came out negative. As we all know, in lymphoma, B-cell lymphoma, especially DLBCL, in the Hans algorithm, we have to do the CD10 and BCL6, BCL2, and MUM1. for basically assigning them as GCB type or the non-GCB type. Okay, so let me come to the summary of immunohistochemical markers, and finally we will come to the diagnosis. So positive markers, LCA, CD20, BCL2, and high Ki67 index of 90%, while CD3 was negative and CD10, BCL6, these were negative. So this tells us that this is a B lymphoid proliferation. So T cells were ruled out, so T cell lymphoma was ruled out. BCL2, the role of BCL2 is that overexpression of BCL2, as is seen in our case, it's an anti-apoptotic marker, and BCL2 positivity or overexpression gives a survival advantage to the malignant B cells. And as for Ki67, it's a proliferation marker indicating the growth fraction of the lymphoma cells, and a high Ki67 is associated with a worse overall survival for NHL. So coming to the final diagnosis, as is clear now, it was a case of B-cell lymphoma, extranodal, and with high Ki67. So a very rare site for that, and we went all over investigating the shoulder mass, the vertebralytic lesions, and then the paraspinal mass, coming to thinking of TB, thinking of multiple myeloma, and finally this was the diagnosis based on the morphology and the immunohistochemical markers. So that's all I would like to say.
Thank you. And so that shows that it's always a challenge to see such cases, and final diagnosis always comes out from the pathologist, though it takes us to a different path clinically. सभी अब कह रहे हैं सबका ठीक था, मैं भी कह रहा हूँ मेरा ठीक है सभी. So anyway, I think what is most important of CPC is to cut out a differential diagnosis, have some learning exercises, teach certain things. So it is generally when you have a very rare presentation of a common disease or a very rare presentation, a rare disease with a common presentation. And extranodal lymphomas are known to cause such CPCs. They occur much more frequently in CPC than thing. I had an extranodal lymphoma of tongue which was given to. So thank you very much, both the clinical discussants as well as.
One of the other key highlights is that we are nothing without the pathologist's help.
Yes, yes, yes. So it is always better to have pathologists on your side than on the side. Thank you very much.
Thank you for the diagnosis.
Yeah. And on behalf of my co-chairperson, we thank the organizers for completing the wonderful conference well on time and with all the ingredients in it. Right? Thank you. Thank you all very much.
Thank you, moderators and speaker. I request Dr. Aman Rohtgi to please felicitate the speaker and moderator.
Now we'll be announcing the results of the postgraduate quiz and paper and poster presentation. I request Dr. Subbalakshmi to come, kindly come over and announce the results.
Quiz team, please come forward. Quiz team, second and third. RML team, RML and team gyms. Please come forward. Sir, NP Singh, sir, may I request you, sir, here. Sir, may I please request you to felicitate our quiz winners? Yes, sir, please. So, Team RML secured 3rd position in quiz, postgraduate quiz, which was held in the morning. It was very interesting. So, Dr. Sunil, Dr. Bidisha, and Dr. Vipul to please come on the stage. Achha, 2 of them are here at present. So, this is Team RML, secured 3rd position. Team Gyms secured 2nd position in PG quiz. Dr. Bhavna, Dr. Rajan, and Dr. Sakthi. These were the team members in. Yes, please come. And team Dr. Srinivas, Dr. Abhishek, and Dr. Neeraj, they were team member of quiz team who secured 1st position, and they have already been felicitated in the inaugural session.
The postgraduates who won the prizes, please, we have your certificates also here. Please do not leave the hall. Kindly come and collect it from here, please.
Now result for paper presentation, which held during the lunch time, 2 to 3. So, 1st position goes to Dr. Jai Patel. Please come forward. Dr. Srinivas, Dr. Suhail, and Dr. Vikas. Please come forward quickly. जीतने के बाद तो जल्दी आना चाहिए ऊपर. They are taking. Yes, sir. Sir, paper, sir. Paper. First. Yes, sir. First. There is slight confusion in the certificate, so we will be providing certificate later on if you are not getting at present. Dr. Srinivas, 2nd. Dr. Suhail and Dr. Vikas secured 3rd because their marks were same. So, please. Dr. Suhail and Dr. Vikas. You are doctor? Please come. So, Dr. Suhail and Vikas has combinedly secured 3rd position. Their marks were same. Dr. Vikas. Thank you, sir. Whosoever have not got the certificate, please give your name in writing. Poster. Now for poster presentation. Dr. Govil, sir, may I please request you to felicitate our poster presentation winners? Dr. Govil, sir. For poster presentation, Dr. Jatin, Dr. Jatin, Dr. Saurabh, Dr. Caroline. Any one of you are here? Okay, okay, come fast. This is first prize, sir. These are 3 are first prize. 3 are first, yeah. We have 3 sessions for posters. So these are the participants who have secured first prize. So please come forward, please come. Dr. Saurabh and Dr. Caroline, right? Yes, please come. Dr. Jatin, are you here? Okay. For second prize, in the 3 sessions, Dr. Mukul, Dr. Bhavna, Dr. Karanjit. Any one of you are here? Dr. Mukul, Dr. Bhavna, Dr. Karanjit. Dr. Bhavna, please. Second prize. Third prize, Dr. Laksh, Dr. Dhruv, Dr. Harshita. Sir, here again a tie is there. Dr. Yash is also there in this thing. So 4 are there in secured third prize in poster presentation. We will giving them certificates later on because there was some this thing. So Dr. Laksh, Dr. Dhruv and Dr. Harshita and Yash. Any one of you are here? कोई और ले लो उनके behalf पे. If any one of you are here, no one is there. Dr. Harshita, Dr. Yash, Dr. Dhruv, Dr. Laksh. Anyone can take on their behalf? Nobody is ready to take. You can take, na? नहीं है कहाँ वो? अच्छा, okay. So, yes. So these were the winner for poster and paper and quiz presentations. So congratulations to all the winners and congratulations to all who have participated also. Vote of thanks. As we bring this enlightening conference to a close, on the behalf of Organizing Committee EDPA 2023, I extend my heartfelt gratitude to each of you for contributing to the success of this event. I would also like to extend my heartfelt thanks to all the past presidents and senior members of EDPA for the constant guidance, to the esteemed faculty who have enriched our conference with their knowledge, to the delegates without whose presence no conference will be successful. Your insights, discussions and shared knowledge have truly made this a memorable experience. I would also like to thank Shambhu, the audiovisual team and the hotel team. I would also like to thank the postgraduates for their enthusiastic participation and making the postgraduate program a success. Special thanks to Dr. Subbalakshmi for curating a successful PG program. Last but not the least, I would also like to thank all our sponsors, Eris Life Sciences, Sun Pharma, Novo Nordisk, Schiller, Vincent Micro, Zydus, Bayer, Torrent, Intas, Biocon, Mankind, Dr. Reddy's, Lupin. Thank you all until we meet again. Thank you.